Yes.
You can go about the one that I missed a little bit. Information for us to make it easier.
Okay.
So you know how you said that physician have this packet
Oh.
and letting the past policy come to it, right? That is actually a very good. Because you don't have so many policies available. But now you use those available bias. You make a judgment on a new patient. One of the lines of the yet was, I've never seen this patient before. So my past available biases, if I use those, then it's this. I'm putting you into a box. Where am I using?
Oh.
Hello, everyone. Hello. Hey, this is Mabel. Hello.
Hi, Mabel.
Yeah, please. Who is that guy that always answer question in the class? What's his name?
Don't say my Don't target me.
Maybe we're on break, okay? Class starts in 3 minutes. Don't worry, you'll meet him one day, okay? He's a real nice young man.
Oh, really?
He signed a Scorpio. He's about, what are you, 4'9"?
700 pounds.
Real nice guy. So if you act real nice, he'll talk to you at the end of the program.
Oh, okay. No problem. I just need to talk to him.
Okay, no problem, Mabel. I will start class in a bit.
I don't mind, I would try it on. Does everything. They have a. Really. Unless you get. Every company. Yeah. Like I shot. It's a little scary. It's like, dude, I have. I've had. All are different. I don't have 10 minutes. I would say. Yeah. For some reason, they're saying. Well, like there's many those are what it's for.
Like PTSD, like, oh, what did I forget to do? You know, like that Harry Potter, like the ball or whatever that's around you to remember something? I need one of those, it's always around. Wait, what? Devil Wash Bottom. Horrible name, that kid's rough.
Now we have to.
Well,
Oh, yeah, here it is.
hospital.
Okay, I.
Oh.
Yeah.
Oh. 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 Oh, oh. Oh, oh, other side. Wrong way, yours. That's right, show something going green. One, give him. Oh, give him a little bit.
But, yeah.
Yeah, I agree with that, never happened. So, we'll just try and never left. Let go in one day.
Yeah.
No, porque esta hora creo que va a ser la hora más puede ser. It's a yeah.
Okay, I'm close with you.
Ask the high time and ask them how you need to breathe. Well, they speak out. There was like 20 minutes after that.
And I.
All the way. I mean, that was on Friday, right?
Half Friday, half. It's half Friday, half next.
Yeah, yeah, I mean, I'm sure is he on track with the, he's on track? The schedule is just a guide. It's just a guideline. Not necessarily need to be follow or happen all the time. All right, good morning. All right, let's do some renal physio today. So kidneys, right? We all know, we all talk about the most important organs in the body, right? Brain, heart, and then followed by kidney, right? So kidney is an important part of your body in the sense that it does a lot of important functions, right? So what's the main function of the kidney? Number one, filtration, right? Filtration, and then what happens after filtration? You reabsorb the things that you need and or excrete the things that you don't need, right? So it's reabsorption and then excretion, right? Along with secretion, which is part of that process too. However, for this process to happen, or in other words, toxic substances, right? Some of them are metabolized through the kidneys, and that's where it is excreted through. But for this to happen, what's the number one determining factor for the kidney to work adequately? Blood flow, exactly, right? How much of cardiac output does the kidney receive? About 20%, exactly, right? So the 20% of cardiac output that the kidney gets is very important because that 20% is what maintains GFR, right? Glomerular filtration rate. So if the 20% falls, GFR will fall. If you have more volume, GFR is better. That's why anytime you go to the hospital or emergency room for whatever purpose, what's the first thing that they do? Fluid, hook you up an IV fluid, right? Because they might be giving you some medications, they might be, doing other things, but all that to be metabolized adequately, what does the kidney need? Fluid, right? So that's adequate GFR. Now, what is adequate GFR? 90 to 120, right? Milliliters per minute. So that's adequate GFR, 90 to 120. In that range, your kidneys are going to work fine.
If it falls below 90, that's mild renal insufficiency. So you just push fluids, try to bring it back up. When it goes below 15 is when you have now renal failure. Because at this point, the kidneys are not going to be able to do anything by itself. And that's also the area where what's your next step there to save the kidney? Or to keep things going through the kidney? Dialysis, right? So once you go into that range, less than 15, and you still want the kidney to do its function adequately, you have to initiate dialysis. So we want to keep it high as possible, between 90 and 120 all the time. To measure that function of the kidney, right? So again, when you go to the hospital, want to know if your kidneys are working properly. What are you going to check for in the labs? Two things, right? Fun and creatinine, because they both indicate how the kidney is doing. Now, both of them have separate value. Okay? PUN or urea, it's a toxic substance, right? Where do we get that from? How is BUN formed? In the urea cycle, nitrogenous base, ammonium, right? You want to get rid of it. That's BUN. How do we get creatinine? Muscle breakdown. So all the activities that you're doing during the day, you're burning and muscle breakdown creatinine. So that is also a base. We don't keep it. Both of them are gotten rid of. Both of them are excreted. However, it reaches the nephron in two different ways, right? Creatinine is filtered, so which means it goes through the filtration barrier and it is dependent on GFR, right? So that's why a measure of creatinine gives you a closer indication of what the GFR is in the kidney, right? BUN doesn't do that. BUN, how does BUN reach the nephron? Excreted is eventually, but if it's not filtered, what's the other way that can get it? It bypasses that filtration, but it gets through in another way. Yes, it gets secreted, right? We talk about it in more detail later, but when it says secreted, means it's not going through the filtration barrier, so it's not dependent on GFR, basically. So when you check for BUN and creatinine, BUN tells you is the kidney secreting or secretory function, which means if it's not secreting adequately, what would BUN be? When you measure in the lab, blood urea nitrogen, it would be high because it's not being secreted. Similarly, if the filtration barrier or membrane is damaged, or if you're not filtering adequately, what would creatinine levels be in the blood? High, because you're not getting rid of it, right? So that's why BUN creatinine is important, because when you measure these numbers, what's normal BUN approximately? Should be about 18, between 15 and 20. And normal creatinine is about 0.8 to 1.2. These are normal numbers. Anytime these numbers are high, they tell you, oh, there's something wrong with the kidney. Because there are situations where only BUN is high with creatinine being normal. So what does that mean? It's filtering fine, but it's not secreting properly. And the vice versa is also true. There are situations where creatinine is high, but BUN may be normal, right? So depending on what function is affected. That's one. The second thing, what else are you going to check for in the lab to get an idea of renal function, other than BUN and creatinine? What else would you do in that? Yes. GFR goes along with BUN and creatinine. What else? Not FeNA. Something that you can do easily, especially in an outpatient office, you can do. Specifically, not glucose. Proteins, exactly. And what protein do you usually look for? Albumin, right? Looking for microalbuminurias. That can be done with just the dipstick in the an office too. Because anytime there is glomerular or filtration membrane damage, what's the first thing that's going to leak out? That shouldn't be albumin. And the pores in the filtration barrier are just large enough or small enough to prevent albumin from going through. A small damage, if the size of the pore goes up a little bit, albumin goes through. The bigger proteins may not go through. like your antibodies, immunoglobulins, they are your bigger proteins, right? They may not go through, but albumin will go through. That's why we measure for albumin in the urine. Anytime there is albumin in the urine, what does that indicate now? There is some problem. It's getting into the urine. Now, is it always abnormal? No. So that's why we have to quantify it. So when we talk about nephritic and nephrotic syndromes, it's based on the amount of protein in the urine, right? Degree of albuminuria, because it's not always abnormal. So there are situations where you might see a little bit of protein in the urine. Can you give me an example where you might see a little bit of protein in the urine and that will correct by itself? Pregnancy, sure, you can have a little bit of protein, yes.
After exercise?
After exercise, exactly, after exercise. Another one? No, renal failure, that's pathology. Now we talk about normal, yes. Infection also not necessarily, not infection. So basically any hypermetabolic state. So fever, hyperthyroidism, right? Hyperthyroidism again will be pathological, but fever after exercise, pregnancy, early morning, because what's the body doing at night? Yeah, so in the morning also, you can see a little bit, but then we quantify it to know whether it is normal or whether it is abnormal. Anyway, that comes up later. So that's how we look at renal function and why the kidneys are important. So now let's start with embryology. So when does the kidneys develop? So it's formed at around the 12th week of life. At 12 weeks of life, they are formed. What is it formed from? The kidney has two segments. You have the early part, and then they have the collecting part, right? So anything from the glomerulus, what comes after the glomerulus? The PCT, loop, and then PCT. So glomerulus until the distal convoluted tubule develops from a structure called the metanephros. That's the early part. And the rest of it, you have the collecting tubule, then your major minor calyces, the renal pyramids, and even the ureters. They develop from something called the ureteric bud, right? So the metanephros and then your ureteric bud. They develop separate. And then eventually they have to come together to form the fully formed kidney. What's going to happen if they don't come together? What do they have? Renal agenesis, right? If they don't come together, it's renal agenesis. Okay. Now, how do you know in the fetus that the child's kidneys are not developed? Which one? Opposite. Oligohydramnios. Why? The kidneys feed a little bit into it. Not much, right? 80% of the amniotic fluid is from the mom, but 20% is from the fetus. How does the fetus get the 20%? It feeds into the fluid, right? If the child doesn't swallow, have you done GI yet? No, right? So in GI conditions, when the child can't swallow, then what do they get? That's polyhydramnios, because you're not reducing it. It's not, the child is not swallowing. Oligohydramnios. So that's why we measure the amniotic fluid index, something called the AFI, amniotic fluid volume. Anything less than 5 is oligo. Greater than 25 is poly, right? And both of them have its own complications. Why do we need all that amniotic fluid? What's the purpose? Why do we need 15 amniotic fluid? What's the purpose? Lung is one. What's the main purpose though? Yeah, go ahead. Shock, exactly. It's like a cushion, right? It's protecting the fetus from the atmospheric pressure. Yes. Exactly. Right. So if you don't have enough volume, then the pressure effects on the fetus is high. So oligohydramnios can lead to that. What condition does it lead to? Powder syndrome, the flat face, underdeveloped lungs. And the second thing, someone said lung development, right? What's in the amniotic fluid for lung development? You said lung development, right? Why lung development? But why specifically lungs don't develop? What's in the amniotic fluid that helps with the lung? Yes, there's something called, so what do we check in the amniotic fluid for fetal lung maturity? Something called that's the thing? Sphingomyelin ratio, LS ratio. Lecithin to sphingomyelin ratio, right? So that's how you measure fetal lung maturity. And the ratio should be what's normal? 2 to 1. It should be 2 to 1. Lecithin to sphingomyelin, 2 to 1, right? So even here, between lecithin and sphingomyelin, which one's more important? Basically, based on the ratio, which one's more important? Lecithin. When is sphingomyelin high? So lecithin to sphingomyelin ratio is 2 to 1, right? But at certain gestational age, it'll be the opposite. Sphingomyelin will be higher than lecithin. When is that? In the beginning, exactly. In the beginning, sphingomyelin is going to be higher. Why? What is sphingomyelin? What do you need sphingomyelin for? It's in the name itself. Myelination, right? Central nervous system, development of your nerves, a myelination of your nervous system, right? So that happens early. But as it goes into the later part, now the graph will switch. Lecithin will be higher, sphingomyelin will be lower. Okay, LS ratio of 2 to 1. At what age is just lung maturity complete? 30? 36 is normal. 33. Okay, so after 33 weeks, you're okay. The child will be fine. Lungs are mature. But if it's before 33 weeks, then we have to check the LS ratio, because most likely lungs are not mature yet. If for preterm labor, for example, right? So then in those kids or those moms who are going to have a preterm before 33 weeks, what do we give them to promote their maturity? Steroids, right? Dexamethasone. Those are the patients or moms who will get dexamethasone if they're going to labor before 33 weeks. After 33 weeks, most likely lung maturity is complete, right? So that's oligohydramnios and polyhydramnios. What's the most common complication of polyhydramnios? If you have too much amniotic fluid, what's the number one risk there? Yes, preterm, because there's so much volume there, right? Pressure. So I can precipitate preterm labor. That's what poly. Anyway, so these two have to form metanephros, ureteric drug will develop into its structures, and they have to connect to make a fully formed kidney. If it doesn't, then that's when you have renal agenesis. Okay, now the renal system, because anytime we talk about urinary system, what kind of goes with it? You always say genitourinary system, right? Because there are some commonalities between the two, or they both develop together, and therefore embryologically they have some abnormalities they share. So you can have a urinary system abnormality, you might also have a genital system abnormality that occur together for that reason. So how does that develop? There are also two other ducts. Metanephric duct is for the kidney, right? The first part of the kidney. Then we also have a mesonephric duct, or the Wolffian duct, and a paramesonephric duct, or the Mullerian duct. Okay, so what do these structures develop into? Mesonephric duct or the Wolffian duct, they develop into male internal genitalia, internal structures. Your testes, vas deferens, epididymis, right? All your male internal structures. But how does your body know that these are the ones that need to be developed? Two things are needed, right? One is they need to be XY, right? You need the Y chromosome, so SRY gene, the Y chromosome. Second thing, they also need MIF, along with testosterone, right? But MIF is not to promote male development. It is to inhibit female development, right? Because the males will develop the internal structures if you're Y, if you have a Y chromosome, and if you have testosterone, it will happen. But by default, at birth, what does everybody have? What do you all have? Malaria, right? So by default, if nothing intervenes, what would we all develop into? Females, right? So that needs to stop, right? So, I mean, you might disagree with me, but so who does that stopping? When you have the Y chromosome, who's going to stop it? You're gonna, if you have the testes, and in the testes there are two types of cells, right? What are the two cells in the testes? Sertoli and Leydig cell. Which one's more important? I mean, it depends, right? So what does Leydig cells release? Testosterone. You need that for development of all of these. If there is no testosterone, what's going to happen to all the structures? Be smaller, right? That's one part. Second part, we need MIF. Where does MIF come from? Sertoli cells, MIF, Mullerian inhibiting factor, right? We also said, just like Wolffian duct, there's something called the Mullerian duct, which is going to develop into all the female internal structures, right? Since we all have that, we need that MIF to turn that off when you are a male, right? So what happens if there is no MIF? What's going to happen to that person? Is XY developmentally, what would you see in that person? So when you talk about structures, there's internal and there's external structures, right? Things that are things we can't see and things that are outside that we can't see. So if it's a male patient, let's say you're a male, XY male, so that part is settled, XY, okay? MIF, for whatever reason, MIF is absent. As they grow, what will happen to internal structures? What will happen to their external structures? Yes. That's only one part of it. What's the complete scenario? Yes, you're right. They'll maintain female internal structures. But what else? How will they look externally? Yes. Which one? Why? Or should they? No, what's the functional inhibiting factor? It only turns off your female structures. That has nothing to do with the male part. What do you need for male development structures, for structural development? Testosterone. Do they have testosterone? They do, right? So what happens to their external structures? You're fine, you'll remain male, right? Externally, you'll be male. But would the internal male structures develop? Why not? But they are XY and they have testosterone.
They don't have MIF.
What's the role of MIF?
To inhibit female alternative.
Does it affect the male structures?
No,
It doesn't. So what will they develop?
they have both.
They will have both. Exactly. Right? So a person with MIF absent will have both male and female structures internally. When you do, obviously it's not going to be completely developed. You'll have a rudimentary uterus. You'll have a rudimentary ovaries. You have some rudimentary tubes there in a male, along with no. Externally, there's two males. Remember, this is not an estrogen issue, right? Nothing to do with estrogen. So there's no gynecomastia, anything like that. It's purely one thing that should be turned off, didn't get turned off. Everything else will develop accordingly, but the thing that should have been turned off also remains on, which means that's how they develop female internal structures. Everything else is male. Externally, they are male. Internally, they are also male, but they also have these rudimentary female structures. Is that clear? As to how? There's a lot of questions on sexual differentiation. So it's very clear. There are multiple scenarios. We'll go through all of them. Yes.
So when this patient comes in like at 21 years old, you would never know unless you did a CT scan.
Exactly. Right. Maybe they will develop infertility. You know, they're growing up fine. You don't know. There are some, a little rudimentary uterus there or some ovaries there, but You don't know what's going on. Maybe they develop infertility because even though the male structures are developed, maybe there is some crowding there, maybe there's some underdevelopment there. So they might, and that's the only way you find out, because you wouldn't know otherwise. Exactly, because externally, they're fine. Yes. Do they have are they XY? So if they have XY, do they have testes and they have, so does testes make testosterone? Yes. So do the male structures develop? Yes. Right, but the females also develop side by side. Internal. Good. There. All right, so that's MIF. And then the paramesonephric duct or the Mullerian duct, they develop into female internal genitalia. Okay, ovaries, only some part of the ovaries, the fallopian tubes, uterus, and the upper third of the vagina. Why is an upper third important? Why isn't the entire vagina coming from the Mullerian duct? Because if the Mullerian duct is absent, right? Let's say a female, the Mullerian duct died. What's not going to develop? Uterus, the tubes, and the upper third of the vagina. But what will still develop? The lower two-thirds. Those are those patients on a physical exam board, they refer to them as the blind pouch. Right? When you talk about a blind pouch, or the when you do a vaginal exam, all it means is that there is no connection between the lower two-thirds and the upper one-third, because they got to connect to form a fully formed vagina. If you don't have the upper third, you just have the lower two-thirds, it ends in a blind pouch because there is no connection.
So when you do that, the gynae exam,
Hmm.
you won't see a cervix.
Yes, exactly. You won't, because you only have the lower part of the vagina, and there's nothing about. There is no cervix, there's no uterus, there's no tube, there's no ovaries. Because the Mullerian duct is completely immuted, and that condition is called Mullerian agenesis in a female. Mullerian agenesis means all the structures that are developing from the Mullerian duct do not develop. But the lower two-thirds of the vagina is from a different structure that continues to develop, and they have a blind spot. Now, here too, everything else is normal, right? The female can develop as a female, but most of the time, it's that when the time of menstruation comes and they don't menstruate, menarche doesn't happen or it's delayed, that's when they find out the blind pouch. Okay, there's nothing inside. Clear? All right, so that's Mullerian agenesis. The Mullerian duct, for whatever reason, it involuted. So a female can develop by design or by default. So that's what we were saying earlier. By design, XX, everything goes normally. By default, if for some reason the male, what you call, you don't have MIF or something is suppressed, not enough testosterone, then they can develop by default into with female structures. Okay. Now, what about the rest of it? There's another structure called the cloaca, which has a base and a tip. The base of the cloaca is urogenital sinus. This is what in female becomes the lower two-thirds of the vagina and also forms the labia minor. Okay. In the male, it becomes the prostate, prostatic urethra, the bulbourethral gland, and the bladder. So that's a connection here too, and the bladder. Okay, so the urogenital sinus. So that's why if you're an abnormality in the urogenital sinus, you have some overlap between the genital system and the urinary system, because that's the structure that develops into the bladder. In the males, so prostate and bladder mainly, and the females, the lower two-thirds of the vagina and the labia minora with the bladder. Okay, so that's the base of that structure, cloaca. It's also got a tip. The tip of the cloaca is the urogenital tubercle. This tubercle is what becomes the penis in the male, and the clitoris in the female. So urogenital sinus has a base and a tip. Base goes into bladder and prostate in the male, the lower third of the vagina, the labia minora, and the bladder in the female. Okay. To kind of close it off, labioscrotal swelling, the last structure, it becomes the scrotum in the male and the labia majora in the female. Okay, so recap. All right, so before I ask the question, I need a volunteer. You put your hand up and then I'll ask you the question. All right, so first, going back to what we were talking about, the kidneys itself, right? So what's the structure that the kidneys develop from? Only?
And
Ureteric bud. Okay, another hand. Come, yes, so what does the metanephros develop into? Well, what structure specifically? Even online, you can put your hand up, I can ask you. Correct, up to DCT, right? And the ureteric bud is the rest of it, right? So that's that part. Now, we also talked about two other ducts, right? You have the mesonephros and the paramesonephros. All right, who would like to tell me what the mesonephros develop into? Yeah. Which are? Yeah, all of that, right? For intermale, internal. What about the other duct? Paramesonephros. What does that develop into? Come on. Yes. What does it develop into? Part of the ovary there. And the fallopian tubes. Okay, those are two. Now, the lower 2/3 of the vagina, right? What does that develop from? Over here. Wait, looking into me. Eye contact. Yes. Urogenital sinus. And what is urogenital sinus a part of? What part of the cloaca? The base of the cloaca, right? So along with the lower 2/3 of the vagina, what else does the urogenital sinus develop into? And the bladder. How about the male? Prostate and the prostate, right? How about the labia majora? Well, that's on the slide, but anyway. And the scrotum is from labiosacral swelling. And then finally the tubercle, right? Something called genital tubercle is what goes into the anus in the male and clitoris in the female. All right. So that's the development. Now there are abnormalities of development. A couple of things they mentioned. Hermaphrodite was a term used to describe these conditions. Not anymore used. Now it's just called disorders of sexual differentiation, DSD, differentiation. So the hermaphrodite term is no longer used. But, you know, we still kind of use it to refer to certain conditions. Okay. So there is a true hermaphrodite and a pseudo hermaphrodite. What's a true hermaphrodite? When the internal genitalia is opposite to the genotype. And we just talked about one example, right? What was the example we just talked about? When the internal is opposite to the genotype. Right there. When? Look on the slide. MIF is missing because they develop female internals, right? So that's one condition when the male internals in an XY or an XY male can have female internals. So internal opposite is true. But can a female be a true hermaphrodite? Can a female develop male internals? Yeah, because they don't have the Wolfram duct ever. You know, nature or by design, I don't know. You know, males are born with both, but females are just born with what they need, right? Okay, so that's why a true hermaphrodite is not possible in a female. Now, there's also pseudo. Pseudo is the other way, the external, so that what we can see opposite to genotype. And there are many more examples of this condition, because externally you're different from your actual genotype. An XY male might look like a female, or an XX female might look like a male. So externally that can happen, right? Because external structures, what are they mainly dependent on? The development of external structures. External structures. What are they dependent on? Male or female. In general, they are hormonal dependent. So if you have testosterone, your male externals will be fine. A female with too much testosterone will also have bigger structures externally. Similarly, a male with too much estrogen can develop breasts, right? Because it's hormonally dependent, the external structures. So anything that affects testosterone or estrogen or its receptors. So also remember, endocrine hormones, right? All hormones need a functioning receptor. So it's not just enough that you have the adequate amount of hormone. What else do you need to have? A receptor that is responsive to those hormones, right? If you don't have an aldosterone receptor that's working, what's the point of having lots of aldosterone? Nothing. It's not going to do anything, right? Similarly, if you have a lot of testosterone, but if the receptors are not working, does it do any good? It doesn't, right? So receptors or hormones. So what are those conditions that can lead to a pseudo hermaphroditism? And let's look at this pathway. Now you have seen this pathway in adrenals, right? Where is androgens made? Primarily. Well, not, you're right, but primarily, the most of it. Yes, testes, right? Yes, there is some from the adrenal cortex, but Leydig cells, that's what they do. That's what the function is, right? Most of it. So that's why even if you have Leydig cells missing, it's a problem because adrenals don't make enough. They do make some, right? Not enough to, masculinize everything. So this pathway is in the adrenal gland, and they make the cortex, and the adrenal gland has a cortex and the medulla. Cortex has three different structures, right? What were the structures? Glomerulosa, fascicularis, or fasciculata reticularis, right? All right, so let's review. You've done this before, right? For the first time you're saying this? Maybe. All right, so there are two enzymes here that deficiency can lead to problems. What are those two enzymes? I mean, there are three, but two primarily, which is 21 hydroxylase, which comes here, and the other is 11, which comes here. Okay. So glomerulosa, what does that make? What hormone does that make? Aldosterone, right? On the other hand, what does aldosterone do? Increases sodium. What else? It decreases potassium. What else? Increases water. What does it decrease? What does it secrete? Hydrogens. So it also maintains some blood pressure, right? Because blood pressure regulation. Okay. All right. So that's aldosterone. If you don't have aldosterone, the opposite. Hyperkalemia, hyponatremia, alkalosis, hypovolemia, hypotension, right? The opposite of all this happens if that's missing. So how is that missing? First scenario is, or the most common enzyme deficiency is 21, right? So it goes the way through 21. So if 21 is missing, what would the person be blood pressure wise? Hypotensive, right? How about sodium? Hyponatremia. What about potassium? Hyperkalemia. What about pH? Alkalosis, right? The opposite of all that. If 21 is missing. How about cortisol? Do you need 21 for cortisol? Yes. If you don't make enough cortisol, how does that manifest in you clinically? What is cortisol? But what is it? Hypoglycemia, because it's a glucocorticoid. So this is the person with all the things we talk about, aldosterone issues, plus low blood sugar. Okay. Now, what are the functions of cortisol? It's a stress hormone, right? It's a steroid. So remember, we talked about, I think we talked about it in oncology, steroids. What do? Inhibits phospholipase A2, right? Remember this? Now you have seen this again after that since, well, that was the only time. What was the only time? No way. All right, K kills T cells and eosinophils. I inhibits macrophage migration. S stabilizes mast cells. And the last one stabilizes endothelium, right? So that's the stress part of it, of what cortisol. And remember, I also said something about cortisol. Everything is decreased except what's the only thing in the immune system that increases with cortisol, where you look in this list, everything is inhibited or decreased. What's missing in this list? Neutrophils, exactly. So with cortisol, all of these decrease, all of these are inhibited except neutrophils. So your neutrophil count will be high in cortisol, right? And what was that due to? Demargination, exactly, right? All those neutrophils on the blood vessels, it demarginates and gets into the blood, right? So that's that immune-related function. What else does cortisol do? Proteolysis. What else? Gluconeogenesis. What else? It all goes in the same, under the same umbrella. Proteolysis, gluconeogenesis. Basically, what is it trying to do in that umbrella, under that umbrella? Trying to increase? Yes, it is trying to increase glucose, right? It's gluconeogenic. So gluconeogenesis, proteolysis, glycogenolysis, and ketogenesis. Ketones. Not glycolysis. Lipolysis, exactly. Yep, correct. Lipolysis too. So basically it breaks down everything and makes glucose from whatever it can, right? Along with making ketones. And that's how in DKA you get ketones too, because through lipolysis under cortisol increased. But what's also the number one hormone that does this in DKA actually? In diabetic ketoacidosis, what's the number one hormone that starts us off? Glucagon, exactly, glucagon. Cortisol comes later. When does glucagon come? It's about 4 hours. Yeah, glucagon. All right, so that's cortisol. That's also inhibited with 21. So now if you can't go to aldosterone, you can't go to cortisol, where is everything else going to go? It's going to go here. So this person will have increased testosterone. So a female with 21 hydroxylase deficiency at birth, what do they look like? Male, right? Because they have clitoromegaly. or in other words, they say ambiguous genitalia, because you don't know it's a male or female somewhere, right? It's a female, but you have clitoromegaly. So that's why it's enough male. What will that manifest? At birth, that's fine, but then there is precociousness as they grow, right? So female ambiguous genitalia at birth, male precociousness with 21 hydroxylase deficiency, right? So what's the other enzyme that could be similar with as far as sexual differentiation goes between the other two enzymes in this pathway? There's 11 and there's 17, right? Which one will look similar to 21? Come on. So 11. Why? Because 11 is here, which again shuns everything to testosterone, right? Then how do we know 21 versus 11? If sexually or externally, 21 deficiency and 11 deficiency look the same, right? Because both of them have increased androgens. Agreed? Let me know if you disagree, right? We can debate over it, no problem. All right. So both of them have increased androgens. But then how do we know which 21 or 11? Other than that 21 being the most common, so if you're in doubt, go 21. But other than that, what else do we look at? We'll look at blood pressure. Why? Because if you don't have 11, what else accumulating is right here, 11 DOC, which if you look here on the slide, weak mineralocorticoid. So which means it will behave like aldosterone, right? So which means you'll have the opposite of 21. They have high blood pressure, high sodium, low potassium. So hypernatremia, hypokalemia with ambiguity would be 11. Hyponatremia, hyperkalemia with ambiguity will be 21. Is that clear? Very, very important. You have to know that code. 100% guaranteed to have some questions on this, right? Yes. Correct. Not because of aldosterone, but because of DOC. Correct. Okay. Now, what's a third that could be missing?
Excuse me, sir.
Yes.
Please, can you highlight the difference between 21 and 11?
Yes. So it's actually right there, right here. 21, hyponatremia, hyperkalemia, hypovolemia, hypoglycemia, ambiguous genitalia, and hyperpigmentation. Why hyperpigmentation? Yeah, because you're backing up, you also have you're decreasing cortisol, right? If you decrease cortisol, what are you going to make up in the pituitary? ACTH. So for making ACTH, what else is made along with it? Yeah, POMC and MSH. So that's why you have hyperpigmentation, right? So this, along with increased, what's missing here is hyper or hypotension. Okay. So all of these go with 21. Clear? Agreed? 11. Hypernatremia now. Hypokalemia, hypertension, but these two are the same. Ambiguous genitalia and hyperpigmentation will be there. But the difference is blood pressure and the electrolytes, right? So that's how you know between 21 and 11. Okay. Now the third is 17. Which is right here. So 17 is blocked. What's made in excess? Aldosterone, because everything is getting shunted towards aldosterone, right? So they'll have hypernatremia, hypokalemia, hypertension. Does that make sense? But what about cortisol? Down. What about androgens? Down. So these males with 17 deficiency will have feminization. So again, ambiguity there, but or testicular feminization. Female doesn't really matter, right? They'll be fine. So that's a third deficiency. So basically in all three, cortisol doesn't help because all three have low cortisols. All three will have hypoglycemia. But the electrolytes and the androgens, you look at that and see whether it is 21, whether it's 11, or whether it's 17 deficiency. Clear? Any questions?
So how do you differentiate between 21 and 17 then? Since they're both kind of similar, they both have hypertension. Is it like you said, the males will
No,
have?
wait, hold on. Not 21, 11, because 11 has hypertension, 21 has hypotension.
I mean, 21 and 17 both have hypotension.
No, 21 has hypotension, 17 has hypertension.
Okay, well, how will you differentiate between the 17 and 11 then? So
11. Yeah, you look at androgens because 17 there'll be hypogonadism, whereas in 11 it's hypergonadism. 17 you're not making androgens. In 11 you're making too much androgens. Is that good?
Yes, thank you.
All right, another question here. ADH doesn't do anything with sodium, right? ADH is pure water, and they will have a secondary effect on sodium. If they take too much water, dilute sodium, hyponatremia. If you're less water, hyponatremia from a dehydration standpoint, but not directly affecting sodium. Whereas in aldosterone, it directly affects sodium and water. So let me ask you, if there is too much aldosterone, what's it going to do to volume and sodium? What about volume? What follows sodium? So what happened to ADH? It will shut off, right? They don't work unless it's in a different situation. When it's a purely aldosterone issue, a purely sodium ADH issue, they kind of turn off each other. Okay.
For 11 hydroxy, why is everything having things that are increased, right?
Because there is excess. Because when you say 11-DOC, it's a weak mineralocorticoid. By itself, initially it'll be fine. But what if it keeps accumulating over a period of time? Then it starts to show its mineralocorticoid effects, which is why sodium will go up. Now, compared to 11 versus aldosterone, let's say sodium goes up to maybe 155 to 150. I mean, that's a difference, right? So once it accumulates, because it acts like aldosterone, it will function like aldosterone. But for that, accumulation has to happen over a period of time.
Not understanding what the regulatory mechanisms are.
Turn which one off? It's not being turned off, it's being converted to aldosterone, right? So it doesn't stop with 11-DOC. So you don't have to turn DOC off. It just, you make 11-DOC and then it makes aldosterone. And so and then when sodium is adequate, it turns off aldosterone, right? No renin. That is the regulatory mechanism there. Make sense? Okay. Any other questions? Good?
Yes, sir. I have a question, sir.
Yes, go ahead.
Yeah, please. I'm sorry. Yeah, can you go through it again? What you said is what is seen in 17 hydroxylase deficiency?
Sure. So in 17 hydroxylase deficiency, you have increased aldosterone, which means you have increased sodium, decreased potassium, and hypertension. Then you have decreased cortisol. So you have hypoglycemia, decreased glucose. And then you have decreased testosterone, which means there is testicular feminization in a male. Everything is small. Okay.
cortisol all this stuff. Or you get too much of testosterone, or you get that's all. What happens in like syndrome and the cortisol will also start decreasing testosterone.
No, because it'll affect androgens. Aldosterone, what's the number one regulator of aldosterone? No. Hormonally. Renin. Aldosterone, even though they all in the adrenal gland, aldosterone, cortisol, and androgens, aldosterone is under the control of renin, not ACTH. Cortisol and androgens are controlled by ACTH. Right? So which means if you have too much cortisol in Cushing's, it will turn off ACTH, which can affect androgens. It can turn, yes. So, but usually when you say Cushing syndrome, it happens later on in life. So everything is already developed, right? So you wouldn't see any developmental issues unless they're born with Cushing syndrome, which usually doesn't happen. It's usually an adrenal adenoma that gives you Cushing's, right? That happens later in life. It's a tumor, not otherwise. Now, adrenal insufficiency can happen even at birth because, either due to low flow or shock or something like that, they can have adrenal crisis, or even with maternal hyperglycemia can also cause adrenal shock in a child, right? Yes, so that can happen, but not Cushing's normally doesn't happen. Okay. All right, so it's important to keep that separate. Aldosterone is controlled by renin. It's a renin angiotensin aldosterone axis. That's one. Whereas ACTH controls cortisol and androgens. Okay. Now, the only other thing also to remember is when you have excess cortisol, it causes hypoglycemia. But when you have too much cortisol, it also has mild mineralocorticoid activity. When you have too much cortisol, that can also increase your sodium. That can also increase your blood pressure. All right. So it has, when you have too much of cortisol, it does have a little bit of aldosterone-like activity. So remember that too in questions. So don't be surprised if you see hypertension in somebody with Cushing's, right? Because it does have some mineralocorticoid activity. Yes. So angiotensin 2, we're going to talk, it's actually coming up. We'll talk about it. Okay. All right, this is clear. Other causes of pseudo. Again, pseudo, we said, external, opposite to genotype. What are some other reasons why external can be opposite to genotype? We need the testes to make androgens, right? What are the testes that not come into your scrotum and started making your androgens sufficiently? They could be stuck in the inguinal area itself, and that condition is called cryptorchidism or undescended testes. Now, if you encounter a child, a baby with undescended testes, what would you do? Do you go in there and grab it and pull it down? Or not yet? How long would you wait? 1 year, right? So you can actually wait until a child is at least a year of age, and if it still hasn't descended, now you want to pull it down, okay? You can wait up to a year to see if it has come down by itself. So cryptorchidism. Retractile testes. So what does retractile testes mean? It's just like some mornings when you come to class, you walk in the door and say, I'm not here today, I'm going back, right? Just like that. Retractile test is it. It comes down and says, I want to go back. It goes right back into the abdomen, right? But why though? Why does it go back? So which means what else do you have to check for? If it has to go back, so if you want to go back to the village, one of the shuttle is left. Yeah, right? So there has to be a way it has to go back, right? So what do you think is still there? The hernia. You have to check for hernia, indirect hernia, because that pathway is still open, so it can actually go back. So what do you have to do? Pull it back down and repair it. Okay, so that's retractile testes. Sertoli-only syndrome. Right? Sertoli-only means what's missing? Leydig cells. So what's missing? What do they not have then? Testosterone. What happened to all the external structures? Right? But what happened to the internal structures here? They have male. If you don't have Sertoli, I mean, you know Sertoli, think again. Sertoli only syndrome. What cells are missing? Leydig cells. What hormone is missing? Testosterone. So what's going to happen to the external structures in a male? Underdeveloped. What's going to happen to internal structures in a male? Hey,
Missing.
listen. Remember, again, we said this before with MIF. What does MIF do? Does it help develop male or does it help inhibit female? Inhibit female. It has nothing to do with the development of the male, right? MIF, Mullerian inhibiting factor. It only inhibits Mullerian. It doesn't do anything with Wolffian. But Wolffian type development, what does it mean? Testosterone. Androgens, right? So if you don't have Leydig cells, what happened to male internals? Underdeveloped. What happened to male externals? Underdeveloped. No testosterone, right? No? Yes?
So MIF, where does it come from? Like Leydig or Sertoli?
Sertoli.
It comes from Sertoli.
It comes from Sertoli. So this is Sertoli only syndrome. So they have MIF, but they don't have Leydig cells. They don't have testosterone. So which means what does the male need for internal and external? Testosterone. So there's no testosterone internal and external development. Now, however, at birth or in utero, what develops the externals? It's not testosterone, it is DHT. But you still need testosterone for that, right? DHT is made from testosterone, which means you don't have testosterone, you're not going to have DHT either. So at birth, it's DHT, and then testosterone takes over after birth. Okay, so which means you can have a lot of testosterone. Listen carefully, right? While the child is still inside, a male child internally can have a lot of testosterone, but when they are born, it's ambiguous genitalia. One. There we go. Okay, question again, right? So a male child, intrauterine male child has everything okay. Leydig cells are fine, Sertoli cells are fine. They have plenty of testosterone around. However, you still see ambiguous genitalia or underdeveloped external structures at birth, in spite of them having testosterone. So now what is the problem? Exactly, the conversion. So what's missing there? 5-alpha reductase deficient. Right? Keep that also clear. So even though you have testosterone, if you can't make DHT at birth, you'll still have ambiguous genitalia. All right. Okay. Mums. Why? What happens in mums? What are those organs, glands affected in mums? Parotitis, orchitis, pancreatitis. What's the fourth? The worst of all them. Encephalitis or meningitis. Encephalitis, meningitis. So parotid gland affect. Parotitis, pancreatitis, orchitis, and meningitis or meningoencephalitis. Right? Those are things you see in mom. So that orchitis is responsible here for the pseudopods. And then 5-alpha reductase deficiency. And what we just said, if you don't have 5-alpha reductase, you can convert testosterone to DHT. That means when the child is born, they'll have ambiguous genitalia because DHT is what's responsible at birth. However, after birth, testosterone takes over and they will develop fine. Okay. Now, we also use 5-alpha reductase inhibitors, right? Clinically for in certain situations. Okay. Where would we use 5-alpha reductase inhibitors? An example of a condition where 5-alpha inhibitors are used as for treatment. Yeah, BPH, right? Benign prostatic hyperplasia. There are also a couple of other drugs which have a secondary effect of inhibiting testosterone levels, like ketoconazole and spironolactone, right? Both of them reduce androgen synthesis. Spironolactone actually blocks androgen receptors. Okay, but how basically it reduces androgen's effect. Where do we use these? Hirsutism in peacocks, polycystic ovarian syndrome, hirsutism, ketoconazole and spironolactone are used as treatment because of its anti-androgenic properties or effects. Okay. All right. So another condition, androgen insensitivity. Fantastic.
Yes, sir, I do. In the notes for 5-alpha reductase enzyme deficiency, one of the conditions you have is the blind vaginal pouch. So I was just wondering if you could just walk us through how that would happen, because I thought the vagina is developed from the Mullerian duct, so I'm not sure how that's connected to the testosterone and DHT.
Yes, that's what I'm going to say right now, talk about right now. Androgen insufficiency syndrome, right? So AIS is you have androgens, but the receptor is not working. Okay, so androgen insufficiency syndrome. Okay, androgen receptors are blocked, but you have enough androgen. So what do these people look like? If it's a male, female, no big deal, right? If it's a male, I'm going to compare these two. But before that, in a male, right? Now, another thing with testosterone, right? If the testosterone is accumulating, but it's not working with its receptor, what will happen to all that testosterone? It gets converted to estrogen. What's the enzyme there? Aromatase. So these individuals with androgen insensitivity syndrome will have a lot of testosterone because it's not a testosterone issue, it's a receptor issue, and the testosterone will get converted to estrogens. They'll have increased estrogens. Which means now what will they begin to look like? Female, right? Externally, a female. So they'll have breasts. Now, this is where the blind pouch came in. You asked about blind pouch earlier. Now, the lower part of the vagina is from what? What structure was it? Already? At least wait till the afternoon.
Is the cloaca?
What specifically? The base, urogenital sinus. So that has nothing to do with the Mullerian duct, right? So if you have too much estrogen, because the urogenital sinus is there in the male and the female, and because rather than testosterone causing it to become the prostate and all that kind of stuff, the estrogen will make it like a blind pouch. So these patients will have a blind pouch. And that also applies to 5-alpha reductase, because if you don't have 5-alpha reductase, you're not making DHT, right? So what's accumulating? Testosterone. What can it be converted to? Estrogen. So the same thing happens even in 5-alpha reductase deficiency. And to answer your question, Fanta, that's why you get a blind pouch in 5-alpha reductase deficiency. Yeah, because the testosterone gets converted to estrogen rather than DHT. Okay, so this is what a person will look like. But AIS, genotypically, they're going to be male, right? That's why we say androgen insensitivity syndrome, because obviously they are male and then it's not working. Mullerian agenesis, they are XX, because we talked about this earlier, right? They're female, but the Mullerian duct is not there, which means what will happen to their external appearance? They'll still be female, right? Meaning they have estrogen. Which means they'll still be looking like a female. They have breasts. And they also have blind pouch here. Because now the blind pouch is due to Mullerian duct disappearing and only the urogenital sinus making the bottom. Now, if you look at these two individuals, they look the same, right? But one's a male and one's a female, genotypically. So, other than genotyping them to see who is male and female, externally, there's another way to differentiate between the male and the female. What else would you look at? What can you look at? Hair, right? What do we need for hair growth? Pelarchy, we need androgens. So which person out of the two will not have hair? Yes, so absent or sparse hair. So axillary hair, pubic hair, all that will be absent. Whereas Mullerian will have normal hair growth. So everything else is the same except that. So sometimes just by knowing that, even though they look identical, you look at hair growth, that can help you separate Mullerian agenesis from AIS. Obviously, the best way to do genotyping. So you look at one's a male, another one's a female. Okay. Now, DHT receptor can also be blocked. The problem here is they have a problem with the receptor to begin with, but medications can be used to block the receptor too, right? Flutamide is the androgen receptor blocker. Now we talk about this in oncology too. Where do we use flutamide? Where do we want to block androgen receptors? No BPH. Prostate cancer. And I also remember saying this. Why do we use flutamide in prostate cancer? What is its purpose in prostate cancer? Did you review oncology? I know it was a long time ago. I know it's not fun, but what's the treatment for prostate cancer? Quiz. What's the treatment for prostate cancer? Medication works.
Is it tamsulosin?
What's that?
Is it tamsulosin?
Nope. Nope. What is the medication? Without prescribing for the flutamide, there's one that you haven't said yet, which also affects the axis. Starts with L. Lupuli. There we go. Lupuli. What is lupuli? GnRH agonist, right? Analog agonist, right? So what does a GnRH agonist do initially? Because it's an agonist. It increases testosterone. So is that good when a patient who has prostate cancer? No, why do you want to increase? But eventually it will shut down the axis. So that initially when you give GnRH agonist, there's a surge in testosterone, right? So what can we treat them with so that that surge will not affect the prostate? Flutamide. That's the reason, and that mechanism of action you have to know, because that is a question. Why do we use flutamide in prostate cancer? To block the effects of increased testosterone initially when you give a GnRH agonist or lupuli. Okay, so that's the reason why. I'm going to ask you more oncology questions. No. All right, so propteron and flutamide, those are your two androgen receptor blockers. Okay, used in prostate cancer. All right, enough with all that. Let's get into.
Excuse me, sir.
Yes.
Please, I have two questions, please. One is that, please, what did you say that, what did we see in the moms, please?
Moms have orchitis, inflammation in your testes, orchitis. So which is what affects testosterone.
Okay.
Second question.
Second question is, sir, please, what did you say that was used in prostate cancer?
Prostate cancer is GnRH, gonadotropin releasing hormone agonist, leuprolide,
Oh,
along with flutamide.
so what did they use fusamide, sir?
What's that?
Why is fusamide used? Why did we use?
Flutamide to block the androgen receptors so that that increase in testosterone will not affect prostate at that point. You want to block the receptor because when you give leuprolide, testosterone levels go up initially. All right.
Thank you. Thanks.
All right. So now let's get to the kidneys. Anatomy. One kidney on each side. Right is lower than the left one because liver takes up a little bit of room, pushing the kidney a little lower. And if you look at the level, measure it at the hilum of the kidney, right is at L2 and left is at L1. Okay. Blood supply. Renal arteries comes off the aorta. Okay. Left is a shorter vessel because aorta is on the left side, inferior vena cava is on the right side. So from the aorta to go to the left kidney will be shorter. Similarly, venous drainage, the right vein will be shorter because IVC is on the right side. Okay. Right renal is a long vessel and it runs behind the vein, inferior vena cava. On the other side, right vein, renal vein is a shorter vessel, the shorter distance, and the left renal vein is long and it's anterior to the aorta. Okay, so the venous vessels are in front and the arteries are in the back. Gonads, left gonadal vein drains into the left renal vein, forming a 90-degree angle. Here comes the next oncology question. Right? So we talked about varicocele, right? Remember varicocele? So if someone has a left-sided varicocele that's not going away, what would you suspect? Or what would you want to rule out? On which side? On the left side, right? Because left renal vein goes into the left gonadal vein goes into the left renal vein. So if you have a left renal mass that's occluding that drainage, the gonadal vein can accumulate, have venous pooling, and you need to varicose it. So look at that. Okay. Right gonadal vein goes straight into the IVC. So that's more significance with cancers and infections that can spread faster because it goes directly to the IVC. Which one? I don't know if it's called the mitochondria. I'm not sure. Yeah, I'm not sure what that. Lymphatic drainage. Gonadal infections and cancers drain into para-aortic. So testicular cancer, right? What's a lymphatic drainage of testicular cancer? Where does it go? What group of lymph nodes? Para-aortic, right? Testicular ones will go to the para-aortic. But if you have like an STI, where would that go into? Inguinal. Yeah, the STIs or any superficial infections that drain into inguinal nodes. If you have testicular infections or testicular cancer, that goes into the para-aortic node. Okay. Nerve. The testicular nerve supply, it actually started in the abdomen. And that's why a lot of times when you have testicular pain, it could present as an abdominal pain too, because of that radiation. What are the nerves? You have ilioinguinal, genitofemoral, and pudendal. These are the nerves. Yes. Any other STIs, sexually transmitted infections, anything superficial, they go into the inguinal nerves. Yeah, lymphatic usually follow veins. Yeah, not the arteries, the venous drainage. Correct. Yeah. Okay. All right, a little bit of anatomy in the kidney. We have a cortex and the medulla, right? So as the nephron goes through the kidney, it kind of goes to the cortex and the medulla, right? Half in the cortex, half in the medulla, right? How many nephrons are in the kidney, approximately? Yeah, I don't know who was the person who signed all those, but they have 1 million of them in each kidney, right? Somehow they got their count. 1 million, at least 1 million in each kidney, right? All right, so the cortex, when you look at the nephron, you have a cortex and the medulla. So what's in the cortex? Your glomerulus, PCT, the early part of the loop. The loop itself is in the medulla, the DCT, collecting tubule. Okay. Now, as blood gets to the nephron, we're talking about the afferent arteriole. You have the efferent over here, but afferent arteriole, blood that comes to the kidney. What's the normal serum? What's normal serum osmolarity? I mean, not exactly, it's a range, about 295, it's 275 to 295. So for convenience, I'm just going to say 300. Okay. So 300, that's normal serum osmolarity. This is the blood that's getting filtered. So when this blood now enters the nephron, the glomerulus and the PCT, what's the osmolarity there? In the PCT, as blood is getting filtered into the PCT, it's going to be the same, right? Because it's the same blood. So in the PCT, it's still going to be 300. Okay. So when we say cortex is isotonic, that's what it means. Because cortex has the same osmolarity as your blood, the fluid in the renal cortex, especially in the PCT, not always, in the PCT. So it's isotonic. All right. Now, what's happening to this osmolarity as it now moves through the nephron? You have a lot of all reabsorption happening there. Now, main thing that changes that osmolarity is water that's leaving. Okay. So in the descending limb, you're removing a lot of water, and the descending limb is impermeable to solute. Okay. It only removes water. I'm removing all that water from the tubular fluid. What happens to the osmolarity of that fluid? It goes up. And that's why as it goes down the tubule, it increases. When it comes to the loop, it's about 800 to 1200. And that's why we say medulla is hypertonic. Right? Now, this fluid now goes up the ascending limb, and the ascending limb is impermeable to water, but it removes electrolytes. Well, I'm the osmolarity now. I'm removing solute, leaving the water in the tubule. Well, I'm the osmolarity now as it goes up. It gets more dilute. Does that make sense? Why it becomes more dilute? Because I'm removing solute. So when it comes to DCT, 100. So DCT is the most dilute part of the nephron, but it's also in the cortex, but it is hypotonic. So the cortex can be isotonic in the PCT or hypotonic in the DCT. Okay. Now, is that significant? Yes, there is a reason why we need to know that, right? So in the kidney, there are some, so we talk about why is kidney so important. There are some autoregulatory things that happens in the kidney, right? Anytime your blood pressure falls, anytime your volume falls, anytime something happens, the kidneys will do something too. Anytime osmolarity changes, the kidneys will readjust. Okay, so what are those two cell types in the kidney that responds to volume, blood pressure, and osmolar changes. There are two types of cells. What's the one that responds to volume and blood pressure changes? The JG cells, JG, juxtaglomerular cells, they respond, they kick in when there's a volume issue or a blood pressure issue. Okay? And what if there's an osmolarity issue? What cells kick in then? The macula densa, right? So if macula densa is responding to osmolar changes, based on what we just talked about, the different osmolarities, where do you think that cells are going to be? In the DCT. So right in the DCT or by the DCT, there's the macula densa. Okay, so in reality, right? And what's a JG cell? So if it has to respond to volume changes, that's coming to the kidney, where's the best place for it to be? No. Yeah, what part of the glomerulus? The afferent arteriole. So this is where the JG cell, because that's the best place for it to be if its role is to identify low flow to the kidney. That's how blood gets there, right? That makes sense? But in reality, those are not two different cells. There is a complex called the juxtaglomerular complex, which is one complex. On this side, on one side is the JG cell, and the other side is the macula densa. So in reality, the nephron is actually, the DCT touches the afferent. When it loops around, that's how it goes. So that's why you have a cell on this side of DCT, and this side is the afferent, and this part of the cell is JG cell, and this part of the cell is macula densa. Okay, so macula densa senses osmolarity. So because it is 100, any change in that will suddenly kick in, turn on the macula densa, and that's how then it will talk to JG cell and correct it. So let's say that the osmolarity in the DCT is 200, right? It's 200. What does that mean? It's more constant hypertonic or concentrated, right? Because it's supposed to be 100. When the osmolarity is high, it's more concentrated. When the osmolarity is low, it's dilute, right? So let's say that fluid that's in the DCT, instead of being 100, let's say it's 200 or 300. What is the problem? So what is going on there? Means that it's more concentrated, which means there are more solutes reaching there, right? But what do you think the macula densa is going to tell the JG cell to do? Either you cannot increase just volume. Are you going to increase GFR or are you going to decrease GFR? You can't just selectively do volume or electrolyte. You can't do that together, right? They're either constrict or dilate. So if I have too many or too much solute reaching there, how does the solute get there? It got filtered, right? So what do you think needs to happen to GFR? Increase, exactly, right? So which means, again, to recap that, if the osmolarity that reaches the DCT is high, the macula densa will kick in and message the JG cell to reduce GFR. How do you reduce GFR? Constrict the afferent. Less blood flow, less GFR. Okay. Conversely, what if the osmolarity is like 50? I mean, it's more dilute. So what will happen to do? What do you have to do to GFR? You want to get more volume in, but at the same time, you're also putting more solutes in, so increase GFR. That's how it works. Okay. The macula densa, right? That's the reason why the macula densa is in the DCT. Now then, after that, as it goes through the nephron, when it comes to the collecting duct, what works here? We'll talk all about that in detail much later when you do nephrophysio. Aldosterone works here and reabsorbs sodium, reabsorbs a lot more water, and then ADH works here to finally reabsorb a lot more water. And so that's why when you pee out the urine, the osmolarity is again 800 concentrated. So which means the medulla is always going to be concentrated. Which also means if you have a problem in the kidney that affects the medulla, right? What would your urine be? Concentrated or dilute? Dilute, exactly. So if you have if you're making a lot of dilute urine and you want to go back and look at where the problem is in the kidney, it's got to be somewhere in the medulla. Why? Because medulla is where concentrating the urine occurs. And if you can't concentrate it, you're going to pee out a lot more volume. So make sense? Clear? Yes. If you consider the efferent, what will happen to GFR? Because afferent is the door in, efferent is the door out. So you can buy, and if you close the door out, what's going to happen to GFR? It'll increase. Okay.
Excuse sir.
Yes.
Please, what is the function of aldosterone here?
Aldosterone, it's reabsorbing sodium and is reabsorbing water. So as the volume goes through the nephron down the tubule, it's getting more and more concentrated. That's why. And aldosterone works there, which we're going to look at later on again in detail. Any other questions?
Sir, no, thank you.
All right. All right, so if the kidneys are too small, what's the number one cause of any organ not developing adequately? Ischemia, always, right? Ischemia. So which means here too, ischemia from what? Either atherosclerosis, which happens later on, and if it's a younger female, it's usually fibromuscular dysplasia. Usually unilateral. So what do those patients present with? When do you suspect renal artery stenosis in a patient? Hypertension, right? Not just hypertension, usually treatment resistant, because when somebody presents with hypertension, that's not the first thing that you're thinking about, right? You want to start on medication, lifestyle modifications, nothing happens, it doesn't change, it stays very high. Then now think about secondary causes of hypertension. And the most common secondary cause of hypertension is renal artery stenosis. Okay, all right. Usually unilateral. So if it is large enough, or if the stenosis is worse, or if it's the lumen is small enough, when you auscultate, you can hear a bruit, right? And remember, we said this earlier too. What's the other condition where you can hear an abdominal bruit? AAA also, right? And how do you differentiate the bruit of AAA to a renal artery stenosis? Location, exactly. If it's an abdominal aortic aneurysm, it's in the midline. Renal artery stenosis, slightly lateral to the midline. Superior and lateral to the umbilicus usually. So lateral to the midline. Okay, stenosis versus AAA. So they'll all lead to a low volume state. What? Your renal artery is constricted. What happens to blood flow to the kidney? Decreases. Okay. So what do we do? Ultrasound can confirm it. We can also measure renin, right? Because if the renal artery is stenosed, less blood's going to the kidney. What's the kidney going to make now? Renin. We can also measure renin levels, but a Bruy ultrasound is usually sufficient. So that brings us to the very important concept, which you might have heard it many times already, renal angiotensin system. Okay. So let's say that you have a plaque or some narrowing in the renal artery. Okay. Or, so what does that lead to? Low volume to the kidney, right? Remember we said earlier, 20% of your cardiac output goes to the kidneys, right? Now, when you have low volume from whatever cause, Doesn't matter. It could be dehydration. It could be polyuria. Might have gastroenteritis. Could be vomiting. Doesn't matter. Could be renal stenosis. But the end result is low volume to the kidney. So in general, when you have a low volume state, okay, how does your body respond? Or first thing is your blood pressure is going to fall, right? You're going to have hypotension, right? So when you have hypotension, what's the first response in the first 20 seconds? What's the very first thing that happens? 20 seconds. I mean, every time my blood pressure falls, do you think RAS system is going to be activated? It's not. Right. Very first, what happens immediately? That's why when we go from sitting to standing, what happens to blood pressure? What do we think? We don't, because it only happens in the few seconds, right? So you think RAS system kicks in every time we go from sitting to standing? It doesn't, right? But what does kick in is your baroreceptors. So the first 20 seconds of hypovolemia or hypotension, you have the baroreceptors. What are these baroreceptors? They're pressure receptors, right? Where are they located? Aortic and carotid sinuses, right? It responds to pressure. When you have, and primarily these are inhibitory. And what are the nerves that control this reflex? Which one's the afferent and which one's the efferent? 9 and 10. But they are both, they are inhibitory. Vagus, right? It keeps your heart rate low, down. So when you have low volume, cardiac output is stroke volume times heart rate. So when your low volume, your cardiac output is low, your stroke volume is low. We can't increase stroke volume, right? So that's volume. You have to give them fluids. But what can we do? What can the body do? It cannot increase volume, but it can increase heart rate. So how do you maintain cardiac output? Stroke volume times heart rate. So let's increase the heart rate. What do the baroreceptors do? When you have hypotension, you're releasing that pressure. The pressure is dropping. You are removing the inhibition from the baroreceptors, so it will start firing. When it starts, it will inhibit firing, not start firing. It will inhibit firing because you're removing the effect on the baroreceptor. It will start, it will inhibit the firing, and then what's going to happen to a heart rate? Increases heart rate. It shuts off your parasympathetic innervation to the SA node. So now what happens to SA node? It can fire faster, and SA node sets the rate, heart rate. So SA node starts firing, then the heart rate goes up. That's what happens in 20 seconds. So once you're out of the 20 seconds, it doesn't help. You're still hypotensive. What kicks in now? The second thing, not the RAS system yet. So 20 seconds to about 20 minutes. Norepinephrine. Where is norepinephrine made or released? What nuclei in the brain? Well, it's made in the adrenal medulla, released in the brain. Where is it?
Is it the locus ceruleus?
Locus ceruleus, right? It's released from the locus ceruleus. And what does norepinephrine do? What receptors does it work on? Primarily, alpha 1. So what does alpha 1 do? It's a constrict, which means increases blood pressure.
All right. That's about the presence of venoconstriction.
Venoconstricts and vasoconstricts. Yes, it does both. So venoconstriction, what does that do to venous return? It increases venous return. Vasoconstricts increases blood pressure. It kind of does both. No, baroreceptors here, that just responds to the pressure changes within your carotid. Low blood pressure, hypotension itself, because norepinephrine is sympathetic. So when you have hypotension for a prolonged, some more than 20 seconds, now that's actually activating those receptors.
That one directly on the renal medulla, or is it brain detecting?
Both. So locus ceruleus in the brain, but it's actually made in the adrenal medulla. It's released from locus ceruleus in the brain. That's a nucleus that releases it, but it's still made in the adrenal and in the adrenal medulla. So both places, it's there. It goes up.
I'm just wondering where the regulator is. So what's the effect, like, for example, in the baroreceptor, you have that receptor there.
Mhm.
Right?
Right.
What's causing the activation of the release of the body?
So when you also have a low blood pressure, right, there's an angiotensin 2 effect along with it. Not always. Angiotensin 2 comes a little later. So when you have, let's say, a hypotension, right? So our bodies, when you have hypotension, what needs to happen? Sympathetics is how you increase your blood pressure and heart rate, right? So which means, what's a signal for that? Hypotension is a signal for epinephrine release. Hypertension is turning off you can turn off the adrenal gland too, right? So if you have high blood pressure, then your adrenal gland is not making norepinephrine. If you have hypotension, that's a signal for, now specifically what pathway, nothing I've come across as a specific. Correct, yes, definitely. Because it's made in the adrenal medulla, right? So that's alpha 1, yes. Yes, because how is epinephrine made? You need, norepinephrine is changed to epinephrine, right? So the next thing is here, you also need to increase heart rate to maintain the continued increase in heart rate, because norepinephrine then is converted to epinephrine, which can now work on beta 1 to increase heart rate also, right? Epinephrine, correct, because that's dopamine, norepinephrine, right? That's the catecholamine synthesis family. So this is happening in the 20 seconds to 20 minutes. You have norepinephrine working on alpha 1, beta 1, trying to maintain your blood pressure. Now, even after this stage, now you're not effectively maintaining your blood pressure. This is when now the RAS system kicks in. Yes, Abdullah, question?
Sir, can you go over the first 20 seconds again? The baroreceptors, how do they do the inhibitory effect that affects the arterial?
Sure. So vagus is inhibitory to the heart. It innervates the nodes and maintains your heart rate. When you have hypotension, you are removing that signal to the vagus, to the baroreceptor, which eventually will remove that inhibition of the vagus nerve on the SA node. And because you're removing the inhibition, SA node starts to fire faster, and that's increase in heart rate. Is that clear?
Yes, thank you.
So now let's look at the RAS system itself. What's happening in the RAS system? First, we said it's low volume, hypovolemia. Low volume, decreased renal blood flow. And remember we said earlier, if you're low blood flow to the kidney, what cells are activated? JG cells are activated. Okay. And what do the JG cells make? They release renin. JG cells also have sympathetic receptors. What receptors are in JG cell? Beta 1, right? So which means any sympathetic stimulation can actually increase renin. Okay. Where does renin go? Into the blood. Angiotensinogen from the liver. It's converted to angiotensin 1. Yes, question?
Yeah, please, can you go this RAS? Can you go over it again from the beginning, please? I didn't understand how you get the RBF, please. Decrease RBF,
Sure.
renal blood flow, something. Okay.
Renal blood flow. Anytime there is less flow to the kidney or decreased renal blood flow is when the RAS system is activated. All right, so low volume is what activates the RAS system. Let's put it here. Okay. which then activates the JG cell to release renin, which converts angiotensinogen, which is from the liver to angiotensin 1. Okay, angiotensin 1 is then, where does that go? To the lung. And an enzyme released from the lung. From where in the lung? Where does ACE come from? Endothelium. Alveolar capillary endothelium. Right? Because those little branches that supply the alveoli, the vessels, the endothelium releases ACE, converts 1 to angiotensin 2. Now, this is the most important part. Angiotensin 2 is what helps with everything, right? What does that do? 5 functions of angiotensin 2. What's the very first thing it does? So let's throw one more figure here. It's the afferent arteriole, efferent arteriole, GFR. That's filtration. Okay. The whole problem is that we have low renal blood flow, right? So if you have low blood flow, what's GFR? It's directly proportional, right? How much volume comes to the kidney is what determines how much is filtered. Okay. So how can we increase GFR? By either increasing blood flow to the kidney or by decreasing how much goes through the efferent, right? So that means more will back up. So whatever renal blood flow is coming this way, and this here is renal plasma flow, okay? Whatever blood that's coming through here, through your afferent, is split between the efferent and then some goes down to get filtered. Okay. So which means if I reduce the amount going to the efferent, I can increase filtration. Does that make sense? So angiotensin 2, what does it do? Oops. It constricts efferent arteriole greater than afferent. What's the effect? Increases GFR. Okay, that's a first effect. Second, it constricts all blood vessels. Increases blood pressure, right? So 2 effects. Third, what else does it do? It increases aldosterone. So when you increase aldosterone, now you're increasing sodium and increasing water. So that way it affects both blood pressure and volume. Question? Angiotensin 2 does. Yeah, it also does that, correct. So the sodium under the effect of aldosterone is from the collecting tubule, but angiotensin 2 by itself also promotes water reabsorption and bicarb reabsorption in the PCT. Okay. Another effect increases ADH. And ADH puts aquaporins, opens up aquaporins in the collecting tubule to reabsorb just water, right? More water. So that also increases volume. And then finally, it also works on the hypothalamus to increase thirst. So these are the 5 effects of angiotensin 2. Okay. Now, afferent and efferent. Angiotensin 2 constricts the efferent. So what dilates the efferent? Yes. Efferent. Still efferent. ACE inhibitors, just the opposite. Efferent, right? We're talking about the efferent. So constricts the efferent, angiotensin 2, dilates the efferent, ACE inhibitors. How about the afferent now? Constricts, what constricts the afferent and yeah, so let's say dilates and then constricts. Constricts the afferent is NSAIDs. So what dilates the afferent then? Prostaglandins. What else? What else dilates the afferent to increase flow to the kidney? Nitric oxide. What else? ANP. What else? What drug do we use in heart failure to increase renal blood flow? To increase blood flow, to open up the afferent. Yes, online? You were saying something? Who it was? Henrik?
Sacubitril?
Not sacubitril. Neurotransmitter or a hormone. Dopamine. Remember in heart failure, you have, what's the treatment for heart failure? You got cardio? Yes, done? Yes? No? Some did, some didn't. I wasn't talking about whether you've done it, but they did it in class. So when we talk about heart failure, what are the drugs that we use in heart failure treatment acutely? Heart failure. Heart failure, you don't want to use beta blockers. Dobutamine, right? Because it's your beta 1 agonist. You want to increase contractility. You want to push more, right? Beta 1 agonist. What else? That's dobutamine. What else? You also use dopamine. But why do we prefer dobutamine over dopamine? Yes. Correct. Because dopamine, it dilates your afferent, gets more blood to the kidneys. So therefore we can increase renal blood flow. So dopamine used. What's the other reason for not use? What's the danger of using dopamine? It's dose dependent. So if you're not careful, what's going to happen? You may go crazy. Right. So dopamine, dose-wise, it works on all three, alpha, beta, and dopamine. So at low dose, it works on dopamine receptors. The intermediate, then beta, then alpha. So which means low dose, you maintain, you're fine. If you go higher, you can go to beta. If you go to beta, now it speeds up the heart, which is probably bad. But if it goes to alpha, because of vasoconstriction, it's going to make the heart failure worse. So that's why dopamine is not generally used first line, although it is indicated if they have low renal blood flow. Dobutamine is usually used first line. Anyway, so prostaglandins, nitrous oxide, ANP, dopamine.
Excuse me, sir.
Yes.
Please, what example did you give that you mentioned dopamine and dobutamine?
So dobutamine and dopamine both are used in heart failure, right?
Okay.
Dopamine, generally, if you also want to increase renal blood flow, because dopamine dilates the afferent to get more blood to the kidneys, it's better. But otherwise, dobutamine is first line to increase contractility. It's a beta 1 agonist, so it increases contractility, inotropic.
Okay. So please, what's the meaning of RBF?
Renal blood flow.
Okay, and renal. What is the RPF? Renal
Plasma flow.
plasma flow. Okay, thank you.
Yeah, well, we'll talk more about this again later in the nephron. But this is the effects of angiotensin 2, and the RAS system in hypovolemia. Now, ACE, what's the side effect of ACE inhibitors? The most common side effects. Cough, right? It's very common. A lot of people develop cough with ACE inhibitors. But why is that?
No.
Bradykinin, because what's normally, what does ACE do? It breaks down bradykinin, right? So if you have bradykinin increase because of ACE inhibitors, that causes bronchoconstriction and causes that cough, irritation, mucus building up, it doesn't break down, and then you get cough. Okay, that's one side effect. The other side effect of ACE inhibitors, angioedema. Same reason, because of bradykinin. Bradykinin is a vasodilator, so therefore it can cause interstitial fluid leak and cause angioedema. And for that reason, it's contraindicated in those who also have what concurrent condition. Where else do you get angioedema? Hereditary angioedema. What is that due to? C1 esterase inhibitor deficiency, a complement pathway defect. So therefore, be careful or don't give ACE inhibitor to someone who already has a history of that. Can be given together. ACE inhibitors cannot also be given if the renal artery stenosis is severe. So the question is, I'm coming back here. If ACE inhibitors dilate the efferent, right? What's going to happen in GFR? It decreases GFR, right? But then how is ACE inhibitors nephroprotective then? If it decreases GFR, when you give ACE inhibitors. I mean, our whole point is to protect the kidney by maintaining GFR, right? So this effect of decreasing GFR is transient. It lasts about 2 days. What happens eventually is the flow between the afferent, GFR, and efferent, it's all based on pressure gradients. Because when blood flows, what's pushing it forward? The pressure differences between the different vessels, right? So what happens is takes about 3 days for the afferent to respond to that efferent dilation, and the afferent also will dilate a little bit after 3 days. So then GFR is reestablished.
So while this is working, are there other ways for ADH to be increased?
ADH?
Yeah.
Other than?
Oh, like saying one of the benefits is to decrease ADH.
Increase.
Sorry, right? So if you're blocking it, ADH normally go down?
Yeah, it will go down. Correct. Everything, all these will be going down.
My question is there another way for ADH?
What's the number one signal for ADH?
Osmolarity?
Not osmolarity, volume.
That's what I'm saying. If that's the case, when ADH gets stimulated in a couple of days.
If you're blocking angiotensin 2, why would ADH? You're inhibiting ADH because in you don't want that excess volume, right? You're trying to lower blood pressure, right? So do you want volume to go up? You don't. You want the ADH to low, because if you have too much ADH, you're going to be absorbing more water. If you're going to absorb more water, what happens to blood pressure? Goes up. So we want the ADH to stay low. So the number one signal for ADH is hypovolemia, osmolarity also to some extent, and then angiotensin 2, right? Unless now there is a tumor or something that's different, or even lung cancer, right? That's different. But normal physiology, this is it. Okay. Yes.
So the GFR goes down. You're opening up.
Correct.
So that have a back with the afferent.
No. If you're going to open up the efferent, it's going to go forward, not backward. Right? But so that forward flow eventually, when you vasodilate the efferent, what happens to pressure in the efferent? Dilate, decreases. So the afferent will sense that pressure difference and will also kind of dilate to kind of bring it back to original pressure. And that's how it increases GFR and maintains GFR. Okay. Now, because it takes 3 days, that's why it's okay to give ACE inhibitors early onset renal failure or hypertension. So what if they have GFR that's already like in the 25 to 30 range? When you give ACE inhibitors, What's going to happen to the GFR now? It's going to drop further, right? But now the kidneys fail because it is so close to renal failure that it cannot even stand that 3 days where it takes for the GFR to come up. So your kidneys you'll precipitate renal failure. Does that make sense? Because if the hypertension is very severe, or if it's bilateral renal artery stenosis, do not use ACE inhibitors. Because now you're going to actually precipitate renal failure. Okay. So then, treatment-wise, what do we do? Ipsilateral atherectomy and contralateral nephrectomy. Why do we not remove the kidney with renal artery stenosis? Why don't we do that? Okay, let's say that the left side is affected. Okay, so on the left side, what's renin? The RAS system is activated, right? So eventually, what happened to volume? Increased. Venous return? Increased. Cardiac output? Increased. Agreed so far? So that cardiac output now comes back into your aorta. It comes here. Now you increase cardiac output. Can it go to the left side? It can, because that's constricted. If you have a stenotic vessel, can it open to accommodate more volume? It can't, because it's a stenotic vessel. So where will all that excess volume go? To the right kidney. So what happened to the right kidney? It will hypertrophy. Okay. So this is a situation they are in right now. Okay. When you see the patient, this is where they are. So now let's say I go ahead and remove this kidney. Right? What happened to RAS on that side? Gone. Right? So what happens to cardiac output? Because you remove the kidney, there's no JG cell there anymore. No, on the left side.
Oh, what happened to the rest on the left?
Yes. What happened to RAS system on the left? I'm not talking about the right. The left is gone. Right? So now what happened to cardiac output? Decreases. So what happens to renal blood flow to the right side? Decreases. A kidney that's hypertrophic, getting a lot of blood, suddenly gets low volume. What happened to that kidney? Atrophy. So now you're lost both. Correct. So blood pressure goes up. Also. Yep. Does that make sense? So let's say on the left side, you have renal artery stenosis. That means the RAS system is activated. Okay. Now, when you remove that kidney, now you're removing the JG cell also. You're removing the RAS system, which means now cardiac output will fall. All that excess volume going to the opposite kidney suddenly will decrease. So a kidney that has been working hard with excess volume and hypertrophy will now see a lower volume. What will happen to that kidney now? It'll start to shrink. That'll become atrophic. So now this kidney has become atrophic and you've already removed the other kidney. No, because when you remove the RAS system, what was the effect of RAS system on volume? Increase volume. When you remove that, you decrease volume, right? No, you're right. The volume might be normal, but because that kidney was getting a lot more and was used to getting a lot more, that drop will precipitate atrophy. Okay. So what do we do is not only that, now if that flow to the right kidney falls, what will happen to RAS system in this kidney? It will increase. What will happen to blood pressure? Increase. So did it help the patient? No, because he's right back to where he started out with hypertension, right? Yes.
Over time, will brain be able to cause like downregulation of stress?
No, The RAS receptors purely respond to volume
Since kidneys removed, you're also removing the RAS.
on one side.
Oh, right.
On one side. You still have RAS on the opposite side. Because
It's still half the cells.
correct, it's half the cells, but it's responding to the volume it was receiving compared to the volume it's getting now. Right? When the volume changes, the RAS will adjust. So what do we do instead? Now, also remember, this only happens late stage. You're not saying that you do this as soon as a person comes in with renal stenosis, say, let's do surgery. This is when it's uncontrolled and the medications haven't helped, and it's come to a point where the right side is at hypertrophic. So what do we do generally is you remove this kidney because it's hypertrophic to begin with. Given that the left kidney has some function remaining, obviously if the left kidney is also completely gone, you got to do transplant, but this is the stage before that. You remove the opposite kidney, which is hypertrophic, and then you do an atherectomy and put in a stent to keep it open. So that's ipsilateral atherectomy with contralateral nephrectomy. And that kidney here, when we talk about increased volume, all that increased pressure and volume coming to the kidney will happen to the capillary. They start bursting, and that's called your flea-bitten kidney, Goldblatt kidney, right? That's when all these capillaries are rupturing in the opposite kidney. That's what happens. Yes. No, we only do medications. We do medication. So all this happens if medications are not enough or someone presents to you in a very late stage where you have to do operative management, right? It's not always the first step. That's later. So in medications, you do this and then it's transplant. Yes, Abdullah?
Yeah, but if you catch the stenosis where the contralateral kidney hasn't gone through hypertrophy, you can technically save it just by
Correct.
putting it in.
Exactly. Yep, you can.
Okay.
Yep. So this all depends on the severity. That's what I said at the beginning. That's not the first thing you're going to do, right? You're going to start with medications, see if it's controlled. If it's not controlled, it's getting worse. Then you go into surgery, see if you can save at least one. If you can't save either, then obviously you have to do a transplant. Okay. All right, ACE inhibitors. Pearls, all your pearls, captopril, lisinopril, enalapril, renalopril, right? All the ones that end in pearls. Now, if you can't tolerate ACE inhibitors, so they develop cough, what's the alternative now? ARBs, right? Sartans, valsartan, losartan, candesartan, telmisartan. Okay. Out of this, the one with the lowest incidence of angioedema is candesartan. So that's the safest among all those. Now, even if ARBs are not tolerated, or you still want to work on the same axis, what's a third option? That's a direct renin inhibitor. Right, aliskiren. So all three work on the RAS system. You can start with an ACE inhibitor, which blocks the enzyme. You can switch to an ARB, which blocks the receptor, or use aliskiren, which blocks the beginning itself, the renin itself. So nothing else is increased. Okay, time for some refreshments. All right, we'll see you in 20 minutes.
Excuse sir.
Yes,
Please, what do you say about our securing?
it's a direct renin inhibitor. So it can inhibit the JG cells to release renin itself. So if you inhibit renin, there's no angiotensin, there's no aldosterone, you inhibit all of those. All right, see you in 20 minutes, 45.
First, right, then,
Hello, who's in the class? Hello? Hello? Candy Satan. Did they say first? Hello?
That's awesome. I like that. With her meeting.
Let me forget your name. That was- I'm sorry.
Going. Look at the school left. What are we going to do? I think that's just. What are we going to go? Start with this. That actually is.
Can we get a stretch break? Stretch break. We all. Yeah, let's do 5 minutes.
Stand up and see my bottom spread.
Yeah.
No, it is heavy. I mean. Gonna do it. That's what you gotta do. It's important, cardio, palm, renal. Yeah, not that much, but I mean, like, important wise, what's that, cardio is number one. And renal. And that's all medical circuits. Unless you got a biochemistry major in underground support. Otherwise, but you know, the goal is to know enough. You only know everything. And study smart. But yeah, biochemistry is not going to fail. But physiopath farm controls. That's why study smart, make sure you know your physio, make sure you know your path, make sure you know your farm and the mindful. Biochemistry you can buy this. That's right, you do first, and then you do that, then you do form, then you do the things. I mean, you have a postal system, right? What do you have left? GI? You haven't done power? No.
How about you? Like what? Was I dreaming? I was dreaming that I was great. I wasn't in class. It was an out of body experience. I did. I wasn't here. Where was I? When did I do it? You stayed. Yeah. Oh, I think I was having a bad day. Stepped out of my body. I thought. That's traumatic. Depersonalization of your relation. Yeah. And then I came back. All right. Derby Starbucks, since we all love arrows, up and down arrows, right? Because it's kind of like testing your knowledge of the concept. So it's just not very difficult, just a simple test to exercise to kind of prove what we just did about the RAS system, right? So what's going to happen to the axis and the hormones depending upon the situation. So starting with ACE inhibitors. 1, 2, 3, 4, 5, 6, 7, right? 7. So 7 volunteers, not everybody at once. Okay, one at a time. So first one, so go ahead with ACE inhibitors. So we're looking at arrows up or down the entire axis. Well, these are the situations. ACE, when someone's on ACE inhibitors, when someone's taking ARB, someone's taking aliskiren, when someone's on beta blockers, sarcoidosis, Conn syndrome, adrenal insufficiency. Those are the 7 situations. So what's going to happen to all those hormones in each of these conditions? So go ahead, ACE inhibitor. Start with renin and go. You can start anywhere you want, and then just. I'm going to add one more here. Let's just keep adding. How about ADH? Down. Now also remember, these are not all. We can add more things. We can add sodium, we can add potassium, we can do pH. Doesn't matter, right? We can just keep adding. But main thing, what's going to happen based on what? So that's ACE inhibitor. So basically, if you're inhibiting ACE inhibitors, you're inhibiting the conversion of 1 to 2. So anything after that is going to go down. Anything before that is going to go up. I'm going to also add, what about blood pressure? It's going to go down, right? So anything after going down before goes up. ACE inhibitors. All right. ARB. Who's was the second hand? Yes.
ARB.
All right. So does that make sense? We talk about receptors, right? If the receptors are not working, obviously no effects. It's like you might not have had it at all. So anything before that, if there is, even though you have a lot of angiotensin 2, if the receptors are not working, it's not going to increase your aldosterone. It's not going to increase your ADH. Okay. All right. Third one. That's the easiest one.
Aliskiren direct renin inhibitors. So everything will be down.
Everything will be down because you are starting out with renin and there's nothing that happens after that, right? So that's all the 3 medications that we talked about. All right, how about beta blockers? So next, someone else. Yes. Doesn't matter. Selective, non-selective.
I know beta 1 receptors are on the DT cells, right? So beta blocker there have decreased renin.
Which means
Everything else
will go. So remember, whether it's selective or non-selective, doesn't matter as long as it's beta 1, right? So selective ones don't just they don't work on beta 2, but both selective and non-selective work on beta 1. All right, Leslie.
Yes, I have a question with the ARBs. ADH will be high because angiotensin 2 will be high too.
No, angiotensin 2 is high, but the angiotensin 2 receptor is not working. So everything that angiotensin 2 is supposed to do will not happen because the receptor is blocked.
Okay, got it. Thank you, sir.
Okay. All right, sarcoidosis. Come on. Someone. All right, someone take the punch. Be brave. Online? Yes, Pablo.
In sarcoidosis, angiotensin converting enzyme is elevated. So everything after angiotensin 1 is going to be elevated.
Exactly. Right, remember sarcoidosis, the granulomas, what do they make? ACE, the enzyme. So which means there's increased conversion of angiotensin 1 to angiotensin 2. So anything after the enzyme is high. But when you, and then because everything after the enzyme is high, how does it feed back to what's before? We'll turn it off. So renin low, angiotensin 1 low. Yes, Maribel?
Yes, sir. What are we trying to achieve by doing this?
Pass the test. No. So we're trying to look at how in different situations the axis of renin, angiotensin, aldosterone axis is affected. So if you take an ACE inhibitor, how is it affected? If you take an ARB, how is it affected?
Yeah, all right, thank you.
Sarcoidosis, is that like short-lived?
Thanks.
ACE being like elevated, but the angiotensin 1 going down, would that like then just taper off or just go to those?
No, it's continuous. So what happens is, so it's not increased to that extent, but it'll stay at a higher level so as to give you hypertension. So they do have hypertension for that reason. So it'll be maintained. May not get to like what 220, 140 levels, but they will have like maybe 160 or 100 in that
Higher than baseline.
higher than baseline. Correct. All right, Kahn syndrome. High ADH.
Oh, no.
High Kahn syndrome is high aldosterone. So if it's high aldosterone, what's going to happen to renin?
So I was saying 88.
Why?
Everything else was low.
So why is ADH high then? So what's causing the ADH to be high?
Okay, yeah.
Is it aldosterone or is it angiotensin 2 that causes? It's angiotensin 2. But here, if you have increased aldosterone, what would renin be? Low. Angiotensin 1, angiotensin 2. So then what would ADH be? Low. And then if it's, yes. Yeah. Big negative feedback. So if you have too much aldosterone, if you have too much angiotensin 2, then remember in any axis, there's negative feedback.
Question on ADH.
Yes.
ADH is not part of the RAS system, but it still is affected by RAS.
It is a part of the RAS system. It's under the effect of angiotensin 2. Angiotensin 2 increases ADH. Right? So if angiotensin 2 is low, the more ADH be. Low. Now, however, we can argue that a little bit because there's also another signal for ADH, which is low volume. Right? So, but primarily when you look at the axis itself, angiotensin 2 is inhibited, ADH will be low. No, it will be decreased. There's always a little bit happening, right? That's why everything is maintained. It's not like, you know, it's sleeping and then suddenly wakes up. It's always functioning. A little bit is being put out every, you know, as we go through the day. What happens, it can decrease that output because there's already too much aldosterone. So which means now I don't need as much renin. I can slow down the release of renin. Fanta question?
Yes, and I apologize if you actually addressed this already, but for the ARB, angiotensin 2 is increased, but then the ADH is decreased. Is there a reason why?
Correct. Angiotensin 2 is what causes ADH to go up, correct? However, how does angiotensin 2 work? It works through its receptor. Now, if you're blocking the receptor, it's like you don't have it, and that's why ADH is low. Is that clear?
Thank you. Yes, thank you.
Yes. Yes, so here, when you look at the axis, it's renin, angiotensin 1, angiotensin 2, which increases aldosterone and which increases ADH. Okay, but when we look at Conn syndrome, you're beginning with the adrenal problem, you already have increased aldosterone. If you have increased aldosterone, now how does that, there are two ways you can look at ADH. If you have increased aldosterone, how is that affecting renin? Decreasing it. Then what happens to angiotensin 1? Then angiotensin 2. So if your angiotensin 2 is low, how does it affect ADH? That's one way. The second reason is aldosterone, what does it reabsorb? It can happen that way too, because you have reabsorbing more salt and water. Do you need ADH? You don't. So that's a secondary effect. You can look at it that way also. Okay. And the last one, adrenal insufficiency. The opposite. There's no adrenal gland working at all. So where do we start? Aldosterone. What's going to happen to aldosterone? Low. So which means the axis is activated. Everything else is activated. Now you tell me what happens to ADH. It increases. Exactly. Does that make sense? So yes. So it wouldn't normalize. You will still have increased sodium, right? ANP, correct. ANP will kick in to get rid of some sodium in water. But remember, our body's mechanisms for compensation are always only to a certain extent. It will never bring it back to normal. So no matter what, that kind of goes across the board on any compensatory mechanisms. Our body will not compensate to perfect normal or overcompensate. It will only try to bring it better, close to normal, never normal.
I understand there's like how would I if there if any.
So anytime there is increased volume, ANP is always working, right? That's again a given. That's our body's compensation too. If you have more volume in your heart, venous return is increased, you are releasing ANP, right? That's always working. So that's why a person, for example, I'll give a perfect example is Conn syndrome. Do they have edema in Conn syndrome? No, I mean, you expect hyperaldosteronism, you expect edema, correct? Because you're retaining salt, you're retaining water. What's happening to hydrostatic pressure in your vessels? Increases. So what happens to fluid? It's being pushed into the interstitium. You should have edema, correct? But we don't. And sodium is near normal. Why? And that mechanism, there's actually a name for it. It's called aldosterone escape, right? So that's what you're talking about. So your body kind of adjusts for sodium. So that's what, to some extent, that's why most of the time in Conn syndrome or hyperaldosteronism, you don't see edema and you see near normal sodium because of that reason. So you're correct, but when you talk about compensation, it's near normal. It's not like 100% exactly the same as it was before. But also remember, it's a range, right? So it could be high normal to low normal, or like 145, it could be 147, something like that, in that range, near normal. Through the loop. So when we talk about the nephron, in the loop of Henle is where you're reabsorbing sodium, potassium, and chloride. Okay, so what happens is when the urine comes through the loop, if you already have a lot of sodium, so what happens is that in that loop where you're supposed to reabsorb sodium, you don't. Because it senses that there is a lot of sodium coming in the urine, which means that there should be a lot of sodium in the body. So what happens? That reabsorption mechanism in the loop will kind of slow down and limit the amount of sodium that's pulled in. And as a result, you end up peeing out more sodium. That's why the sodium remains normal, and you don't really see edema or near normal sodium in those situations. And that mechanism is called aldosterone escape. Okay. All right, is that clear? The axis? Any questions? Yes.
First, these syndromes are affecting ADH.
No, not ADH, because ADH, although it's under the ADH is primarily by volume, right? So if you have too much ADH, syndrome of inappropriate ADH secretion, what's going to happen to your volume in SIADH? Remember, yeah, initially you're increasing it, right? But then same effect as A and P with euvolemia, right? It's euvolemic hyponatremia. So that way it doesn't, this axis will not always respond to AZ. To some extent, yes, because it's euvolemia, it kind of stays the same. Because renin system is activated by volume system. We talk about small kidneys. Now, what do you have larger kidney? What are the different causes why you have a larger kidney? Polycystic kidney disease. And there are two other conditions which are very rare, medullary sponge and medullary cystic kidneys. Now, based on what we talked about, in medullary sponge and medullary cystic kidney disease, what would the urine be? Everybody said? Medulla, what happens to the medulla? Concentration of urine. So if you have a medullary sponge kidney or medullary cystic kidney, whether the medulla has a lot of holes or cysts and it's not able to concentrate urine, what will the urine be? There we go, right? So medulla is affected in those conditions. So you can actually say in both these conditions, you have a very dilute urine. Polycystic are two types, adult and infantile. The adult is autosomal dominant, bilateral. And sad part is all of them will develop hypertension and all of them will get renal failure at some point, right? The other risk with autosomal dominant polycystic kidney disease is what? They can also die from aneurysmal hemorrhage, right? Subarachnoid hemorrhage, because they have aneurysms in which vessel? Anterior now. It used to be posterior, now it's anterior across. It can occur in both, but more commonly it's still anterior communicating artery. So, yes.
I'm saying it says in posterior communicating.
Yeah, this is the older slide. So it could be in anterior or posterior. Anterior is still more common across the board, okay? All right, so if you have a subarachnoid bleed, someone who has an aneurysm that ruptured, what will they come to you complaining of? The worst headache of the life, right? That's them complaining. What else can you see on a physical exam? Subarachnoid. They can have seizures, sure.
I don't know how to say it in English, but
Meningeal signs. Meningeal signs, they have neck stiffness, right? Because it's like meningitis. So it'd be a differential for meningitis just because of irritation of the meninges. There's a subarachnoid bleed. So meningeal signs make you suspect meningitis, but what might you see in meningitis that you don't see in subarachnoid hemorrhage? Fever, simple fever, right? Because it's a meningitis, they're going to have high fever. But subarachnoid, it'd be sudden and sudden severe headache, and it's occipital headache. So even the location, occipital headache, meningeal signs or neck stiffness. So what do you do next? Always CT scan, right? Always CT scan. However, non-contrast. However, subarachnoid hemorrhage, half the time CT is normal, but you still think it's subarachnoid hemorrhage. What do you do next? LP, lumbar puncture, exactly. So you do a CT. If you see it in CT, you're done. You're good. If you don't see it in CT and if you still have a high suspicion, the next step is going to be a lumbar puncture. When you do a lumbar puncture, what do you see in lumbar puncture? Xanthochromia, right? The separation of legs, yes.
The only reason why you do the CT, irrespective of bleed being there, check for mass
Mass effect and also bleed. You don't know if it's an intracranial bleed, but it's an extracranial bleed, right? So depending upon you want to identify that.
But in the subarachnoid hemorrhage,
It's not extracranial, extraparenchymal. Extraparenchymal, right? Because that might give you a little more time as compared to treatment as compared to an intraparenchymal bleed where Yeah, it's emergency and there's not much you can do anyway if it's a massive intracranial bleed. But intraparenchymal bleed. All right, so you do a lumbar puncture as anthocomia. Now, yes. So that's also why you should never do a lumbar puncture before you do a CT, right? Always, because you want to make sure that there is no herniation. Because if you miss a CT and you go directly to lumbar puncture and it becomes a vegetable, then you'll be poor very quick. So yeah, can't do that. So then in subarachnoid, once you know it's subarachnoid bleed, what should you administer first, medication wise? Before. No. Calcium channel blockers, right? Why? What do calcium channel blockers do? Which calcium channel blocker? Imodipine, the vasospecific ones. Because anytime there's a bleed, what's going to happen? What's your body's response to reduce the amount of blood that's lost? Vasoconstriction. But brain is not the place you want all the vessels to vasoconstrict. So if you prevent that reflex vasoconstriction, give them imodipine, and so that the rest of the brain is still perfused, and then you can use what you call, if you have intracranial pressure mannitol, but otherwise you have to actually, it's surgical management, right? You'll go in and do something called endovascular flipping or coiling of that vessel. That's usually definitive management for that. Anyway, that's adult. Infantile is autosomal recessive, unilateral, but these children will eventually develop hypertension and renal failure. So all of them, it's a pretty bad state because eventually you're going to need some transplant or something later. So medullary cystic kidneys, a lot of cysts in the medulla. So what's going to happen? Polyuria, right? Because it's going to be lots of dilute urine. You cannot concentrate the urine. They'll be in a low volume state because they're peeing out all that urine, which means they'll also get thirsty, the polydipsia. And then occasional kidney stones because it changes the concentration of that urine that can lead to precipitation, kidney stones. Similarly, medullary sponge, they have holes in the medulla. Same problem, polyuria, polydipsia, low volume, and kidney stone. So they are both very similar in presentation. One, they have cysts in the medulla. The other one, they have holes in the medulla. Both will lead to inadequate concentration of the urine, so dilute urine. Okay, rare conditions. All right, so now let's talk about aneurysm. Sudden severe abdominal pain. Differential. Somebody presents with sudden severe abdominal pain. What are the few things you think about? All the top conditions. Pancreatitis, peritonitis, kidney stones, appendicitis, a lot of different conditions. AAA, right? Diverticulitis, all depending upon where the pain is, which quadrant is located. Left lower quadrant, diverticulitis. Right lower quadrant, appendicitis. Epigastric, pancreatitis. Right upper quadrant, cholecystitis. Left upper quadrant, what's that area? Why do you have pain in that area? What happened to you? Well, okay, what else? What's the other condition where you have acute mesenteric or abdominal angina? Mesenteric ischemia, because remember, where is that watershed area? Left upper quadrant, right? So anytime you're hypovolemic, ischemic, what's the area that you get pain first? Flexure. So based on the quadrant, it can vary, right? So those are the most common in the quadrant. Now here we talk about kidney stones and aneurysm for us, pancreatitis, ischemic bowel in GI. Kidney stones. So no, we talk about AAA first, then we go to stones. Most common cause, atherosclerosis. Most common cause of that, hypertension, which caused by? You climb the ladder, where does it go to? Smoking, right? So that's why. When do we screen for AAA? At what age? No, not that young, older. 65. But who gets screened? Only males. with a history of smoking. So males at 65 with a history of smoking, that's when you do an ultrasound, one-time ultrasound to look for AAA. 90% of these aneurysms occur below the renal arteries. It's a good thing, right? Because it occurred above the renal arteries, you would lose your kidneys also. So because it occurs below the bifurcation, at least the kidneys are not affected. But what can it lead to? It can lead to other issues. So when would you suspect a AAA in a person? What are some presenting signs or symptoms or complaints in AAA? When it dissects, pain to the back, right? But it hasn't dissected yet. You just have an aneurysm. So you won't have any pain at that point. But what will they be complaining of? You can hear an abdominal worry or a mass. Pulsating mass, yes. Okay, that's fine. Anything else? If you're an aneurysm, right? What's going to happen if blood flow is an aneurysm? Increase, right? So what about blood flowing through it? Decrease. More blood there. So what will be distilled to the aneurysm? What's going to happen to blood flow? Yeah. Extremities, exactly. So low pulses in the field in the feet. Not only that, they can present with claudication, right? Low blood flow. They can complain of erectile dysfunction, right? Because beneath the aneurysm, there is low flow. So all signs and symptoms of low blood flow beneath the level of the aneurysm, right? So that's where you can talk about erectile dysfunction. They can have claudication, low pulses in the feet, all those kind of stuff. Yeah, let it be low bilaterally. So that's how you know, and it's equal on both sides, but it's low bilaterally. That's how you know it's not a single, yeah, it's not TAO, but it is more an aortic issue.
Based on anatomical location.
Yes. Yeah. Nourish. That's yeah, what you call, because of ischemia or low blood flow to your genitals, sexual dysfunction from that, and they'll have what's the other one? Radiofemoral delay, right? The radio pulses will be fine, but your femoral pulses will be slower. They won't be together because blood's not getting there, right? Ankle brachial index. So that you look at blood from the upper limbs and blood from the lower limbs again. Try to see if they are equal or there's any delay. If there's a delay, that means that blood's taking longer to get to your peripheries. Okay. All right. Now, when this aneurysm begins to tear, that's when you get the sudden severe pain. No, this pain, yes, Abdullah, question?
Yeah, is this one option where you could get bilateral artery stenosis if it's above the renal artery?
Well, you don't get renal artery stenosis, but you'll definitely get low renal blood flow. Because renal artery stenosis means the renal vessel itself is stenosed. It won't lead to that, but it will lead to low renal blood flow for sure, and ischemic kidneys. Okay. So let's say this is an aneurysm. So if within that aneurysm, what about blood flow? Increase, right? How about pressure? So when all that pressure pushing on the walls of the aneurysm, eventually what's going to happen? All that friction, the wall's going to separate. It's going to open up. That's when you get the pain. That ripping, tearing pain is the dissection that's happening. And this pain is epigastric and radiates to the back. So two pains, epigastric that radiate to the back, either AAA or pancreatitis. So radiating to the back, epigastric pain is either one of these two. Okay. So when it dissects, it's when you get that pain, right? That's why we screen the aneurysm. Why are we screening them? If we catch it, we're going to monitor it, we're going to manage it. The other presenting problem with this is they all have hypertension. Okay, so we want to control the hypertension because what's eventually going to cause it to rupture is that increased pressure. If you don't maintain the blood pressure, it's going to eventually rupture. You want to maintain that blood pressure. Now, once it's already dissected, now that's more of an emergency kind of situation, right? So our goal is to prevent that dissection from happening. So once we diagnose it, we look at, all right, how big is it? And we manage them based on the size of the aneurysm. If it's small, less than 4 centimeters, we follow if it's progressing or not, and we manage the hypertension. If it's greater than 5.5, now that's a risk of imminent rupture. We don't want that to happen, you got to do surgery. If it's between 4 to 5.5 centimeters, then we can kind of like look at the situation, monitor it closely, and also see if there's any coexisting or comorbid factors. Somebody who's diabetic, somebody who is hyperlipidemic, maybe you might probably consider surgery because they had an increased risk of it getting worse or progressing. So based on the size, we decide what to do. Okay? 4 to 5.5. Yes.
Anytime that you have dissection, you usually go to surgery.
Dissection, you have to go to surgery because now it's ripping, right? You have to correct that because it can go into shock and other bleeding and other issues. Now, aneurysms in the thorax, thoracic aorta, 2 types of aneurysm. So we're talking about abdominal aortic aneurysm, which is in the midline, right? Thoracic aneurysms in your thorax with the thoracic aorta. The aorta comes out of the left ventricle. Okay. Now there's type A and type B. Type A is the proximal part of the aorta, and type B is the distal part. Type A aneurysms, so they both present with ripping pain, chest pain, radiating to the back. So one of the differential for sudden severe chest, what are the differential for sudden severe chest pain? MI, dissection, chest pain, or angina, right? Angina, dissection, or MI for sudden severe chest pain. Okay. Now dissection, like I said, it could be proximal or distal. Most common causes of proximal aneurysms are your collagen vascular diseases, Marfan's, so they have an aneurysm, Ehlers-Danlos, syphilis, Takayasu, the pulseless disease. Those are all affecting the proximal aorta, right? Type A. Type B, most common is trauma. Most common, number 1 is trauma for type B. Why? Because and where does that dissection usually happen? In this area, right? Why is that it happens in that area? Why does it happen at the isthmus? Not only that. Yes, when our ductus arteriosus, right? When it shrinks, what does it become? Ligamentum arteriosum. And that is attached to the isthmus. So which means when you have a decelerating injury, when you move forward, that part of the aorta is held back, where the rest of the aorta moves forward. And that's why the isthmus is the most common location for that tear to happen in trauma. Other causes are your hypertension, diabetes, hyperlipidemia, or for type B, right? So collagen vascular disease for type A, trauma and other risk factors for type B, most common, okay? So in type A versus type B, something else that can also be seen in type A dissections is when you dissect, it kind of happens towards the ventricle, like goes from, it's like unzipping, right? Goes from top to bottom. How far can it go? What's here that can also be affected? The aortic valve. So these patients who have proximal aortic dissection also present with a new onset murmur. That's another clue for that. Along with them having tamponade along with murmur. So what will be the murmur of? Aortic regurg. What's murmur for aortic regurg? Yes, pulse. What's the murmur? It's diastolic. Could be blowing. Decrescendo, right? So decrescendo, diastolic, decrescendo murmur. It's a new onset. So didn't have it before. Why now? Coming with chest pain. That's what happened. That dissection has gone on to affect the valves also. And obviously they'll also have this blood collecting in your pericardial space that can lead to tamponade, right? All that for dissection there. Okay. Now, if they do have dissection, what's the diagnosis? Or how is it diagnosed? A CT, a spiral CT. Okay. So what do we do? If you have, yes. Yes, pericardium is around the heart. When the aorta dissects or ruptures, that blood's leaking out into the pericardial space around the heart, and it gives you top of that. So this is where, when you have dissection, right? Once you have dissected, is it an emergency or an urgency situation? You have hypertensive emergency and you have hypertensive urgency. When dissection has happened, is it urgency or emergency? It's always emergency, right? Which means you have to bring the blood pressure down quickly. If it's urgency, then the difference is you have time to bring the blood pressure down. Because it's happened over a period of time and no end organ damage, so take the time to bring it down. Urgency, you got to bring emergency, you got to bring it down immediately. But the other question is, let's say he had 220 over 180 blood pressure or 160. When you drop that blood pressure, can you bring it down from 220 over 140 to, let's say, 160 over 100 quickly? Why not? You reduce perfusion to pretty much all organs. Because if you have that high of a pressure for a while, every organ has a higher perfusion pressure, which means when you drop it so quick, all perfusion pressures go down and every organ can get low blood flow. Most important one being the brain. Okay, so you want to bring it down. Usually 25% is what you bring it down by in the first hour, right? If ever a question comes up, by how much? 25% of the blood pressure. Right. So the next question is, how do we bring this blood pressure down in an emergency? So what are those antihypertensives that can be used in a hypertensive emergency? There are multiple drugs. So name a few for me. Yes. Nitroprusside. But what's the side effect of giving somebody nitroprusside? And everybody said cyanide poisoning, but that's not what I was asking for. That's not what I wanted. Yes. Reflex tachycardia, right? Cyanide poisoning, yes, but that's if you give continuously more than 12 hours, yes, you can get cyanide poisoning. But immediately when you give somebody nitroprusside, what are you going to look out for? Because you're dropping the blood pressure, their heart rate can go up, reflex tachycardia. So to prevent that, you can also co-treat with beta blockers, right? Nitroprusside. Give me another drug used in hypertensive emergency. Labetalol, most commonly used. Another one, hydralazine. Another one, alpha methyl dopa, but not usually used in unless they are, yeah, we have pregnancy or something like that. Okay. Anything else? Yes, you're right. So dopamine, there's something called phenol dopam. So that's a dopamine agonist. Yes, Leslie.
Sorry, was not meant.
Dipines. Yeah, go ahead, answer.
Phenoxybenzamine.
Correct. Well, you use the phentolamine, correct. Dipines, clevidipine, nicardipine, you can use those. Those are your vasospecific calcium channel blockers, and phentolamine, alpha-1 blockers. So these are all options for treating an emergency. Now, all of these will be IV drugs. Okay, so that's why it's important, any of these. You can't give them a regular oral drug and expect the blood pressure to fall quick. So we want to give, these are all IV medications, all right? Any of them are okay. You'll only have to look for any contraindications where they can take it, but otherwise, generally, they should all be fine, okay? So it can be used in urgency or emergency. The only difference, same medications. The only difference is how fast you bring down the blood pressure. In an emergency, you bring it down faster. In an urgency, you take a little longer to bring your blood pressure down, all right? All right, now to the ureters. What does the ureter develop from? No. Ureteric bud, it's in the name itself. Ureteric bud, okay? Ureters. So the ureters got three narrowings. The first narrowing is at the hilum. Okay, this is the uretero-pelvic junction, pelvis of the kidney. Okay, then the mid-ureter, there's a narrowing, and then uretero-vesicular junction, there's a narrowing where it enters the bladder. So why is this important? Because this is where the stones, when you develop stones, they're going to get stuck. Could either be at the larger stones, the largest opening is the uretropelvic junctions. So the large stones will get stuck here. Which one is the largest stone? True white stone. Those are the, so if you have a stone that's stuck at the hilum of the kidney, 90% of the time it's going to be a true white stone because that's a larger stone. The smaller stones will go into the ureter, can be at the mid ureter or at the uretrovesicular junction. Okay, so now let's look at, we talked about the ureter bud, narrowing stones, kidney stones.
Excuse me, sir.
Yes.
Please, can I go to the last slide, please? I'm trying to get the junction. Please, can you explain it again, where the stones got stuck up?
Yeah, it could be at the pelvis of the kidney, the uretropelvic junction. The larger stones get stuck there. It could be in the middle of the ureter because that's where the second narrowing is. Or it could be at the uretrovesicular junction where the ureters enter the bladder, where the third stone is. I mean, another place where it can get stuck, right? All these are narrowings of in the ureters.
Okay.
Kidney stones. What are the different types? What's the most common cause of a kidney stone? Cause, dehydration, right? What's the most common type of kidney stone? Calcium. What's the most common cause of calcium? I mean, it's still dehydration. Outside of dehydration, what are some other causes of calcium stones?
Okay.
Hyperparathyroidism. Yeah, kidney stones are also, these calcium stones are also formed in alkalotic urine. So anything that changes the pH of the urine can precipitate different types of stones. Henrik?
The tumor syndrome?
Not calcium stones. That's a different kind of stone.
Sorry, yeah.
So hyper PTH. Hyper vitaminosis. Which vitamin? D, because it absorbs calcium. And another condition we talked about earlier in regards to ACE. What other condition do you have? Hypercalcemia. Sarcoidosis, right? They also have hypercalcemia, so they can lead to stones. Sarcoidosis, hyperparathyroidism, dehydration, number one, hypervitaminosis, D. Okay. Most common type, calcium stones. It could either be calcium phosphate or calcium oxalate. So what's the shape of these stones? Yeah, they're either dumbbell shaped or envelope shaped. It could be either envelope shaped or dumbbell shaped. And so that's from hypercalcemia, right? So there's also another condition where you precipitate stones because there is more calcium in the urine, not in the serum. Serum calcium is normal, but these individuals, they excrete more calcium in the urine. So it's a hereditary condition where you have hypercalciuria, right? With normal calcemia, which means there's more calcium in the urine. So if you have all this excess calcium in the urine, what's going to happen? It's going to clump together and cause a stone. Not Bartter syndrome, no, not Bartter. Bartter, this is hereditary hypocalcemic hypercalciuria. Bartter is different. That's later on in the tubules. Okay. So hypercalciuria. Now the difference is generally when you talk about stones, what's always first line? Fluids, along with pain. Pain first, right? Because it's very painful. If anyone had kidney stones, it's very painful, right? So analgesia, IV fluids, and then if based on the size of the stone, if it's small and you want it to pass by itself, then you want to give them something to facilitate the stone to pass through your sphincters. So there is when you give them alpha-1 antagonist because they relax your sphincters, urethral sphincters, your urethral sphincter, they can relax it. You give them alpha-1 blocker so that they can facilitate passage of that stone if it is small. Okay, so again, management is based on size there too. So these are the most common type of stones, calcium stones. Okay. Now for hypercalciuric stones specifically, what's the treatment? Thiazides, right? Not for any kind of stones. Specifically for hypercalciuric stones, use thiazide. Because what do thiazides do? They pull calcium out of the, not calcium wasting. They actually pull calcium out of the urine. The opposite. Calcium wasting means it puts calcium into the urine. So here it actually pulls calcium out of the urine.
Oh.
Yeah, no, calciuric, right? So remember when we talk about diarrhea, what are the side effects of thiazide? Hypercalcemia, right? Because it pulls calcium from the urine and puts it into the blood. So we are kind of using that as a benefit when you have hypercalciuric stones. All right. Second type of stones, screw-white. Who gets screw-white stones? Infections. In what kind of infections? Urease positive organism. Protease is a number one, right? Yeah, there's a big list of urease positive bugs, but most common is protease. Yes, Fanta, question?
Yeah, sorry to take us back a little, but for the hypocalcemic hypercalciuria, what is a clue, like in a vignette, that would point us towards thinking that is the diagnosis?
They have calcium stones, but their calcium is, serum calcium is normal. Or they have a family history.
Okay, okay, thank you. And
those
would
were
they
the-
usually present in childhood as well, or not necessarily?
Not necessarily, not necessarily.
Okay, thank you.
Screw-white, they're also, what's the shape? Stag, horn, calculus, triple phosphate stone. These are all different names for the same stone. What's it made of? Calcium, magnesium, ammonium, phosphate. Okay. Urease positive. So here you treat the infection along with giving them fluids, giving them painkillers, also treat the infection. Okay.
What was the most common infection?
Protease, right here. This is number one. Any urease positive UTI can cause stag on stones. Number one is protease. So then you treat the infection along with treating the stone. Third type is uric acid. Now this is the one that's associated with tumor lysis and gout. You have excess uric acid in the urine. Other cause of what precipitates uric acid stones is low pH. So we talk about calcium is in an alkalic urine. Okay. Protease or screw-white is also in an alkalic urine. Okay. Two stones that are precipitated in alkalic urine. And there are two that are precipitated in acidic urine. One is uric acid. The other one is cysteine, which is coming up next. Okay. So uric acid stones happens in tumor lysis when someone's on chemotherapy. So how do you prevent uric acid stones in someone who's taking chemotherapy? You give them xanthine oxidase inhibitors, which are allopurinol or not respirogase, febuxostat. There is, but if you are going through tumor lysis and making a lot of stones, yeah, you can give respiratory acid. Respiratory acid breaks it down. So basically, that's after the fact. After you form the stone, you're helping break it down and dissolve it. Whereas allopurinol febuxostat, it prevents. Yeah, but this is used actually to prevent tumor lysis. Yeah, like, I mean, it does have like renal side effects and other issues, but hopefully you're not using it for in long term. When you pre-treated it and then give chemotherapy. But yeah, if there's a question, that would be a correct answer, to prevent. So it depends on what the question is. If it's asking to prevent, then respiratory will not be correct because it's after the stone's formed. Okay. Yes.
Something like probenecid or uricosuric acid.
Yes, I mean, that's not generally used. These are, we stick with like either prevention or respiratory case. That's the current treatment regimen. Respiratory case. Now, the other thing is normally if you suspect a kidney stone, what's the imaging of choice? You can start with an X-ray. You always start with an X-ray. KUB, exactly. But only problem is if they have a uric acid stone, you can't see it on an X-ray. So then you have to do ultrasound or even a CT is best for uric acid stones. And the other question is, if uric acid stones are formed in an acidic urine, okay, what's the most common location in the nephron where uric acid stones are formed, precipitated? Again, you need to know the location. Where are these stones formed in the nephron? Or which part of the nephron is basically the most acidic? I mean, yeah, cortex medulla is a little, that's broader. Well, I want the nephron, part of the nephron. PCT, loop, DCT, collecting tubule. What is it the most acidic? At the very last. Because remember, what's the pH of urine, normal pH of urine? It's acidic, 4.5 to 5.5. But where does that acidification happen? In the collecting tubule. Remember, where the aldosterone dumps all the hydrogens in there? So the acidification of urine happens mostly in the collecting tubule. So if a question is about where are uric acid stones normally seen within the nephron, where are they precipitated, it'll be in the collecting duct or collecting tubule, because that's where the pH is very low, because it precipitates in an acidic pH. Okay. The other kind of stone is cystine stone. This is the other one that's precipitated in an acidic pH. Cystine stones too. Okay. Now, this is due to malabsorption. What is it made of? Cysteine, or the other amino acids, cysteine, ornithine, lysine, and arginine. So there is a malabsorption of these amino acids in the nephron. What's a condition called? Where there's amino acid transporters affected in the PCT. Homocystinuria, correct? Okay, there's a lot of things written. Other than that, Fanconi's syndrome, not anemia, syndrome. Because PCT, correct. Fanconi's syndrome is where there is a problem with amino acid transporters in the PCT. That means you have more of these in the urine, can precipitate cystine stones. Now, what are these stones, or what do they look like? Hexagon. The coffin lid, which one is coffin lid? Yeah, the struvite stones are coffin lid. Calcium stones are dumbbell shaped or envelope shaped. Struvite stones are coffin lid. Uric acid, they're actually, what's the shape of uric acid stones actually? It's rhomboid. Okay. Uric acid stones are rhomboid, and then cystine stones are hexagonal. Right, that's cola stones. And the last one is oxalate stones. This is also due to malabsorption. Normally, what happens to oxalate? What is it bound to? Calcium, right? But what if there is not enough calcium to bind to oxalate? Then oxalate will precipitate by itself. Why is there not enough calcium to bind to oxalate? Hypocalcemia, Marbel?
Yeah, so please, I want to know raspberry case. What is it? What is it used to treat for?
For uric acid stones. It breaks down uric acid stones.
Okay, what about coffee lid? Where is this in?
Tumor lysis syndrome. Or
Okay,
gout.
thank
you. Yeah, why is there no calcium? Where is all this calcium getting stuck? Saponification. So if you have fat malabsorption, right, calcium gets stuck in that fat. So which means there's not enough calcium for binding to oxalate. So which means if someone who presents with a child who's presenting with the oxalate stones, what do you want to test for? What's the most common cause of malabsorption?
Fatty liver or something.
Cystic fibrosis, CF, in a child who presents with a lot of oxalate stones, rule out cystic fibrosis. What if it's an adult? If it's an adult, you think Crohn's. Celiac, yes. So basically malabsorption, you're looking at most common. So celiac or even CF, Crohn's, where there is malabsorption of fat, so which means calcium now gets stuck and precipitates in fat, oxalate is free to crystallize by itself and you get oxalate stones. So that's why if you have a lot of the stones, you want to check for a malabsorptive condition. Now, another condition where someone is in the ER, when you do a urinalysis, you see a lot of oxalate crystals in the urine. What condition would that be? Yes, ethylene glycol poisoning. So antifreeze, somebody who drank a lot of antifreeze. So that's another clue for ethylene glycol overdose or poisoning is oxalate crystals in the urine. When ethylene glycol metabolizes, it becomes oxalic acid, and then that precipitates as oxalate crystal. So that's a clue for that. These stones can also be hexagonal shaped. All right, so how do we manage kidney stones? Based on the size. If it's less than 5 millimeter, this is where you give them fluids, pain medications, and an alpha-1 blocker like tamsulosin to relax the sphincters and let it pass. Once the stone has passed, you collect it and then you send it for analysis to find out what's it made of. Okay. If it's between 5 and 1 millimeter, it's large, but not that large, you try to break it down. And that's how where we do lithotripsy, you're delivering shock waves to kind of break down the stone so that it can be passed naturally. And if it's large, greater than 1 centimeter, open laparotomy. Because based on where it is, it can also cause other problems, like if it causes reflux, back up, can lead to hydronephrosis, can lead to pyelonephritis, sepsis, and all kinds of problems, right? So that's why we might have to do an open laparotomy to remove that stone. And if it does lead to pyelonephritis, then you have to put a percutaneous stent, because if you have pyelonephritis, do you want all that to, you remove the stone and you want all that infection to go through your ureters into the bladder? You don't. You want to avoid that. So you have to put a stent, a percutaneous stent to remove that, to drain that pus, and then treat with antibiotics and such. So if you have pyelonephritis, right, what kind of antibiotics would you use? Someone's in the hospital for pyelonephritis. What's your number one antibiotic? That's more for like UTI. Yeah, ciprofloxacin. Because this is going to be IV antibiotics now, right? Quinolones will be first line. Even ceftriaxone is okay. Because now he's developed severe pyelonephritis and requires IV antibiotic treatment. Kidney, ureters, bladder. So just the X-ray. So when you order an X-ray, they order a KUB just to make sure that you catch all three in the picture. And usually an X-ray is enough. But sometimes if the stones are really small and you want to get an accurate measurement, a CT is better. So you can actually get a size and the exact location, and if it's a smaller stone. Because if it's a larger stone or a small stone, an X-ray may or may not pick it up. No, you for which one? No, you actually remove the stone. You open up the ureter. Yeah, you open up the ureter or wherever it is stuck and then remove the stone. Yeah. Right, the ureter enters the bladder posteriorly and inferiorly. Okay, the bladder is made up of smooth muscle, right? They have the detrusor muscle, and bladder it's activated, or the contractions of the bladder is parasympathetic, right? So what kind of receptors will be on the bladder if it's parasympathetic? Muscarinic. So they have M3 receptors, and because it's smooth muscle, what other receptors will be there? Beta 2 and beta 3. Okay, so M3, beta 2, beta 3, and on the sphincter, that's where you have alpha 1, right? So all those receptors are relevant when we talk about the bladder, because these are receptors we are also going to target when we treat different causes of incontinence. So alpha 1 on the sphincter, M3, beta 2, beta 3 on the muscle. Okay, yes. Yes, the internal urethral sphincter is alpha 1. External urethral sphincter is nicotinic. That's parasympathetic. That's voluntary, correct.
There's no,
No, no, we don't. Yeah, we don't work on on the voluntary. All right, so that's how the bladder contracts. Now let's see what we talked about next. Hydronephrosis. What's hydronephrosis? Urine packing up into the kidney, right? What's it due to? In the newborn, malimplantation, where the ureters, rather than going posteriorly, inferiorly into the bladder, it's implanted somewhere else. So now that can cause backup into the kidneys. Second one, in male infants, it is newborns, posterior urethral valves, causes reflux. When you go slightly older, in children, it's chronic UTIs. Now, UTIs, what can it lead to? Fibrosis and scarring. So that's the actual cause. In older adolescents, it's strictures, but here it's from STIs. Strictures means there's narrowing, right? So that can also cause backup. Adult males, prostatic enlargement. Remember, prostate has the prostatic urethra, right, going through it. So prostate is right here, right? The prostatic urethra that's going through it can compress that and cause backup. And in adult females, the uterus can prolapse and compress on the urethra. Similarly, a bladder can prolapse and push on the urethra, causing backup. Now, how do you know it's a cystocele? When you do a vaginal exam, if you have a bulge and the anterior vaginal wall, that's the bladder that has prolapsed and is pushing. So a bulge on the anterior vaginal wall is a cystocele. A bulge on the posterior vaginal wall is a rectocele, okay, depending upon location. So that also can cause compression of the urethra and lead to backup, lead to hydronephrosis, right? STIs, most common, chlamydia, gonorrhea, and actinomyces. So how do we treat each of them? Chlamydia, what do we treat? What's a drug of choice? Yeah, doxy or azithro. How about gonococcal infection? Ceftriaxone. And if it's actinomyces. So actinomyces is not very common. Penicillin. It actually affects who gets actinomyces infections with IUDs. It usually affects, yes.
Oh, I was going to ask with gonorrhea, do you do like dual antibiotic case also?
Not anymore.
Not anymore.
No, it's just one for culture. Actinomyces usually affects IUD. So someone has a IUD placed, and then they get infected. It's most likely actinomyces. Now, this is a gram-positive organism, and it's spore forming. That's why it sounds like a fungus. It's a spore forming gram-positive organism, and that's why we treat it with penicillin. Okay, so chlamydia, gonorrhea, and actinomyces. These are your STIs. Chlamydia and gonorrhea are the more common. Actinomyces is pretty rare. Okay, so just remember the treatment for it.
Excuse me.
Yes.
Please, did you say that actinomycin is not a fungi, that is a gram negative or what?
Gram-positive bacteria.
Okay, so what is the IUCD? What does it do?
IUD is intrauterine devices, and actinomyces infects those IUDs. It grows on the IUD, basically. Okay. PPH, most common cause of urinary obstruction in adults, males. It compresses the prostatic urethra. So what do we want to do? Two things, either relax the sphincter to help the symptoms, and number two is to help shrink the prostate. So we talked about that earlier. For sphincters, what's a receptor we are trying to antagonize? Alpha 1, right? So tamsulosin alpha-1 antagonist. And then we can also use finasteride too. What's finasteride? 5-off reductase inhibitors. We use that to kind of shrink the prostate. If both don't work, then we can do a transurethral resection of the prostate. Surgery lasted. So that's BPH. Yes. You kind of like break it down and take it piece by piece. Prolapse, we talked about prolapse, uterine prolapse. Who gets it? Who are at the risk for this? Multiparous women, large babies, right? Diabetic moms who have large babies, macrosomia, estrogen connection, because what does estrogen do to all your muscles? Relaxes. So the pelvic floor gets weaker and then it prolapses. For that, you know, the definitive treatment is surgery to strengthen the pelvic floor. What's that? These are risk factors and causes. Yeah, I mean, why would somebody get uterine prolapse or even a bladder prolapse, right? Because the pelvic floor that holds these organs up kind of becomes very lax and then it just pushes down. Hydronephrosis, if it's unilateral, what's the most common cause? A kidney stone. If it's bilateral, it could be a kidney stone. But another cause of bilateral hydronephrosis is both the ureters getting fibrosed. When does this happen? In retroperitoneal fibrosis, where both ureters are affected. Now, both kidneys, you're going to see hydronephrosis. Okay, if it's usual, that's very unusual, right? Because if you have a kidney stone, it's usually unilateral. Now, what puts you at a risk for retroperitoneal fibrosis? With this surgery, you should not use anymore. Nitrofurantoin. Where do we use nitrofurantoin? Treatment of UTI. So side effect of that. The other drug that can also lead to retroperitoneal fibrosis is your ergot. Where do we use ergots? Migraine, treatment of migraine. So those are the two medications that can lead to retroperitoneal fibrosis. Which one?
How often are you using in order to have
Chronic, like chronic UTIs. Someone's using nitrofurantoin for a long time, right? No. Even ergots, right? That's migraine treatment. So it's a chronic condition. So you have to use it chronically and not from a few days of use. Another risk factor for urethral injury is abdominal surgery, right? Especially uterine surgery, ovarian surgery. So that's another reason, another time where they can nick the ureters accidentally and can lead to hydronephrosis unilaterally, right? That's a third cause, pelvic surgeries. Bladder, how does it develop? So there's something called the urachal cyst. So urachus is a connection between the bladder and the umbilicus. So you have a kid brought in by a mom who says that there's always something dripping out of his umbilicus. Yellow colored fluid dripping out of the umbilicus. What is that? That's urine. And why is that? Because that urachus, which was supposed to disappear, stayed on, and then there's a connection between the external environment and the bladder, and you see that dropping. And this is due to a persistent, what's that called, is the allantois. Remnant of the allantois. That's what forms a urachus or urachal cyst. Treatment is surgery because you don't want an open tube from the outside to the bladder, right? What's going to happen? What's going to go in? Infection, sepsis, all that kind of stuff. So you don't want that to stay open. That's a urachal cyst. So just some embryological abnormality. Similarly, there's something called the extrophy of the bladder. This is where you can actually see the bladder. The abdomen, it does not close around the bladder, pushing the bladder inside. The bladder stays outside the abdomen, and the abdominal wall just goes to the side. So the bladder is actually exposed. Again, here too, it's an emergency surgical procedure, and it also puts you at increased risk for bladder cancer. Okay. Which one? No. It's not growing somewhere. It's just that it didn't go all the way in. It's still there. Right. I mean, it because it's exposed, right? So there's more irritation, and then eventually it can turn cancer. There's a higher risk of cancer later on in life. Yes. Question, Ryan?
Yes, for the extrophy of the bladder, doesn't this coincide with also hypospadia? Or is it
Epi. Yeah, it can also be seen with epispadias. They occur together. Epi is when the urethral opening is on the ventral surface, on top. Okay. All right, I think we'll take lunch because I don't want to start. Stop. No. All right, 1:15. Don't be late. 1:30. How about 3:55?
Please, 120, please. 120. 120.
All right, we got a lot of important stuff to cover. So like I said, the afternoon is the most important part of the lecture. All the physio stuff. Yep, the nephron, right? That's the most exciting part too. 1:15, 1:20, somewhere in that range.
That's the one that raised.
I've been in this situation. Also. I wish that.
Oh, yeah, real.
Yeah. No.
All right. Lunch? Really good?
Did you have?
Too short?
Too short.
Oh,
Too what?
too short.
Oh.
What did you eat? For an hour and a half.
We're really good.
Oh, you're also counting the time it takes to digest. I think some you want to. Anyways, so going back, we've got a bunch of stuff to do. So starting out with incontinence. Right, so when somebody comes to you and talks about, you have some symptoms that points towards an incontinence. So what your first question to yourself is, what do I need to do, right, to help them? So it's two situations here, whether you want to help them to pee or not to pee. I just wanted to say that.
That's amazing. That's really good.
Excuse me, please, I have a question, please.
Yes.
Please, you said that cortisol and androgen, they are from ACTH, and the aldosterone, is it from where?
Renin.
Okay, thank you.
Sure. All right, so because incontinence, it could be a problem that there's too much, or things are leaking, or there's too little, and then you're overflowing, right? So even though it's incontinence, you're not always addressing the same issue. So treatment might be to help them pee or to kind of reduce, right? So now we talked about receptors earlier, right, on the bladder. What were the receptors that we talked about on the bladder? The receptors on the bladder. Muscarinic, beta 2, beta 3, and alpha 1 on the sphincter, right? So how are these receptors? How do we work on these receptors to help get to where we need to, right? So 2P, if it's muscarinic receptor we are going to attack, what do we need to do? Antagonize it or agonize it? Agonize it. M3 agonists. So what are some examples of M3 agonists? Bethanacol, something that its brother, carbachol, right? Bethanacol, cholinergic, right? Bethanacol is the cold part is cholinergic. So bethanacol and carbachol. Okay. Now, similarly, now if you're going to work on beta 2, what do we need to do? Agonize it or antagonize it? If it's beta 2. Because what's a normal function of beta 2? What does it do? In your blood vessels, in your heart, it relaxes smooth muscle. So when you relax smooth muscle, are you going to pee or no pee? Not pee, right? Muscle is going to relax. So which means if you want them to pee, we have to antagonize beta 2. So those would just will be all your beta blockers. Because beta 2, it has to be non-specific beta blockers. Well, we don't use it for that purpose because there are other drugs available. But theoretically, that's what we want to do if beta 2 is what we're going to address. Beta 3. So beta 3 works mostly on the other side. So let's not talk, there's no beta 3 antagonist yet, at least for our purpose. And then alpha 1. And where is alpha 1 seen on the bladder? On the sphincter. And when we activate alpha 1, what's its normal function? Constriction, right? Vasoconstriction, sphincter constriction. So which means here, if you want to help them void, what do we agonize it or antagonize it? Antagonize it. Alpha 1 antagonists. And what are those drugs? Yes, all those zosins. Prazosin, tamsulosin, doxazosine. So these medications, any of these medications will help them mature. Okay? Now, on the other side, not to be, it's the opposite. M3 antagonists. What's an example of an M3 antagonist? Most common. Atropine. Another one. Tolteridine, yes. Oxybutynin. Commonly used, right? So those are M3 antagonists to stop. How about beta 2? Agonists. What would beta 2 agonists be? Albuterol, terbutaline, Ritodrin, right? Any asthma drug actually. Albuterol. Now here beta 3. Beta 3's action is similar to beta 2's action. Beta 2 relaxes smooth muscle. Beta 3 also relaxes smooth muscle. Right? So which means when you use beta 3, you're relaxing the detrusor and you are preventing that flow. And what's the beta 3 agonist? What's a beta 3 agonist? Mirabegron. It's a beta 3 agonist. So when we talk about incontinence, we're going to also refer back to these drugs to see which one is used for which incontinence. But the general basic understanding is based on how it works. And that's why this is important. See what receptors do what normally. So that way, even if you don't know specifically, you know, you can, okay, what receptor do I need to address to either help them to or not to? Okay. And then alpha-1 agonists. What will be some examples of alpha-1 agonists? Ephedrine, phenylephrine. So that's why, where do you see these in ephedrine, phenylephrine? What kind of medication do we generally see this in? Two medications or what you call antihistamines or cold medications, right? So that's why, you know, one of the side effects of these medications is what? Urinary retention. So that's why an older person who had a cold went to the pharmacy, bought some over-the-counter medication, took it for a cough and cold. You know, a week later, they've been taking it. A week later, they come in with urinary retention. What is that? Because of that. Was that a question?
Yes, I had a question. Yeah. So the urinary sphincter, I thought when it contracts, you urinate.
No, urinary, it's a sphincter. Sphincter is at the outlet. So when you're constricting, you're closing the door.
Okay, that's why I was confused on why would you give.
See, look here, if this is a bladder, and then you have the urethra. The sphincter is right here. When you constrict it, you're actually closing that door. Okay.
Okay.
Excuse sir.
Yes.
Please, is it alpha-1 agonist in not that causes urinary retention?
Correct.
Thank you. So what's the difference between beta 2 and beta 3 for not to pee?
Yeah, so they are two different receptors, but they have the same action. Beta 2 activation causes relaxation of the muscle. Beta 3 activation also causes relaxation of the muscle. So basically, if you want to inhibit, then you can actually work on either use a drug on beta 2 or you can use a drug works on beta 3. It's just two different receptors, but with the same end outcome. Okay.
Okay.
And there are, like I said, there are no beta 3 antagonists that we know yet. So that's why we don't have anything here. Okay. So this is generally how you approach, how do I treat or how do I address incontinence? Now let's look at all the different types of incontinence. Normally, right, after you void, what should be left over in the bladder? It's about 50 to 100 cc's. So if you have complete voiding, when somebody has voided, this is how much will be left over. If you have more than 100 cc left over after normal maturation, that means you're not voiding completely, right? You have, I don't know, some kind of a problem. And that's why we actually measure this in some cases of incontinence for helping us with the diagnosis. We measure what we call post-void residual volume. If it's greater than 100, it points to overflow incontinence. Other two doesn't affect overflow incontinence because there's too much left over. All right, so now let's look at the different types of incontinence. Urge. Urge means what do they complain of? They want to go all the time, right? Every half hour. Anytime a little bit of volume collects in the urine, collects in the bladder, they have the urge to go, right? It could be due to uncontrolled contractions of the detrusor or spasms of the detrusor. Now, what would cause that detrusor or any muscle to go through the spasms? Hypernatremia. That's in general more likely to fire, but not when it comes to muscle. Muscle, what electrolyte is with muscle? Calcium, right? But in general, when we talk about spasticity, right? We talk it in terms of a neuronal issue, nervous system issue. What kind of issue would it be? Causes spasticity. Upper motor neuron stroke. UMN, right? Stroke, your upper motor neuron and lower motor neuron. If it's an upper motor neuron, you get spasticity. If your lower motor neuron disease, you get flaccidity. Upper motor neuron means your muscles are going to be spastic. So here, the detrusor is also going to be spastic. There, you feel like you want to go again because the detrusor, it's not waiting for the signal that the bladder is full to contract. It's just randomly getting those signals and you're going to contract. Okay, capacity is low. So how much can you hold if you're going all the time? Little, right? The capacity is also decreased because even with a small increase in volume, you want to go to the bathroom. However, the sphincter is fine because alpha 1 sphincter, no problem with that. It's the detrusor, the muscle that the problem is. So what do we do when we look at this list? Which category of medications will we use? Not a trick question. I know, lunch on your mind. Pee or not to pee? Not to pee, right? So any of those medications can be used for treatment. So what is first line if you're a kid? Imipramine. Why imipramine? What kind of drug is imipramine? It's a TCA. What do we use that here? Because what is another side effect of TCAs? They are anticholinergic, right? So that side effect of a TCA, the anticholinergic property of the TCA, can be used in children. Or oxybutynin. We just said it's an M3 antagonist. Atropine, oxybutynin. We can do M3 antagonist. Or what's a third medication that can also be a first line here, medication-wise, from that list? Which one? One of the other ones. So another treatment here is your beta-3 agonist. Okay. So treatment for urge incontinence, medication-wise. If it's an adult, you look for oxybutynin or you look for mirabegron. If it's a child, imipramine. But that's medication. However, since this is a spastic bladder, we can also start with conservative, which is what you call bladder training exercises. How do we do that? So usually have the patient urinate very frequently and then try to kind of increase that duration. For the first few days, every hour, then every 2 hours for the next few days, every 3 hours for the next few days, and then every 4 hours. Normal frequencies about for most people is every 4 hours. Okay, so we kind of like do the bladder training exercises first, and then we use one of those medications, either oxybutynin or mirabegron in adults or imipramine in a child. That's urge incontinence, spastic bladder. Stress incontinence. Stress is because what part of the bladder is affected if it's stress? What kind of stress are we talking about? Stress for the USMLE? Or that too, right? Or what other kind of stress? Pressure, right? When you cough, when you sneeze, when you laugh, when you sit, go from standing to sitting, all right? So that stress incontinence. Why does that happen? Which part of the bladder is a problem from all what we talked about? The sphincter is a problem because that's a muscle, right? So it's become lax. And that actually the sphincter is part of the smooth muscle itself. So which means anytime the smooth muscle is relaxed, There we go. The sphincter also becomes relaxed. Under normal circumstances, it's fine. There's enough pressure to hold the urine in. But anytime pressure, intra-abdominal pressure increases, now there's not enough tension within the sphincter to hold it closed, and then you leak a little bit. Okay. So actually, true story, I'm not joking, in Champagne, this actually happened when somebody was taking the USMLE. That's what I said. So they had an accident, and it happens. So because what happens when you're in stress? What's first firing? When you're in stress, parasympathetic and then sympathetic, right? So if you're not careful with your parasympathetic, if you're not ready for that parasympathetic kicking in when everything is tight, what's going to happen? Oops, right? But I'm oops movement. So you go to the USMLE, you say, okay, you read through all the instructions and say, all right, I'm ready for it. Let's go start. Question 1. Oh, there you go. Parasympathetic kicks in. And then if you're not ready, So actually what happened that the center had to be shut down middle of the test. Everybody who was writing that day had to leave and redo it because it's a biohazard now. Right? Yeah. And then they had to shut it down. So I'll turn on the mic and say this. So let's say, there you go. Let's say that the test is not going well. I never said that. Huh? All right, so any increase in abdominal pressure will cause sudden loss of urine. But here, the detrusor is fine. The muscle is fine, right? It contracts adequately. But the sphincter is not tight enough to hold everything in, and then you lose it. Okay? Sphincter pressure is decreased, capacity is normal. So here, what do we want to do now? Strengthen it. What's the first thing? What's the first advice for a person with stress incontinence? They're usually seen in older women because of the estrogen connection to there, right? Because you have more estrogen, and then what happens to all the muscles because of estrogen? Relaxes, you may have sphincter also losing some pressure. So the first step is to strengthen. So what do? Kegel exercises first. Then we can talk about medications and all after that, and then surgery. Now, one group of patients or people you're going to say this is obese, right? Why obese? Because they have a lot more estrogen, right? So one of the first line there also should be to address that, and weight loss should be also included in that treatment regimen. Now, we also want to tighten the sphincter, right? So when we talk about tightening the sphincter, what receptor are we trying to address there? Alpha-1, agonist or antagonist? Agonist. So that's where ephedrine or pseudoephedrine or phenylephrine can be used to tighten up the sphincter or to increase that pressure. So that's stress incontinence. Overflow. The overflow can also be referred to as neurogenic bladder in some situations. Overflow can be because of a mechanical obstruction, right? Mechanical obstruction, BPH, typical example. It shuts off the urethra. Now you're not emptying your bladder all the time. It kind of fills up and starts leaking. This is where we are always going to look for post-void residue. Because if it's more than 100 cc after a normal emptying, that means you're not really emptied completely. Okay? Detrusor activity is decreased. So your muscle is not contracting adequately. This would be a lower motor neuron stroke in that context. Okay. Sphincter pressure is increased because the bladder is hyperextended, putting more pressure on the sphincter. Because there's difficulty initiating a urine stream, a weak stream, dribbling, urgency, frequency, all that kind of stuff. So if it's an obstruction, you want to surgically correct it. What are the different causes? In newborns, posterior urethral valves. All those different causes of hydronephrosis that we talked about earlier is the same causes. Okay? Or if it's a neurological issue, diabetes is a very common cause, because diabetic neuropathy can cause the detrusor muscle to not function adequately or contract adequately, can get overflow. So treatment here would be cholinergic, agonists. So basically, this is a lazy bladder. So we want to help it contract. Okay. So those are the 3 different types of incontinence and how you treat them. Now, to put them all into a chart, if the bladder capacity is normal, detrusor function is normal, and sphincter pressure is decreased, what kind of incontinence is that? 5 seconds. Stress incontinence, because what's the clue? Sphincter pressure is decreased, so that has to be stress. Bladder capacity is increased. Boom, you should have the answer now. Overflow, right? Irrespective of what the rest of it is, it's going to be overflow. Increased bladder capacity, decreased detrusor function, sphincter pressure is increased. And then finally, for urge, bladder capacity is decreased because they got to go all the time, so that you don't hold much urine. Detrusor function is hyper, so it's hyperactive detrusor, but the pressure on the sphincter or the sphincter itself is fine. See? Those are 3 different incontinences and the pressure differences, right? Yes.
Other than botanical, what are the drugs for?
Carbachol, botanical, that's the number 1, first line. Cholinergic agonists. Basically, any cholinergic agonist would work, but those are the ones that we use, especially in like post-operative urinary retention after post-anesthesia. It's the same thing, right? Because the detrusor, all the muscles are relaxed, so we want to kind of jumpstart it, or help it contract, or even cholinesterase inhibitors are fine too, because you're trying to increase acetylcholine, so they would also do the same effect. I mean, you don't use it, but yeah, theoretically they can also work. Yeah, that's a treatment of choice. Yeah. Urethra, it develops dorsal to ventral, fuses from the tip to the base of the penis or clitoris. So some abnormalities in development there. Hypospadias, it results from failure of fusion of the urethral folds. Okay, they fail to fuse, or they fuse in a abnormal plane, so you have the urethral opening at the base. It could be all the way back, all the way by the anus too. So that's how far back it can go. It has to be corrected surgically immediately. So this is hypo. Epi, we said earlier, usually what was the condition epi was seen with? What was the other extrophy of the bladder? They kind of occur together. So that's due to a mallocation of the genital tubercle, epispadias. Whereas this is hypo. Circumcision usually done for cosmetic purposes. Some people say there's UTI reduction and penile cancer reduction and all that. But if at all you do it, it should be done ideally within the first 48 hours. In the pediatrician's office itself, you can do that. Okay. Right, some other inflammatory problems, phimosis and paraphimosis. Both of these happen due to repeated STIs. Because there now, when there's infection and then there's scarring and there's healing, there's fibrosis, and they kind of, the skin stick to each other. If it's phimosis, the skin is adherent to the head of the penis. And then if it's paraphimosis, it is to the base of the penis. It's both because of STIs and then scarring. Okay, and this is somebody that needs to go see a urologist. Some other infections, balanitis. That's infection of the head of the penis. Most common cause is Staph aureus. If Staph is the offending bug, what's the drug then we use? Penicillins, ox, clox, diclox. So oxacillin, cloxacillin, dicloxacillin. So those are all oral drugs. If you need IV, you can go nafcillin. Okay. Then urethritis, someone presents was burning on urination. Dysuria, with or without a discharge, right? UTI, sure, or it could be an STI. STI, we talked about it, it's the same bugs and the same treatment. Okay, so chlamydia or Neisseria, and rarely actinomyces. So chlamydia and Neisseria should be the most common. So dysuria, urethritis. Okay, so they usually have a cloudy, milky discharge along with burning and all that. Then you suspect urethritis. STD treatment, we talked about azithromycin or doxycycline. If it's chlamydia, if it is gonorrhea, cephalosporins. Other infections, cystitis. So you have simple UTIs. Then there is cystitis. And then there's pyelonephritis. And then there is prostatitis in males. Okay. All four conditions, what's the number one cause? All four, what's the number one cause? E. coli, right? Followed by Proteus, followed by the same for all four, whether it's UTI, whether it's cystitis, whether it's pyelonephritis, or prostatitis, which also means treatment is the same or similar with minor differences. Okay, so in general, how do you separate cystitis and pyelonephritis? Cystitis, you have urgency and frequency without any CAS in the urine. So remember, even in oncology, I think we talked about if there's a problem in the kidney, you're going to see CAS. If there's a problem in the bladder, you're not going to see CAS. Right? So cystitis, urgency, frequency, no CAS. Pyelonephritis, you might have urgency, frequency with CAS and what else? Flank pain. Right? Cystitis is suprapubic fullness or suprapubic pain, whereas if it's flank pain, it's pyelonephritis. Right? And since it's the same causes, infection-wise, here too, for cystitis, what's the treatment? Can you use nitrofurantoin, ampicillin. Pyelonephritis, remember we said earlier, what's the number one drug for pyelonephritis? Quinolones. Ceftriaxone. Or you can use also ampicillin sulbactam. Yes.
Did you have constitutional symptoms in patients with cystitis?
Sure, yeah. It's an still infection, right? So you'll have fever, you'll have pain. What else? What other symptoms?
Oh, I mean, fever, malaise and stuff, but I always thought that pyelo had more.
Pyelo has more because pyelo is more septic, definitely. It's much more severe, right? So fever also, you talk about cystitis, yeah, you might have fever, but maybe a low-grade fever. Pyelo might have a high-grade fever and the pain, and they're more sick generally in pyelo, especially if it is if it's requiring like IV antibiotics. That means they have to be hospitalized because there's simple pyelo where you can treat outpatient too, because they still have pyelonephritis, but they're not toxic. They're not that sick. So that is usually seen in outpatient. They can treat with oral antibiotics, but they are in that septic range, very high fever, what you call lots of pain, dysuria, pus, and all that. Then you have to admit them and treat them inpatient. Okay. All right, now let's get into a little bit about casts. So there are different casts in the urine, right? Casts, where are casts formed? They're the tubules, right? As urine is going through the tubules, that's where they precipitate. So which means if there is a cast, the problem is within the kidney. It cannot be, before the kidney, it cannot be after the kidney, it has to be within the kidney, right? And casts also give us a clue as to what the actual problem is or what the diagnosis is. Sepsis and pyelonephritis, what kind of cast? White cell cast. If it's interstitial nephritis, what kind of cast would you see? Eosinophil casts. And interstitial nephritis usually is from drug allergies. And they have eosinophilia. So what are the different causes of eosinophilia? There is a mnemonic for that, right? For increased eosinophils. Anytime you say increased eosinophils, what's normal eosinophil count? Less than 5%. In the differentials, when you do differentials, to be less than 5% should be eosinophil. So if you have 10%, that means it has to be one of those conditions. So what are those conditions? Somebody said parasites, neoplasm, and somebody said allergy. or even asthma kind of go together. And then you have two more, another A and a C. The other A is for Addison's disease. So adrenal insufficiency and collagen vascular diseases. So like Ehlers-Danlos. Okay. But even in this, these three are the most important. Allergy, asthma, Addison. So a lot of times, eosinophilia, when you don't think it's an allergy or asthma, nothing like that in the question, but you might see some adrenal issues, hormonal issues, will go cortisol, low blood sugar, and then they have eosinophils always go to, it could be adrenal insufficiency. So that is also a clue for adrenal insufficiency is eosinophilia. And then finally, parasites. If you see a red blood cell casts, in general, what's the condition? Glomerulonephritis or vasculitis. So all causes of glomerulonephritis, it's usually vasculitis in a bigger picture. So that's where you see red cell casts and hematuria. Okay, glomerulonephritis. I think there's another slide. Yes. So white cell casts, nephritis. Red blood cell, glomerulonephritis. Eosinophils, interstitial nephritis. Fat or lipoid casts, nephrotic syndrome. Waxy casts, renal failure. Hyaline and epithelial casts are normal. Remember, what part of the kidney is the most, functional? PCT. So that means there's always the cell size sloughing off and rapidly dividing cells there. So thus, hyaline epithelial casts are just normal wear and tear, normal findings. And then we have muddy brown casts, or other way to describe them, granular casts, right? Muddy brown or granular means acute tubular necrosis. So basically those are also dead cells, necrosis, right? Necrotic cells that have clumped together and gives you that muddy brown appearance. Brown cast, or sometimes called granular casts. And finally, crescenteric or crescents in the urine. That's from nephritic syndrome, but RPGN specifically. Could either be good pastures or Wegener's. So those are the two conditions where you see crescent. So these casts also gives you a clue as to what the etiology is of their renal disease. Okay. All right, so now let's, I don't know if you're waiting for, but we are here. Let's talk about the nephron, right? So this is the most important part, because what happens, everything happens in the nephron, right? We need to look at what are the different things that happen in the nephron. So we kind of briefly touched on this earlier. Afferent arteriole brings in blood, renal blood flow. Afferent is renal plasma flow. Then you have GFR, which is what goes through the glomerular membrane, gets into the PCT. Okay. And remember, we said there are two ways you can get into the PCT, right? Either it gets filtered or it gets secreted, right? So here, this purple, is secretion, because if you follow the arrow, it's coming into the tubule, right? So that's secretion. And what's going back into the efferent, that's reabsorption. And what's coming through the glomerulus is filtration, right? So everything ends up in the PCT. So it can either go through filtration, which means the glomerular membrane has to be, permeable, it has to be normal, the charge has to be fine, everything needs to work intact for that, for blood to be filtered. Then those that are not filtered will go through the renal plasma flow in the efferent arteriole and then get secreted. So what was that we said is secreted for the most part? PUN. And what was filtered for the most part? Creatinine. Okay. So when we want to look at the filtration function or GFR, if you want to calculate GFR, which one would we use? Creatinine, right? So that's why we calculate something called the creatinine clearance. Okay, so creatinine clearance will give us an approximate GFR. And how do we calculate the clearance? So there here, there are three equations that you have to remember, and you can be asked to calculate these to kind of identify if there is a problem or not. So any clearance of any substance is the same equation, whether it's sodium, potassium, magnesium, BUN, creatinine, doesn't matter. It's just a clearance equation for any substance. So what does that clearance mean? It's talking about based on how much the kidney received, how much of it is removed per unit time by the kidneys. So if I get X amount, how much of it is actually removed and how much of it stays in. That's what clearance actually means. So clearance of any substance, here we are just going to talk about creatinine, is urinary concentration of creatinine multiplied by urine flow rate, which should be given, divided by plasma concentration of that substance. So whatever the substance is can be substituted. It's urinary concentration multiplied by flow rate, which is, per second, how much of our urine is, how fast urine is going through, divided by what's left over in the plasma. So you can calculate anything by that. So this will give you an indication of your GFR. Now, creatinine is 80% filtered. Okay, so even though we say it's completely filtered, it's about 80%. 20% is still secreted. But because it's 80% filtered, that's why we look at that to understand GFR. But there is something else that is 100% filtered. What is that? Inulin, exactly. So between inulin and creatinine, which one is more accurate for GFR? Inulin, because it's 100% filtered. Similarly, BUN is most of it is secreted. There's still some filtration, but most of it is secreted. Similarly, there's another substance that is also primarily secreted, which is PAH, para-aminohippuric acid or hippurate. So instead of looking at BUN and creatinine, we can also give them PAH or give them inulin and measure its clearance. So PAH and inulin are exogenous compounds that need to be given to the patient and then measured in the urine to calculate clearance. So inulin clearance or PAH clearance will also give you the same data as for creatinine clearance and BUN clearance give you, right? So that's one equation. The next equation is filtration fraction. Okay, fraction. So if I get, let's say we said 2 liters of blood that's reaching the kidney, right? About 20% of your cardiac output. Let's say it's 5 liters cardiac output. No, 20% is 1 liter, right? So 1 liter is reaching there. So out of this 1 liter that gets there, how much of it is actually filtered? So that's a filtration fraction, the proportion or the percent of it that's filtered. How do we calculate that? Is GFR divided by renal plasma flow. Okay, you calculate GFR, we can actually use creatinine clearance. If they want to give you really nice math problems, yeah, you have to calculate GFR, you have to calculate RPF, then you put in a filtration fraction. Another way to look at RPF is 1 minus hematocrit. So even if they don't give you RPF, but they give you hematocrit in your lab values, you can use that to calculate RPF, right? So those are the 3 equations to remember, and you might have to calculate it depending upon the question. Okay, all right.
Excuse sir.
Yes.
I have a question.
Mm-hmm.
Please, why is this renal blood flow always on the afferent and the renal plasma flow always on efferent?
Afferent. What does afferent mean? It's coming to
something,
right? Afferent. Whether we talk about afferent artery or afferent nerve, whatever. When you talk about afferent, we talk about something that's coming to that structure or organ. So that's renal blood flow because blood is coming to the kidney. Efferent means it's taking away from that organ or structure. So that's why blood's leaving or going away from the kidney. That's efferent flow.
Okay, I mean, so is it tied to renal plasma flow, efferent? Correct,
yes. Efferent arteriole, efferent and afferent, they are vessels. What's in that vessel? In the afferent artery, it's blood, renal blood flow. It's coming to the kidney. In the efferent, it's plasma flow because now you have already filtered the blood and the plasma, whatever was left over, is going through the efferent.
Okay, so another question, what do you say about BUN and also GFR on this the diagram?
GFR can be calculated using the values for creatinine or creatinine clearance.
Okay,
BUN can be calculated, or the renal plasma flow can be calculated using BUN, or you can also look at BUN clearance. So that indicates secretion. When you're going through the efferent, it's secretion, and when you go through the GFR, it's filtration. Okay.
thank you so much.
Mhm.
Oh,
All right,
thank
so
you
those are a
so
few
much.
equations. Now, for this to happen, you have the Bowman space, you have the Bowman's capsule, and this is a glomerular filter or artery. Yes. It's a blood vessel because it's what it does is when you reabsorb, right? So these are called your peritubular capillaries because they go along the tubule, the descending limb, ascending limb of the tubule. So these kind of right by the side of it. It needs to be next to the tubule because whatever you're removing from the tubule, that's where it goes into. When you say reabsorption, it's going into peritubular. Then what does that have? What does it do? This then connects with your venous capillaries, right? And then the venous capillaries, and those are called by the loop, that network of capillaries, those are called vasa recta. Okay, they collect to the venous capillaries and then they go back to the heart. They reach the inferior vena cava and then take it back to the heart. So that's how it's staying within the blood itself. Yes, because we don't filter them, right? We only filter the blood. We don't filter the cells. Because what is the difference between blood and plasma? Right. So when you say plasma, what has been removed from the blood? So blood contains everything, right? Plasma is part of it, where you have the proteins, you have the cells, you have the all those things, right? So are you filtering the blood's RBC, the cells? Are you filtering WBC? Are you filtering platelets? You're not. So that continues to go on. That's that plasma bond. Okay.
Can you explain the arrows again? The ones that go RNS?
Sure. So once you filter the blood, it gets into the PCT. Now in the PCT, now at this stage, that has water, that has your electrolyte, that has sodium, that has potassium, that has chloride, magnesium, everything is still in the tubule. But if you don't take it back into the body, you're going to pee it out, right? So that process by which it's taken back into the blood from the tubule is reabsorption. And that's why it goes from the tubule to the blood vessel. That's reabsorption. And then BUN is a toxin. It's a waste product. We don't need to keep it. And that comes through the efferent and goes into the PCT, into the tubule. That's why the arrow is this way. It's secreted into the urine. Reabsorption, you're pulling out of the urine. Secretion, you're putting into the urine. And then eventually, whatever is left over is excreted.
Thank you.
All right, so going back here, this is a glomerular capillary, okay? In every compartment, there are some pressures that either aid, help, or oppose movement of fluid, right? So what are the two pressures within the capillary? Hydrostatic pressure and oncotic pressure. Hydrostatic pressure is from the fluid, whatever fluid, whether it's blood, fluid, doesn't matter, whatever fluid. Oncotic pressure is from protein, okay? Similarly, even in the Bowman space, there has to be two pressures, right? So what would the oncotic pressure in the Bowman space be? It should be 0, because do proteins go through the vessel? It does not filter. So this is pretty negligible, right? So when we look at, there's something called net filtration pressure. Okay, how is that calculated? By the two pressure. So hydrostatic pressure is what, if you have increased hydrostatic pressure, what does it do to fluid? It pushes it out, right? It aids filtration. But if your oncotic pressure is high, how does it affect filtration? Against it, because proteins, what do proteins do? They attract water or fluid, they pull. So which means if you have too much oncotic pressure is pulling into the vessel. And then hydrostatic pressure is also going this way. So the pressure here has to be higher than the pressure here in the Bowman space. And that's how the net filtration pressure is approximately 8 milligrams of mercury, right? Plus 8. That's approximately net filtration pressure. So if that 8 becomes 12, what's going to happen to filtration? If that 8 net filtration pressure, 8 becomes 12, what's going to happen to filtration? Increase or decrease? Increase, right? Because you have increased the pressure to filter. On the other hand, if net filtration pressure goes from 8 to 4, what's going to happen to filtration? It decreases, because you need at least that 8, positive 8, plus 8. That's your net filtration pressure. Okay, so let's say that you have a condition. What condition? Let's say cirrhosis, right? What happens in cirrhosis? What's the problem in cirrhosis? They don't make enough protein. So which pressure is affected? High or low? What happens to GFR? It increases. Does that make sense? That's too fast. Yes. So if you have cirrhosis, as an example, the problem in cirrhosis is that body is not making, liver is not making enough proteins. No proteins, what pressure is affected? Oncotic pressure, right? Will the oncotic pressure be low or high if you don't have protein? Low. And we also said proteins hold on to water, right? So if I have proteins here, your kidneys or your filtration barrier here, if I don't have protein here, which way will fluid go? This way or this way? Up or down? Down, because there's not enough protein to hold it in. So GFR will go up, more going towards the kidney.
So, protein can also increase the height.
So we can see you.
All right. No, you do. No, you do. Right?
That was my question. You're saying that proteins can also hold on to water.
Correct.
Is that the equivalent of only the oncotic pressure?
Only the oncotic pressure. It doesn't affect hydrostatic pressure. So I'll talk about that pressure also. So when you talk about an example, so a condition that increases GFR would be cirrhosis, right? There's not enough proteins in the blood to hold on to water. It can easily go through the glomerular membrane. Okay. The opposite of that. What's a condition where you have too much protein? That's also liver problem. Losing protein. What's the next? Multiple myeloma, amyloidosis. There too much proteins. What do you think happens to GFR? It decreases. Why? If you have too much protein now, it's holding on. And what is that protein? When we talk about protein high and low, we're talking about in the blood. Right? If you have increased protein here, it's going to hold on to all the water. So less is going to go through or get filtered. If you have too little protein, the opposite is going to happen. I don't have protein to hold on to water, so I'm just going to freely lose that fluid. It goes to the filtration barrier. So make sense? So high protein state and low protein state. So that's purely with protein. Now we can also put this concept.
Please, can you repeat what you said, please?
Sure. Protein, right? Protein, the function, or normally if you have protein, it holds on to water. If you have too much protein in the blood, I'm going to hold on to more volume of fluid in the blood itself. If I have too little protein in the blood, that means the water is going to leak out of the vessel. Not enough to hold it in. Does that make sense? So that's what I just said about protein. So, do you have edema in cirrhosis? Peripheral edema, right? Why? Oncotic pressure, same reason, because in your blood vessel, there's not enough protein. The water is leaking out into the interstitium. You have edema, right? You have ascites in cirrhosis. They do. But same reason. When no protein, where's all the third spacing, right? It's going into the interstitial space. Is there edema in nephrotic syndrome? Yes, nephrotic syndrome is low proteins. Same reason they have edema, right? That's one side of it. Yes.
Cirrhosis versus nephrotic syndrome. One has increased filtration, one has decreased filtration.
Both of them have increased because in nephrotic syndrome, the protein's leaking out. When the protein's leaking out, what's it taking with it? Water, right? So initially, there'll be increased GFR in nephrotic syndrome. Okay, so that's protein related. How about hydrostatic pressure? So what's an example where you have edema due to hydrostatic pressure? Heart failure. So heart failure, where's all the fluid backing up? Into your venous system. But here, which pressure is affected? Oncotic or hydrostatic? Hydrostatic. So that hydrostatic pressure, increased hydrostatic pressure in the vessel, what will it do to fluid? Push it out into the interstitium, you have edema. Do you have ascites and portal hypertension? Yes. What's the cause of the ascites and portal hypertension? Portal hypertension kind of goes with cirrhosis. But what is the cause of ascites and portal hypertension? Is it oncotic or is it hydrostatic? It's hydrostatic. So, there are questions where you can trick you because cirrhosis and portal hypertension goes together, right? Portal hypertension is a complication of cirrhosis. But if the question talks about cirrhosis and ascites, it's always oncotic pressure. But if the question is asked in the context of portal hypertension causing the ascites, then it's going to be hydrostatic pressure. So same condition, but two different causes. Okay, portal hypertension, hydrostatic pressure. For cirrhosis, oncotic pressure.
Cirrhosis damage the kidney because it increases hydrostatic pressure because of the portal hypertension. It decreases oncotic pressure. That results known to be way increased filtration.
Increased filtration.
Attacking both.
Yep. Yeah. Portal hypertension, there's also in cirrhosis actually leads to low flow to the kidney. No questions? Okay. All right. Is that clear? So that's how you get.
I have questions, sir.
Yes, go ahead.
Please, do you say in nephrotic there is increased protein or decreased protein?
There's decreased protein. There's increased protein in the urine, but decreased protein in the blood.
What about in cirrhosis?
Cirrhosis, decreased protein in the blood. The liver is not making any protein, so decreased protein in the blood.
Okay, so, okay.
Same thing with pulmonary edema in CHF. What's the responsible for that? Hydrostatic pressure, because blood backing up from the heart, from the left side, in pulmonary hypertension, increased pulmonary pressures, it can leak out, lead to pulmonary edema. Yes.
Cardiac pressure and hydrostatic pressure. It's not matter if it's kidney, any capillary blood is due to bipolar.
Yes, exactly. Yeah, any vessel, it's the same thing. Kidney glomerular capillaries, it's blood vessel, right? So any vessel can be affected. Okay, now let's talk about renal failure. Pre-renal, intra-renal, post-renal, all renal failure. When did we say it is renal failure? When GFR is below 15, right? 15 renal failure, all right? So there are different crosses of renal failure. It could be something to do with the kidneys itself. It could be something that happened before the kidney or after the kidney, right? Pre-renal means the problem was before the kidney, which number one causes low volume. Okay, pre-renal, before the kidney, low volume reaching the kidney. Now we go through the same process that we talked about earlier. When there is low volume, what is activated? Or before we go to activation, in low volume, what happens to BUN? Right? Pre-renal, decreased renal blood flow. What happens to creatinine? Oh, actually, sorry. You just agreed with me? It was a test. Yeah, it's not clearing. So in the blood, it goes up, right? BUN goes up, creatinine goes up, right? So now what's kicking in? The RAS system kicks in, okay? And remember, one of the things that the RAS does to reestablish GFR is what? Well, the very first thing it does, to increase constriction of efferent. So here now, constricts efferent. Agreed? So when you constrict efferent, what happens to GFR? Increases. So what happens to serum creatinine? When you increase GFR, it decreases, right? But you have constricted the efferent. What happens to BUN? Yeah, because you're constricting the outlet, BUN still remains high. So which means this creatinine and this creatinine kind of normalizes approximately, but BUN remains high. So which means what would the BUN to creatinine ratio be in pre-renal? Around 20. That's because creatinine remains normal and the BUN goes up. Okay, because normal, what's normal BUN to creatinine ratio is about between 15 and 20. That's a normal ratio, right? 15 to 20 is normal. So if it goes above 20, BUN to creatinine ratio, it's going to be pre-renal. And so one of the things that I always tell students when they look at labs, especially when you're looking at BUN and creatinine, it's always a very good habit to quickly do the ratio, right? You're just going through the labs, BUN, creatinine, just do the ratio quickly. All you need, you don't need a number. All you need to know is it greater than 20 or is it less than 15? That's all you need to know. You don't need to know where it is. But it's 30 or 40, it doesn't make a difference because it's about 20, right? And 99% of the time, if you see a BUN creatinine ratio greater than 20, you close your eyes and say it's pre-renal. 99% of the time. And hopefully you don't ever see that 1%, but in medicine, there are no absolutes.
I didn't understand why people like stayed high.
How is BUN secreted? Through in the kidney. How does BUN get into the urine? How is it going? How do your body get rid of BUN? Secreted through what? What's the vessel? The efferent. Right? Yes, agree? So angiotensin 2 out of the RAS system, what does it do to efferent? So how much is getting through now? So what's in the body? That BUN is in the body, blood urea nitrogen. That's why it's high. You're constricting the efferent. But constricting the efferent doesn't affect creatinine, right? Because creatinine goes through filtration. In fact, it increases creatinine clearance. That's why creatinine, the net change in creatinine is minimal. And BUN goes up, creatinine stays low, ratio is high.
As long as like this constricted is like less surface area.
Yeah, it's a tube. It becomes smaller. So how much goes through? Yeah, flow. Yeah, it's like, you make the door bigger, how many people you go through? More, right? You make it a narrower opening, less gets through. So is that clear? So that's the first part, the ratio, BUN to creatinine ratio greater than 20. So which also means you're activating the RAS system, right? So what are the hormones that are activated now? Aldosterone, what does it pull from the urine? sodium. So then you look at the next number, which is urine sodium. Or another way to represent it is FeNA. It came up earlier. FeNA, fractional excretion of sodium. What's the difference? One's a proportion, one's a number. Urinary sodium, if you have aldosterone kicking in and pulling all that sodium in, what should urinary sodium be? Low, it's less than 20, which also means fractional excretion of sodium is also low. It's just a fraction, less than 2%. Or even actually even less, put it 1%. So make sense why? You have aldosterone acting. Aldosterone pulls sodium. When the RAS system is activated, aldosterone is activated. What does aldosterone do? It pulls the sodium out of the urine. Less sodium ends up in the urine. So FeNA is low, aldosterone sodium is low. Now, 8, yes.
From your concentration of sodium normally is
20, more than 20, 20 to 40. Yeah, 20 to 30 actually. Yeah. 2 to 3%. Yeah, approximately 2%. All right. So now first is the ratio. Second is your sodium. And third is osmolarity. And we talk about urine osmolarity. So these are the 3 things that you're going to look for between pre, intra, and post. It's going to help you what the actual problem is. Now, what would osmolarity be? Do you think it'll be concentrated or it'll be dilute? Concentrated, right? Because we are pulling all the water from the urine. Although we are pulling sodium, what are we pulling more than that? Water. So look at it this way. What does aldosterone do? Pulls water, pulls sodium, and pulls water. But RAS also activates ADH. What does ADH do? Pull water. So just by looking at that, how many waters to how many sodium? I mean, it's not exactly, but as a representation, more water than sodium, right? Twice the amount of water than sodium, which means urine will be concentrated. Hence, when we are dehydrated, when we pee, will be concentrated, right? You're pulling out all that water. So which means, what's your osmolarity? Urine osmolarity is a big range, right? It can be as low as like 20, it can go as high as 800. But normally, urine is acidic and urine is concentrated, normally, right? So here, if it's greater than 500, that's a number to remember. Urine osmolarity greater than 500, FeNA less than 1%, V to gram ratio greater than 20, all will indicate pre-renal. Pre-renal means what would be an example for pre-renal then? Heart failure, dehydration, blood loss, hypovolemia, yes, blood loss, could be pregnancy, could be road traffic accident, and also cirrhosis. Okay, so these are the common examples of pre-renal. CHF, low cardiac output. Cirrhosis, there is splanchnic vasodilation, so blood is actually redirected into those splanchnic vessels, less blood reaching the kidney. Dehydration, overall there's low volume. Bleeding, low volume, right? Vomiting, diarrhea, doesn't matter. All causes of low volume will fall under pre-renal. So you're clear on pre-renal? Yes. Yes. Yep. Not hydrostatic. In cirrhosis, oncotic is low. Not hydrostatic. When you talk about cirrhosis, it's purely oncotic pressure, right? Nothing to do with hydrostatic. No. It's two different conditions. Okay. So actually, I want to make one more point here. We talked about edema, right? So let me actually put some example here. So these are the three causes of edema for different reasons. Two we already talked about. In CHF, there's edema. That's because what's the hydrostatic pressure in CHF? Elevated. What's oncotic pressure in CHF? Normal. And what's capillary permeability in CHF? So actually, I'm going to redo it because we like arrows better. Let's do it this way. So you have hydrostatic pressure, oncotic pressure, capillary permeability. All right, let's talk about we'll come to sepsis. CHF, what's hydrostatic pressure? Increased. What's oncotic pressure? What's capillary permeability? It's normal. Nothing wrong with the capillary permeability means the holes in the capillaries, are they affected? They're not. You just, the pressure is pushing more things out, but the permeability is still the same. Fenestration, the property of the vessel to let things out. That's permeability. I want to make a point because this is also a question that I've seen, and people get confused. Oh, one side, the other is low, obviously, right? No, that's not how it is. It's purely one that's affected. So when you talk about cirrhosis or even nephrotic syndrome, what's hydrostatic pressure? Just following the same principle that we did for CHF. What's hydrostatic pressure in cirrhosis or nephrotic syndrome? No. Good question though. But no portal hypertension, cirrhosis. It's normal, exactly. What's oncotic pressure in cirrhosis? Decrease. What's capillary permeability in cirrhosis? Normal, exactly. Now we come to the third question. Sepsis. Sepsis, what's the problem? So what's hydrostatic pressure in sepsis? Why? So why is pressure decrease? The volume is still, no, it's not. It's normal. The pressure is normal. Your vasodilation, your blood pressure, that's normal. That's decreased. What's hydrostatic pressure? It's normal, right? Because are you adding more volume? You're not. Whatever volume there is, it's there, right? You're not drinking more water. What's oncotic pressure in sepsis? No, normal. But now comes the question, what's capillary permeability in sepsis? Increase. You see that? Because how is capillary permeability increase in sepsis? So what you going to answer?
No, I was going to ask about oncotic pressure because there wouldn't be any change in oncotic pressure even though you're adding more immunoglobulins.
We're not adding immunoglobulins.
Like
No. So there is antibodies. Yeah, you're having. So when you have inflammation, like sepsis, you have mediators of inflammation. You have cytokines, you have interleukins. What do they all do? They damage the capillary. That's how they increase permeability. The oncotic pressure, because of proteins, it doesn't go up like that. It doesn't. So this is actually a question where you have three different causes of edema, but we would think that, yeah, they all related to each other. No, it's a pure problem with each of these. So an example for capillary permeability leading to edema is sepsis. An example for oncotic pressure leading to edema is cirrhosis and nephrotic syndrome. An example for increased hydrostatic pressure leading to edema is CHF or even portal hypertension. Okay. Portal hypertension can go in there too. All right. So remember that. So don't associate with each other. Think of it as an independent condition which affects only one particular property within the vessel. Okay. All right. Kuna, question?
Yes. Why is osmotic pressure normal in congestive heart failure?
Is there a protein problem in heart failure?
No.
That's it. So oncotic pressure only changes with protein changes. If there's increased protein, increase oncotic, decreased protein, decrease oncotic. If the CHF is purely a fluid backup, it has nothing to do with protein. That's why the oncotic pressure remains normal.
Okay, so
Clear?
cirrhosis, it's a protein problem for cirrhosis?
Yes, exactly.
Why is
So
that?
that's, yeah, cirrhosis, what's the problem in cirrhosis? What organ is not working in cirrhosis?
The liver,
What's the main function of the liver?
filtration,
Liver.
or detoxification.
Okay, what else?
Energy production.
What else? You're missing one other important function. What does it make?
It makes proteins.
Makes proteins, correct. So if you have cirrhosis, it's making any more protein.
No.
Yeah, so that means low protein, low oncotic pressure.
Okay, thank you so much.
Sure. Yes. Yes. Blood pressure goes down. What is hydrostatic pressure then? So hydrostatic pressure is the pressure exerted by the fluid that's within the vessel, right? So how much of fluid is in that vessel from before? So you have X amount of fluid circulating in the body, right? So when you have sepsis, is that amount of fluid in the body change? It doesn't. So the fluid that hydrostatic pressure is a pressure exerted by fluid on the walls of the capillaries, right? So whether it's dilated or constricted, if it's holding the same amount of fluid, does it change the pressure? It changes blood pressure because of vasoconstriction, vasodilation. But does it change if there's, like, let's say, just as a number, 2 liters of fluid before you had sepsis? Yeah, you're vasodilated, but the fluid within that vessel is still 2 liters because you haven't added any fluid to the body, right? So how do you get more pressure? Now, if you start giving him a bunch of IV fluids and, overload him with fluids, then it'll change. But by itself, it's the same amount that's circulating within the body. It doesn't change the hydrostatic pressure. Okay.
So,
yes.
Please, where is there increase hydrostatic pressure in portal hypertension?
Portal hypertension is also a problem in the portal venous system. It's a blood pressure, it's hypertension. So it's a vessel issue. It has got nothing to do with protein. There's more pressure within the portal venous system, which is pushing the fluid out of the portal veins. Okay, because it's hypertension, so increased pressure.
I have another question.
Yes.
Thank you.
Okay, so since it's a vessel issue, why is capillary permeability normal
In which one?
in portal hypertension?
Yeah, vessel issue in the sense that what's happening to the vessel? There's no damage to the vessel. So when you talk about capillary permeability, that's based on the pores that are in the vessel through which the fluid leaks out, right? So when there's portal hypertension, the pressure is increased in the capillary, but those pores remain the same size. They don't change because there's no damage to the endothelium. In sepsis, there's damage to the endothelium, which means those pores in the vessels also become larger now, which increases capillary permeability.
Okay, I got it. Thank you.
All right.
Excuse sir.
Yes.
Please, can you throw more light on this nephron, the hydrostatic pressure, oncotic pressure, like the explanation?
What about it?
Hydrostatic pressure and oncotic pressure, the initial explanation that you gave about how it goes into the cell and out of the cell.
Okay, so that's okay. I got rid of that. Okay, no problem. So here, when you talk about a vessel, you have 2 pressures. You have hydrostatic pressure and you have oncotic pressure. Oncotic pressure pulls fluid towards it. Hydrostatic pressure pushes away from it. So depending upon which one's affected, if you have increased hydrostatic pressure, it's going to push fluid out of the capillary. If you have increased oncotic pressure, it's going to hold fluid within the capillary. That's the difference. So those are the pressures that has to be affected for any fluid to leak out into the interstitium. Okay.
Okay, so the arrow you gave, like the hydrostatic pressure is pushing fluid towards it, right?
to, no, it's going into the interstitium.
Okay, but you say you push it fluid towards it. So how is it going to interstitial now?
The oncotic pressure pulls fluid toward it, not hydrostatic. Hydrostatic
Oh.
pushes away, and this is a blood vessel. Hydrostatic pushes away, oncotic pulls towards.
Okay.
Hmm? All right, clear?
Yes, thank you.
All right, so good with pre-renal? You know, I've forgotten all about pre-renal now, right? So intrarenal. So intrarenal, where is the problem? Intrarenal, right? So examples would be glomerulonephritis, interstitial nephritis, acute tubular necrosis. Doesn't matter. The problem has to be within the kidney itself, inside, within the kidney. So remember we talked about, so going back to this picture, if the problem is here, within the kidney, right? Is it filtration or secretion that's going to be affected? Where do I draw the green lines? Everywhere, not everywhere. Well, not everywhere. Let's. Yeah, filtration, because you're talking about this area. Now, is it clear? You're talking about that area, right? Whatever goes through straight here is still going through. Does that make sense? So creatinine, so when we look at BUN creatinine ratio, what happens to creatinine? Serum creatinine. Serum creatinine. Increased, right? Because you're not filtering. Not filtering is not getting into the urine. You're not peeing it out. It collects in the blood. But does secretion still happen? It does, because it's not going through the glomerulus. It's going through the efferent arteriole. That still happens. BUN is normal. So now denominator is high. What happens to the ratio? Less than 15. Okay, so BUN creatinine ratio is less than 15. That's your intrarenal failure. Now we're going to look at the other things too. The three things that we want to look at is the ratio. We want to look at urine sodium and FeNA. And then we want to look at urine osmolarity. Okay. So if filtration is not happening, it's like the filtration barrier, glomerulus, is like a sieve, right? You're purifying the blood so that I can remove electrolytes from it. Now, if I'm not purifying that blood through filtration, am I reabsorbing anything? We are not. Where would sodium end up? In the urine. Urine sodium is greater than 40. FeNA is greater than 4%. Does that make sense? No? Why? So let's say that you have blood that needs to be filtered, right? You have lots of stuff in the blood, right? I have to purify it. That's why it goes through filtration. Once I purify it, it gets into the PCT. Now the PCT knows what to do and gets the sodium out because it sees it right there. Oh, the sodium, I'm going to take it out. Okay. Now, when you have intrarenal issue and filtration is affected, all the blood is not being purified. It's getting dumped into the PCT, right? So along with it, there's a lot of junk in it. So the PCT, those little channels, can't identify where sodium is because there's a lot of stuff in it. It hasn't been purified. So what's going to happen? It can't remove all it needs. It takes some, but most of it ends up in the urine. Make sense? Creatinine 40 milliequivalents, if it's a number, and 4% FeNA in the urine of sodium. It's not being reabsorbed, exactly. So you're losing it. Okay. So which also means now what happens to urine osmolarity? Is it going to be dilute or is it going to be concentrated? Exactly. So is it going to be dilute or concentrated? It'd be dilute. It's the same reason. ADH is not working, aldosterone is not working. What are you losing more into? The urine. You're still water, right? You're losing salt and you're losing water, but there's more water than salt in the urine, which means it will get dilute less than 350. Yeah, there is more sodium. By all means, there is more sodium, but there is also twice the amount of water than there would be normally, which causes it to be diluted. Does that make sense? Clear? These numbers are very important because that's what's going to help you identify what the cause is. Sure. If you look at this, we take them all off. So the problem in intrarenal is here. Okay, so this is where the problem is. So is it filtration or secretion that's affected? Filtration. Because whatever blood comes here, whatever needs to go straight still goes into the efferent. Whatever needs to come down here, it doesn't happen, right? So what's secreted, it still happens. And what is secreted? BUN. So BUN secretion continues to happen normally. Okay. Now we're talking about the early stage for any condition. Once a kidney is failed completely, then yeah, everything will be, all bets are off. Now it's gone. But this is how it starts out. Does that make sense? All right. Question? Could be PCT, yes. Not necessarily always. It could be PCT, it could be the glomerulus. Not DCT, mainly PCT. Yeah, that's why acute tubular necrosis, right? Where does acute tubular necrosis affect? Usually PCT, because that's the one that's most vascular. Yeah. All right, good with that? Now we look at the third scenario. It's post-renal, after the kidney. So what are some examples there could lead to post-renal? Something that's happening away from the kidney, after the kidney, but eventually will affect the kidney. Stones. What else? Mass, BPH, you know, what you call uterocele, cystocele, doesn't matter. Anything that can cause obstruction. So now again, going back to this picture and retrying this. All right, so this continues DCT. I'm just going to draw it here just for lack of, and let's say this is the ureters. Okay, so let's say you have a stone here that's blocking the ureters. Okay, now what's going to happen? Initially, the stone is in the ureter. Everything is happening normal, correct? So which means when you look at BUN creatinine, is it affected? Initially, no, it's not affected because the problem is away from the kidney, BUN creatinine is normal. But over a period of time, if it's not addressed, what's going to happen? Now urine is backing up. How far does it go? All the way to? And then keeps going higher, higher up to the Bowman space, right? It can't go back into the vessel, right? It will not go back. It'll collect in the Bowman space. So back up, yes.
Wouldn't it first get to the collecting tubule?
Yes, correct. That's collecting tubule is here. I'm just drawing it for lack of space. So it's going to go through the entire nephron all the way up to the Bowman space. Okay, now, oh, I removed that picture. But when you go to the Bowman space, remember we drew this picture out? Bowman space, if you have all this fluid in the Bowman space, what pressure is increased there now? Hydrostatic, exactly. If now you're increasing hydrostatic pressure in the Bowman space, what do you think is happening to GFR? Decreases. That make sense? Decrease GFR. If you decrease GFR, what happens to creatinine? In the blood, increases, right? So along with that, if I'm going to collect all this fluid in the tubule, right here, What's happening to this pressure within the tubule? Increased pressure, right? And if secretion is going to happen into the tubule, and if I have too much pressure here, can I add more into it? You can't. So what happened to BUN then? Increases. Exactly. Does that make sense to everybody? I mean, it doesn't usually go back into the vessel. It just collects in the Bowman space, because what's happening is there's also fluid trying to come through, right? And there's more pressure here, so it kind of like opposes each other. So which means if initially both normal, ratio is also normal, right? But what we say happened to BUN and creatinine eventually? Both will increase. So, but if both increases, what happens to the ratio? It's the same, exactly. So in post-renal, the ratio, BUN to creatinine, the ratio is the same, but individually, BUN and creatinine both are elevated. Does that make sense? Clear, everybody? Good? I'll call you at 2 a.m. and ask you this, will you answer me?
Yeah, excuse me, sir.
Yes.
Please, sir, can you throw more light on intra renal failure, please?
Yeah, intra is within the kidney, right? If it's
Yes.
within the kidney, is it secretion or filtration that's affected? Tell me.
Oh, is a filtration, sir.
Filtration that's affected, exactly. So if it's filtration is affected, would it be creatinine or BUN that will go up?
It's creatinine.
Creatinine, exactly. So look here. In the ratio, creatinine went up, BUN stay the same. So ratio, because the denominator increase, ratio drops. Is that clear?
Yeah, so which ratio drops, sir? Where would the ratio drop from?
BUN to creatinine ratio, normal ratio is between 15 and 20.
Okay.
It'll go below 15.
Okay. Okay.
Okay. And then because I'm not reabsorbing anything, I'm also going to lose electrolytes or sodium in the urine. That's why urine sodium is high. Fractional excretion of sodium is also high. Okay.
Okay, increase urine sodium and what again?
Because you're not reabsorbing sodium, all the sodium ends up in the urine.
Yes, okay.
Right? That's why urine sodium or FeNA, which is also sodium in the urine, both of them will be high.
Okay.
Okay.
All right, thank you.
So in post-renal anemia, is there any instance where the creatinine is much higher than the BUN?
No.
Because certain texts, they also say that the BUN creatinine ratio is also low.
So think about it this way. If you are backing up, right? You haven't caused renal failure yet. Your BUN creatinine is affected. But if you don't do anything about it, what's going to happen to the kidney eventually? You precipitate renal failure. So in that state, maybe the ratio can change. But normally we don't look at it that way.
Is that because of the capillary permeability in the Bowman capsule increase?
Not that itself. It's because if let's say the complete filtration, so even now, even though filtration is affected, creatinine is increasing, there's still a little bit going through, right? So as the creatinine level, as the renal failure advances, what happens to creatinine level? Well, in the blood. As renal failure advances, what will happen to serum creatinine? Increases. So yeah, that increase is probably when it leads to, okay, less than 15. Because now because of that renal failure, now creatinine is kind of increasing to 2, 4, 5 levels. Now you precipitate renal failure, there the ratio might be smaller. Yeah, that's the reason why. Question here somewhere? Leslie, you had a question?
Yes, doctor. I understand why in post we have a high creatinine because the high hydrostatic pressure moved to the Bowman capsule, the volume, right? But
yes.
Can you explain me again why the BUN is increased?
Sure. If you follow my arrow here, it's a different color. So let's say the green that I'm writing is BUN, okay? In the tubule, there's a lot of fluid. So this is completely filled up with fluid because of backup. What's happening to pressure within that area in the PCT? Leslie.
Increased hydrostatic pressure.
Increased hydrostatic pressure. So remember, movement across a membrane. What's the number one determinant of movement across a membrane? Concentration gradient, or you can also look at it as a pressure gradient. So it goes from a high pressure to a low pressure area, right? Always.
Yes.
So now, because the pressure in the tubule goes up, it's going to be harder for this BUN to get into it, to be secreted. Does that make sense?
Oh, yeah, it makes sense. Thanks.
That's the reason why BUN goes up. Okay.
So, excuse sir.
Yeah.
You said that in intra renal that the creatinine is going to be increased. So how come you said that the ratio of BUN and creatinine will be decreased less than 15?
Because the denominator is increased. Remember, the ratio always goes opposite to the denominator and goes the same direction as the numerator.
So which one is the denominator now? Is it the creatinine or?
Creatinine.
Okay, the creatinine, you said it increases or it decreases, sir?
Increases.
Okay.
Because creatinine increases or denominator increases, the ratio decreases.
Oh, thank you.
Okay. All right, so now going back to urine sodium, FeNA, and urine osmolarity in post-renal. If all this is collecting in the PCT, is there any reabsorption happening? Things are just being dumped into it, you're leaking basically. So urine, this will be identical to basically intrarenal. Right, so that part of the equation, all the other values will be identical. Because you are not filtering, you're not reabsorbing, you're not secreting, nothing's happening. You're basically peeing out all the electrolytes. Yes.
What was FeNA again?
Greater than 4%. Fractional excretion of sodium.
If left untreated, this is probably the fastest way to really keep.
Well, it won't be fastest because it's going to take time for everything to back up, right? If you have a stone, but over a period of time, definitely. So that's why stones have to be treated. You can't leave it alone because what's going to happen first is hydronephrosis. So that's why we do an X-ray. That's why we do a CT scan to see if there's a hydronephrosis. So if you have a small stone with mild hydronephrosis, that's how usually the radiologist will report on the X-ray. Mild hydronephrosis, stone, 2 millimeter, whatever. That's fine. You can, get it broken down. You can pee it out. It'll be fine. But you have significant hydronephrosis, that means you have to do something right away. Because what's the next thing that's going to happen? Pyelonephritis. What's the next thing that's going to happen? You're going to destroy, damage, intrarenal failure now. And sepsis, and that's what, yeah. So if you don't do anything about it, yes, you can develop renal failure. So that's pre, intra, post. Clear? Yes, no, maybe. Thumbs up, thumbs down. I don't care. It doesn't matter. You can tell me whatever you want. We'll think about it. I'll look at it tomorrow. Okay, so those are 3 causes of, and like I said, across the board. Now, whoever's going to come to see me in my tutoring session, if you see BUN creatinine, and without me telling you, you have to tell me the ratio, asking you. Okay, because it's a good exercise. You should always calculate it. That's a good habit, not just for the exam, even in real life, right? When you have a list of labs as a resident, you have a list of lab, the attending gives you the lab and look at it, BUN creatinine, you immediately say intrarenal, like what, right? So you should remember that it's a good exercise to always do the ratios for BUN and creatinine whenever you see that in a question. Okay, same thing with osmolarity. So these are some of the things that when you look in the lab, it immediately tell you something without even reading the question. Okay. All right. So what was next? Fluids. I think you have had some mention of fluids in some of the chapters earlier. So let me just go through in general. So anytime you're dehydrated, what's a fluid of choice for resuscitation? Normal saline, right? Always normal saline. What's a fluid for maintenance? No, half normal saline. right? Half normal saline. So if you're dehydrated, you give them normal saline. If once you have corrected the deficit, now you're just maintaining, because now he's in the hospital, he's getting IV fluids, he doesn't have a deficit. You've already corrected the deficit. So you're not resuscitating, you're just maintaining fluid, which is half normal saline, right? So what's the difference between normal saline, half normal saline, quarter normal saline? What's the difference with all that? It's a concentration of solutes, like sodium, for example, right? Because if you're euvolemic and eunatremic, do you want to give them more sodium? You don't, right? But when you're deficient in that, like you're dehydrated, you have a fluid deficit. So you want to correct it by giving them isotonic fluid, right? Isotonic is either normal saline or what's the other isotonic fluid? Lactated ringers. So lactated ringers or a normal saline, both of them are isotonic, means same osmolarity as our blood. That's why we give that. Now they're all fine, it's corrected, and the volume, now you just want to maintain it. So their net, there's no loss. Now you want to maintain it. When you maintain it, you don't want to give too much, right? So that's why you step it down to half normal saline, because you only want to give X amounts of solutes, so it doesn't become more concentrated, right? So in a child, you don't want to do that. That's why you go to quarter in a child.
That's what I gave you. Everything is, we're saying everything is fine. That means both ECF and ICF are isotonic.
Balanced, correct.
Right? But giving half
Hi,
normal,
well, first of all, find this thing here.
Yeah, I think your mic is on.
Oh, I'm
maybe-
sorry.
Oh, no problem, right?
So if you have isotonic environment, right, ECF, ICF are okay. Wouldn't giving half normal saline be a hypotonic environment? Wouldn't that cause you to secrete more sodium and water from itself?
Secret? No. So isotonic, so normal saline, half normal saline, they're all actually isotonic, right? I mean, not meaning they have less amount of sodium, but the thing is, you are not trying to correct a difference. So even when you give this fluid, water is going to move in and out of the cell to balance it out. The solutes are not going to move out, right? What's going to move?
Just water.
Just water. So that's why it balances it out. It doesn't affect the sodium unless you give somebody too much sodium.
The body already has a gradient in water.
Right, exactly, because now there's no deficit. So they are euvolemic, they are fine, but they're just not drinking or eating. So we're just maintaining it with half normal saline.
Lysis will only happen if you were originally hypotonic.
Correct. Yeah, exactly. So if you give too much sodium, it's going to pull water out of the cell. If you give too much water, it's going to push volume into the cell. So both is bad, right? Either the cell can rupture, either because it shrinks or because it swells. But anyway, that's a different concept. So in children, the next question is, do you ever give glucose with resuscitation? Dextrose with fluid resuscitation. So generally, you don't give, right? Why? A person who requires fluids.
You have
Yeah, so a person who comes into the hospital who requires IV fluids, who's at a deficit, what is he in now? The very day one of class. Low energy state, right? So if you give him a bunch of glucose, can he metabolize that glucose? He can't. So what are you going to do now? You're pumping with glucose. What's glucose going to draw towards it? Again, water. So you're going to kill him. So that's why initially when you go resuscitation, it's always normal saline. Maintenance, you can always add glucose. Now, because you have brought up the deficit, he's fine. He can now generate ATP. He can metabolize that glucose. So only maintenance fluids, you can add dextrose. Resuscitation fluids, do not add dextrose. Okay. So anytime you're dehydrated, normal saline for, so this is wrong. This should be just normal saline. For dehydrated child too, you can actually use normal saline when they are dehydrated, and then maintenance use go down to half a normal saline or quarter normal saline. Okay, so how do you know a person is really dehydrated? You look at the person, right? What are some signs and symptoms of severe dehydration? Capillary refill, what else? sunken eyes, or in the child fontanelle, dry mucous membranes, all those kind of things. So if you all see all of that, he's dehydrated, he or she is dehydrated, okay? Now, another scenario, sometimes when you test in a test, there's a burn patient, right? Here, how do we calculate resuscitation amount? It's using the equation 4 cc's per kilogram weight per person burn surface area. Okay, so just a quick example, 75 kilogram with 30% burns. How much fluid does he require for resuscitation? $75 kilogram, 30% burns. So 4 cc's per kilogram per burn surface area. Yeah, it's about 9,500 or 9.5 liters. Never go? What do you mean 50%? When you give it. All right, so that's the next thing. So this person who was 75 kilograms of weight had 30% of his body surface area burnt. So when you want to give him fluids, when he comes to the hospital, you want to give him fluids, how much fluid do you want to give him? That's the equation to calculate that, 9.5 liters. So that's a first step. Leslie, question?
Yes, I have a question regarding the resuscitation fluids for children. It has to be normal saline or half normal saline?
If it's a dehydrated child, normal saline can be used.
Okay, no half, okay.
Not half. If someone who has, let's say, had a couple of episodes of vomiting and they come to the hospital, no signs of dehydration, but they were not taking in any fluid, then you start out half normal saline. But if you see signs and symptoms of dehydration, then normal saline.
Okay, thanks, sir.
All right. So now the second question is, how do we give this fluid? This is what you're talking about, the 50%. Half of this is given in the first 8 hours. So the other half is given in the next 16 hours. So this is where the 50% comes in, right? Because you don't want to give everything at the same time. First half over 8 hours, the next half over 16 hours, okay? Now, yes. No, because when you're trying to give him fluid, obviously if he has renal failure, then it'll go straight to dialysis. But otherwise, this is fine. Okay. The other situation is when you use 3%. When do we give somebody 3% hypertonic saline? When they are hyponatremic, but a number below 120. Not all hyponatremia. Either sodium below 120 or symptomatic hyponatremia. So he could have seizure 125 as serum sodium, but he's having a seizure. That will also require 3%. The second indication for hypertonic saline, what other condition would you usually give hypertonic saline? Think about why you're giving it and what's the situation where sodium has dropped that much. SIADH, yeah. Remember, SIADH, there's dilutional hyponatremia because the volume overload is so much that their sodium levels can drop and they can cause seizures, and therefore you want to increase the sodium faster. SIADH is the other condition where you're going to use hypertonic saline. Okay, 3%. All right. In burns, you use the rule of nines to calculate the person's surface area burn. Sometimes the question will tell you he has 30% surface area. Sometimes it'll list the places that are burned. So then you have to calculate it yourself. Head and neck is 9%, each arm is 9, front is 18, back is 18, each leg is 18, and then genitalia is 1%. So that's an adult, right? You have to use that to calculate the amount of surface area burn. If it's a newborn, then you remove 9% from each lower extremity. So it'll be 9% each leg, and then that 18% added to the head and neck region. So it will become 27%.
You also, just in treatment for hydrocephalus, you still give hypertonic saline?
ICP down, yes, because it can pull the fluid. We can pull the fluid out. Yes, but I don't think I don't think it's like first line, basically. You know, you don't generally do it because you can also do mannitol. So ICP first line usually is mannitol rather than giving them hypertonic saline because that's more dangerous. Right, exactly. So mannitol also has side effects. It can also do the same thing, but it's better because you're not adding anything. You're just removing fluid. But you give him hypertonic saline, you're also adding volume, right? So you're kind of like removing it with mannitol. Okay. Well, total body water. How do we determine total body water? It's 60% of your weight is in water. D2O, deuterium, that can be used to measure body water if somebody needs to. How? We don't need to know, but that's what we use to measure it. Similarly, this water is separated between intracellular and extracellular compartment. Most of it, 2/3 of it is in the intracellular compartment and 1/3 of it is in the extracellular compartment, right? But extracellular compartment also includes interstitium and plasma. Out of that 1/3, 3/4 is in the interstitium and 1/4 is in the plasma volume, right? So we can also measure in extracellular fluid volume by using inulin. Again, how it is done is beyond our scope, but if you need to measure extracellular volume, you can use inulin. If you want to measure plasma volume, you use albumin. If you want to measure total body water, we use D2O. That's the extent of what we need to know in that particular case. Okay. All right.
Excuse me.
Yes.
So if you want to measure albumin, you use what?
No, if you want to measure plasma volume, we use albumin.
Okay.
Okay.
Okay. So when do we use TBW?
Total body water, we use D2O.
Okay.
To measure
Thank you.
total body water. All right.
Okay.
All right. So now, finally, we have to enter the nephron now, right? We don't have a choice. We have to do this. All right. PCT. Now let's talk about what happens in each part of the nephron. Okay. PCT, the most important part of the nephron, right? What happens here? Pretty much everything. Reabsorption. Secretion. You have 100%, you have 90%, you have 65%. So what does reabsorb 100% in the nephron, in the PCT? Glucose and protein, amino acids. Oops. Right? So that's why even if you see a little bit of glucose or a little bit of protein in your urine, what does that mean? There is a problem, basically, because proteins and glucose should never be in your urine. Because whatever is delivered to the PCT, all of it is reabsorbed, right? When does the transporters get saturated? In the kidney. So there are two numbers. When does glucose start spilling into the urine? 200. 126 is diabetes. 126 is the cutoff for serum glucose for saying somebody is diabetic. But when it shows up in the urine, it has to be above 200. So which means if there's glucose in the urine in a person, his blood sugar is at least 200. Exactly. Because up to 200, you won't see it in the urine. Cutoff is 200. Yeah, because that's when it shows up into the urine. However, even at 200, the transporters are not saturated. What level are transporters completely saturated? That's about 350. To transport all your good transporters, all of them are bound or saturated at a higher level. But that really doesn't matter because it's going to show up in the urine about 200. If you're about 126, you have diabetes. Similarly, amino acids too. They should never be in the urine. Protein should never get there. Okay. What's the next most important thing that's reabsorbed? 90% bicarb. 90% of bicarb. That's what's urine pH? It's acidic, right? 4.5 to 5.5. Why? Because all the bicarb has already been reabsorbed. 90% is reabsorbed. Everything else, 65%. How much of sodium? 67. Wow. Okay. How much of potassium? How much of water? Magnesium, chloride, phosphate. Yes, exactly. You get the idea, right? 65% of everything else is reabsorbed. So that's the reabsorption part of the PCT. How about secretion though? There are a couple of things that are dumped into the urine. What are a couple of things that are dumped into the urine in the PCT? BUN, yes, okay, BUN. What else? Creatinine is not secreted, but it goes into urine. Other than BUN and creatinine, others. Other than that, acid, hydrogens, right? You're taking them bicarb, you're taking hydrogen. What's the other thing that's dumped into the PCT? Not potassium. Potassium is reabsorbed. Phosphate, right? Number phosphate. Now, who was doing that? Putting phosphate into the PCT. Parathyroid hormone. Remember, parathyroid hormone, it reabsorbs calcium, secretes phosphate. So phosphate goes into the urine under parathyroid hormone. However, phosphate is also reabsorbed in the PCT, right? But who causes the reabsorption of phosphate? So that 65% of phosphate is still there. Reabsorption is also there. But who does that? Vitamin D, exactly. So phosphate is the only thing that's actually reabsorbed and secreted there. Okay, a little bit of potassium all goes through while it goes through the nephron, but here this is how it is reabsorbed and secreted. So when we talk about reabsorption, 100% glucose, amino acids, and along with glucose, there's something else that goes through. There's a sodium glucose transporter, right? So what else goes through here? Sodium. Why is this important? Because we have a drug that can block this used in the treatment of diabetes. What's a drug? SGLT2 inhibitors. What drug is that? The flozins, the canagliflozin, empagliflozin, all the flozins, they block sodium glucose co-transporter. So that's one thing. They also have other, you take in sodium on the, before that, the cell, this is a tubule. The blood side is called it's a basolateral side, B for B. And the side of the cell that faces the tubule or the lumen is the luminal side. Okay, so the cell is actually lining the nephron, the tubule. Okay, and on one side you have the blood, a vessel that's going through. On the other side you have the tubule. So things are getting secreted into the tubule and then reabsorbed into the blood vessel. Okay, so on the basolateral side, there's a sodium potassium exchanger, ATPase actually. How many sodium, so how many potassium? 3:2 on the basolateral side. Okay, and then under the effect of carbonic anhydrase, you have bicarbonate reabsorbed, and this hydrogen is secreted back, whereas this bicarb now goes reabsorbed. Okay, and here's carbonic anhydrase. Okay, so the main things to know on the PCT is 65% of everything is reabsorbed, 100% of glucose and amino acids, and then 90% of bicarb reabsorbed. And the bicarb reabsorption happens through the enzyme carbonic anhydrase. Okay, so that's normal physiology. So now let's talk about medications that work here. So what are the medications? They inhibit carbonic anhydrase. So carbonic anhydrase inhibitors. What are the medications? Acetazolamide. Acetazolamide is the one that's used, but there are others that also sound the same. Brinzolamide, torzolamide. Those are all carbonic anhydrase inhibitors. Where do we use carbonic anhydrase inhibitors? Indications. Altitude sickness. Yes. No, it's potassium. So sodium potassium ATPase, not hydrogens. I mean, hydrogens are also secreted, right? So Not on the basolateral side, on the luminal side. Yeah, luminal side, not on the basolateral, it's always sodium, potassium, ATPase. Because hydrogen never goes into the blood, right? It's in the cell, and then from the cell, bicarb is taken into the blood and hydrogen goes back into the urine. Altitude sickness. What's the other indication for acetazolamide? Which one? Glaucoma. Another place where you use carbonic anhydrase inhibitors.
Pregnancy?
Pregnancy for what?
I don't really know.
Pseudotumor cerebri. So altitude sickness, glaucoma, pseudotumor. That's what we use acetazolamide. Okay, carbonic anhydrase inhibitors. So now, so those are your medications. That's your physiology. Now you have pathology there also. So what are the two main conditions that affect PCT? One we kind of talked about.
Excuse me, sir, please, that potassium, is it going inside the cell, outside the cell?
Which one?
The potassium? The
Potassium it's an exchanger. So you're exchanging potassium for
sodium. Okay.
On the basolateral side. And then this potassium is kind of secreted. A little bit of it actually goes out.
Okay. No. Okay.
Leslie, question?
Sorry, no.
Fanconi syndrome. And RTA type 2. Fanconi syndrome, the problem is with amino acid. So what do you see in the urine? Protein. So amino acid urea, glucose urea, phosphaturia. So when you see all of these, Fanconi syndrome, that's a problem with the transporter, amino acid transporter. So it affects reabsorption, and you see all of them ending up in the urine. Fanconi syndrome. Okay. RTA type 2. Renal tubular acidosis. So this is a metabolic acidosis. All right. Metabolic acidosis, there are two types. Anion gap acidosis and non-anion gap acidosis. Which one is this? Non-anion gap acidosis. We know the mnemonic for anion gap acidosis, right? What was that? Mud piles. Mud piles, all of those methanol, uremia, DKA, paraldehyde, INH, lactic acid, ethylene glycol, salicylates, right? Mud piles. That's increased anion gap. If it's normal anion gap, another good practice again, when you see all these electrolytes in a question, quickly do the anion gap, right? How do you calculate the anion gap? Positive minus negative, but we don't generally use potassium. It's just sodium and then bicarb and chloride. Normal should be about 8 to 12, right? 8 to 12. If it's within that, it's normal anion gap. So in RTA type 2, it will be between 8 and 12. Whereas in all the other ones, the mud piles, it'll be greater than 12. That's your anion gap acidosis. This is normal anion gap, okay? So RTA type 2, what's the problem in RTA type 2? So what we say is happening, which can lead to acidosis. You're reabsorbing bicarb in the PCT, right? 90% of bicarb. So it's a problem with reabsorption of bicarb, which means you're losing the bicarb in the urine. You're not taking bicarb back into the body. So is there enough base to buffer the acid in your body? No. So your serum pH falls, right? So in RTA type 2, your serum pH is less than 7.4. So acidosis. Okay. Now, along with that, what else happens? You're also going to lose potassium. So they have hypokalemia. Okay. Reabsorption is affected. It can affect reabsorption of multiple electrolytes, but potassium to a greater extent, hypokalemia. Okay. Which also means if someone takes carbonic anhydrase inhibitors, overdoses on carbonic anhydrase inhibitors, can lead to RTA type 2? Yes, because you're blocking bicarb reabsorption, right? When you take carbonic anhydrase. So that can cause RTA. Fanconi syndrome can cause RTA type 2. Carbonic anhydrase inhibitors can cause RTA type 2, or it can happen by itself because of a problem with reabsorption. Okay, so yes.
Okay, but trying to understand how the hyperkalemia is manifested.
So hypokalemia is happening not just because of the problem PCT. When there is a reabsorption that's affecting the PCT, when potassium goes through the tubule, the rest of the tubule also readjusts. And then the net benefit or the net problem there is that there will be a decrease in potassium altogether because you're losing sodium, you're losing potassium, you're losing other electrolytes also, but the kidney readjusts to some extent. But overall, they'll still be left with the potassium deficit.
Aren't you like trying to figure out H plus and then interpolate itself? Wouldn't you reabsorb back the potassium? Or we talk about like a
Net deficit. Even with that, there's a net deficit. Right? Yeah, you're right. It does. You're reabsorbing potassium there, and you're dumping hydrogens there, but that's still not enough to correct the deficit. Right? There'll be a net deficit. Okay.
Because PCD has a higher.
PCD has 65%. All right. So now, when we treat RTA type 2, we're getting there. Right? When we treat RTA type 2, what are the things we are going to correct? We have to correct the acidosis because why? What's wrong with acidosis? What does it do to the body? It denatures all the proteins, right? We don't want that acidosis. So how do we correct that acidosis? What can we do? Can we give them bicarb? But the PCT is not working. So how is it going to reabsorb bicarb? If you give them bicarb, 90% of reabsorption happens in the PCT. And the problem is with PCT, carbonic anhydrase. So what's the point of giving them bicarb? Fluids you have to give, but we have to correct the acidosis. How do you correct the acidosis? We actually use well, fluids, you can use any fluid, that's fine. But yeah, how do you correct the acidosis? Lactate ringers helps to some extent, but not really. We use thiazides. Right? So how does thiazides work? So this is another concept here. You might have heard it somewhere. Contraction alkalosis. You heard of the term contraction alkalosis. So you're basically what that means, you're causing volume contraction, which leads to alkalosis. How do we do that? Thiazide, what does thiazide do? It's a diuretic. Makes you pee out a lot more volume. So what are you now being pushed into? You're dehydrated. Basically, it's dehydrating you, right? Thiazides make you pee out a lot more, makes you dehydrated. Now going back, when you get dehydrated, what system kicks in? The RAS system kicks in. Aldosterone kicks in. What does aldosterone do on the other side? Secrete hydrogens, right? That is what it's called, contraction alkalosis. So basically, you're giving thiazides to cause volume contraction. So that's dehydration, which is forcing aldosterone to be kicked in to kick out more hydrogens, which leads to alkalosis. Make sense?
My question is this, based on the question that I asked earlier, how much more is the DCT contributing to pick up the H+, right? Because you're also reabsorbing some of that potassium at that time, right?
So H+, what's the primary for hydrogen secretion? Now, when we talk about PCT, it was all about reabsorption. Remember earlier when we talked about uric acid stones, I asked you a question, which part of the nephron is the most acidic? Collecting duct. Why is that? Most of the hydrogen is secreted in the collecting duct. We're talking about secretion, not reabsorption, which is different, right? So majority of the acid is secreted in the collecting duct. That's why that area is the most acidic. So we can actually make aldosterone secrete even more acid there, but that doesn't really affect how much potassium is reabsorbed. It's still, 5% is what's left, or even 2% is what's left because another 3% gets reabsorbed in the loop.
So you won't be correcting the hypokalemia.
You won't correct the hypokalemia with that, correct. So that's why treatment also includes what? Potassium. You also have to give them potassium plus thiazides for treatment of RTA type 2. Good? Clear? Yes. For what? What would insulin do to potassium? So would it be hypo or hyperkalemia? it'll make it worse, right? So if it's hyperkalemia, you can give insulin. Yes. Thiazides, it's a diuretic. You make you pee out more. Volume contraction means you're losing more, you're getting dehydrated. Yes. Potassium. Right, because they are hypokalemic. And we have to correct the potassium, because if you don't correct potassium, what's the danger? What membrane? Yeah, cardiac membranes are very sensitive to potassium changes. So we can't leave them at hypokalemic. So as we are correcting the acidosis, we also have to correct the potassium and give them potassium at the same time. Okay. All right, so that's PCT. Now, as we go from the PCT to the DCT into the loop, remember we said earlier in the descending limb, what's reabsorbed? Mainly water, correct? It's impermeable to solute. It's just water that's reabsorbed. But we can block this in that descending limb. What drug blocks that water reabsorption? No, we haven't gone to the loop yet. This is a descending limb. Louder, louder, louder. Mannitol. Confident, need more confident. Scream it, yell it. Mannitol, right? Osmotic diuretic. Why? It only, and that's why it's good, because it only draws water out. It doesn't affect anything else. But there's a problem. If you give somebody mannitol, let's say that someone met with a road traffic accident, had a head injury. He came to the hospital, he saw papillary edema. What does that tell you? Increase ICP. What do you start him on? A mannitol drug. Okay. A few minutes later, he died. What happened? It's something to do with what you gave him. You gave him mannitol. A few hours later, he died. Exactly. Too much. So rate of infusion. Right? If you give too much mannitol too fast, what's it pulling out? Water, right? Remember, if I remove all that water from the extracellular compartment, what's happening to osmolarity in the extracellular compartment? Concentration increases, right? I'm removing water. Now that increased concentration, where is it going to pull water from now? From inside the cell. So it will actually precipitate haunting demyelinolysis. So that can happen. So you have to be careful even with mannitol, how quickly you give it. You can't give it too fast. You can't give too much. You have to monitor it. If you don't want to pull too much water out, you can precipitate permanent brain death. That's one complication. Second complication, same scenario. You start them on mannitol. 2-3 hours later, he developed shortness of breath, respiratory difficulty. What happened? This is the other side effect of mannitol. He developed, not ours. What are you pulling out of the brain? Fluid. Where does the fluid go? Into your venous system. It has to go through the lungs before it's peed out. Pulmonary edema, right? So the second side effect is pulmonary edema. Same reason, because you're giving it too fast, right? So pulmonary edema and too much, too rapid of a correction can cause pontine demyelinolysis. So remember that with mannitol. Okay. All right. So now we come to the loop. In the loop, pretty straightforward. There is a triple transporter. Not on this side, it's on the other side. So triple transporter. What does it take in? Potassium, 2-chloride. And on the basolateral side, just like in any cell, you have a sodium potassium, ATPase. Now, the other interesting thing in the loop is that the gradient that's created by movement of sodium potassium chloride also creates a gradient for what else to kind of sneak in. Calcium and magnesium, right? Calcium magnesium needs the gradient created by sodium potassium chloride, which means when you give a, that's why when we talk about loop diuretics, what does loop diuretics do? They block the triple transporter. But if they block the triple transporter, there's no more gradient. What happens to calcium and magnesium? that won't be reabsorbed either. And that's why we say loops lose everything, right? Because if you block sodium potassium chloride, you're indirectly blocking calcium magnesium also. So here, that's it, pretty straightforward. This is the only channel that works there. And then you block that by loop diuretics. What are loop diuretics? Furosemide. What else? Bumetanide, torsemide, and which one? Ethacrynic acid. Why do we need to know this? Because all three contain sulfur. So if you have a sulfur allergy, then you can't use any of those. You have to use ethacrynic acid as a diuretic. Okay. Number one indication for loop diuretics: heart failure and pulmonary edema. The best drug for pulmonary edema is loop diuretics. We also used in hypertension, treatment for hypertension. Okay. So in the loop, again, that's it. The normal mechanism, normal physio, medications. As far as diseases go, path go, there's one disease that affects the loop, which is Bartter syndrome. Barter's. I think it's Barter's, yeah. Bartter syndrome. So Bartter syndrome inhibits sodium potassium chloride transport, triple transporter. That's it. So it works like a loop diuretic in a way. You see the same net effects of electrolytes. All electrolytes are low. Low sodium, low potassium, low chloride, low calcium, low magnesium. So whether you're using loop diuretics or you have Bartter syndrome, you see the same electrolyte picture. Okay. So that's the only pathology there, and the physio and the medications. Good. I'm going a little faster, but
Excuse me, I have a question, sir.
yes.
You said that when the loop blocks the triple transporters, that the calcium rush into the cell, right?
When you block it, calcium and magnesium also cannot come into the cell. So basically, when you block the sodium potassium chloride transporter, you're blocking calcium and magnesium also. All five are blocked. Okay. In the DCT, and not too much. What happens in DCT? They have a sodium. What else is reabsorbed? Not much of water. Chloride. Sodium and chloride. Was the main transporter here, right? Sodium and chloride. It's a symporter, so they go together. Sodium and chloride. And yes, somebody said, I heard something. Calcium, because what else is here? You have a PTH receptor. So parathyroid hormone works here to reabsorb calcium. So parathyroid hormone reabsorbs calcium in the DCT in exchange for phosphorus. Where does that go? Was phosphorus secreted? PCT. It's a interesting mechanism where you're pulling one from the DCT, but you're sending something out in a different part of the nephron. Leslie.
PTH do it through vitamin D activation, right?
That's separate. We are not talking about vitamin D here. We are talking about pure PTH effects. How does PTH work on reabsorbing calcium by itself? It's through the DCT.
Okay.
Yeah.
So,
but PTH also activates vitamin D, but that's somewhere else.
so you like PTH alone causes calcium reabsorption of the kidney.
Correct. In the DCT.
Okay, thanks.
What drugs are working here? Thiazides, which are hydrochlorothiazide, chlorphalidone, indahamide, metolazone. These are all your thiazide diuretics. And side effects of thiazide, it's important, right? Because what does it cause? So hyperglycemia, which means you can't use thiazide in diabetics. Hyperlipidemia, don't use thiazide in high cholesterol. Hyperuricemia, don't use thiazides in patients with gout. And then calcemia, hypercalcemia. Okay, that's a side effects. Uses, where do we use thiazides? Number one is for hypertension. Where else? We just talked about one condition where we use thiazides, right? RTA2. Diabetes insipidus, nephrogenic diabetes insipidus. Kidney stones, excellent. Hypercalciuria kidney stones. And osteoporosis, why? Yes, can pull calcium from the urine. Okay, so those are the most common indications. RTA type 2, hypertension, nephrogenic DI, hypercalciuric kidney stones, osteoporosis, not first line, but yeah, we can use it as a because of its effect, but not number one. And that's in the DCT. Okay, and then the only path in the DCT is the other syndrome, which is Gittleman's. Okay, which blocks sodium chloride. So it's like thiazides. Just like Barter's was like furosemide, Gittleman's is like thiazides because it's blocking sodium chloride transfer. So they will have hyponatremia, hypochloremia, all that kind of stuff. That's the DCT. Cool. Questions? And the last part.
Excuse me, what's the last medication you have on this? You have your uremia for side effects, and what again?
Calcemia, hypercalcemia, hyperuricemia. These are side effects of thiazide diuretics.
Okay.
Okay.
So you say in Gateman that there's going to be hyperkalemia and what again? In Gateman,
Yeah, Gittleman, you have hyponatremia because it's blocking sodium reabsorption. Hypochloremia.
okay.
In the collecting duct, there are two cells. You have principal cells and alpha intercalated cells. Okay. On the luminal side, we have what we call the epithelial sodium channels, ENaC channels. That's for sodium reabsorption. Here too, on the basolateral side, you have ATPase. Okay. But these ENaC channels, what activates these ENaC channels? What hormone? Not ADH, the other one. Aldosterone. This is where aldosterone works. In the principal cell, okay? It activates the ENaC channel, so reabsorbs sodium. Water follows. And then what's excreted is, or secreted is, so potassium. So sodium in exchange for potassium. Medications that work here. You have aldosterone antagonists. What are those? Spironolactone and eplerenone. What do we use spironolactone? It decreases mortality in what? It's an important drug. Good cardio, right? Heart failure. It decreases mortality in heart failure. We also talked about spironolactone earlier in the day. We use it in hirsutism. Okay. So spironolactone and eplerenone, they work by inhibiting aldosterone, which then turns off your ENaC channel. There are two drugs that work directly on the ENaC channels to inhibit it, not through aldosterone. Directly turns off the ENaC channels. What are those drugs? Not eplerenone, amiloride and triamterene. So all four are K-sparing or potassium-sparing diuretics because they hold on to potassium by blocking the ENaC channel. So sodium is not reabsorbed, potassium is not secreted. You hold on to potassium. That's why they are K-sparing, all four, but by different mechanism. Amiloride and triamterene works on the ENaC channel, whereas spironolactone and eplerenone antagonizes aldosterone. Okay. Now, there's one pathology here where rather inhibiting this ENaC channel remains activated all the time by itself. And that's called the Little syndrome. So Little syndrome, the ENaC channels remain activated. So basically what that means is that they're going to be hypernatremic, hypertensive, hypokalemic, right? Because you're reabsorbing excess sodium. So we know what works on those channels medication-wise. What's the treatment of Little syndrome? Amiloride and triamterene, exactly, right? So Little syndrome is activation of the ENaC channel, and we know that ENaC channel is blocked by amiloride and triamterene. So if you want to treat Little syndrome, you put them on amiloride and triamterene.
So please, this Renal syndrome will have hypokalemia, hypo what?
Hypokalemia, hypernatremia. Pathology here. RTA type 4. Okay. RTA type 4, what group of patients do you see RTA type 4 in? Diabetics. Because diabetes causes vasculitis, which affects the JG cell. So if JG cell is ischemic, what are you not making? Renin. Not making renin, what downstream, what else are you not making now? Aldosterone. So which means you have hypoaldosteronism. So anything that can cause hypoaldosteronism can lead to RTA type 4. So is the only RTA among the three that has increased potassium. Because if your aldosterone is not working, what are you not getting rid of? Potassium. So they have hyperkalemia. Right? Hyperkalemia, their serum pH is also less than 7.4. Metabolic or normal anion gap metabolic acidosis. Another example, right? So here to want to correct, the problem is aldosterone, right? Not enough aldosterone being made. JG cell infarct. So what do we do for treatment? We can give them aldosterone, but what's a synthetic form of aldosterone? Which one? Fludrocortisone, right? Fludrocortisone. However, they also have hyperkalemia. Potassium high, what's the problem? Arrhythmias. We don't want the potassium high. So how do we treat hyperkalemia here? Furosemide, because loops lose everything. It's not that bad to go to insulin and all that. So usually furosemide is sufficient to get rid of that excess potassium, right? Fludrocortisone and furosemide would be the treatment option. So that's RTA type 4. JG cell problem, aldosterone problem. Type 2 was a bicarbonate problem, okay? Right? So that was a principal cell. And the last cell is the alpha intercalated cell, okay? In the alpha intercalated cell, the main function there is that it's called a potassium or hydrogen potassium ATPase. So here you are actually reabsorbing potassium and kicking out hydrogen. And then you are reabsorbing bicarb a little bit here because you are making H2CO3, which splits into bicarb and hydrogen. Again, carbonic anhydrase works here. Okay. So that also will kick out some hydrogen. So that's why This is the part where most of the hydrogen is secreted. And that's why this part is the most acidic. And that's why uric acid stones precipitate here. And that's also why urine is very acidic. When it comes out, it's acidic. It's been acidified. All right. That's RTA. So here also there's a pathology, which is RTA type 1. So type 1, the problem is your hydrogen potassium ATPase not working. Okay, hydrogen potassium ATP is not working. So you keep hydrogens and get rid of potassium. You have low pH and low potassium. But here, because the problem is in the intercalated cell and the PCT is working fine, what can you give them for treatment for bringing them back to alkalosis? Give them bicarb. Here you can give bicarb because the PCT will absorb that bicarb. PCT is fine. The problem is in the collecting duct. PCT will reabsorb the bicarb. You also have to give them some potassium because they are hypokalemic. Okay, so those are the 3 RTAs. There is RTA type 3 also, which is a combination of 2 and 4, but there's no real electrolyte abnormality there, so we don't really worry about it. No questions on it. So 1, 2, and 4. So remember where each one of them is, what the electrolyte picture is at, and what it used for treatment. Okay. So just a summary of all that we just talked about. Type 1, type 2, carbonic anhydrase is a problem, and type 4 is renin and aldosterone. Cool. All right. So now we have 10 minutes to finish nephritic and nephrotic. All right. 5 minutes nephritic, 5 minutes nephrotic. But the good part here is nephritic and nephrotic, what is it based on? Clues. So which means you know the clue, you know the answer. So can we do it in 5 minutes? Yes, we can. Because what do we need to know? What I'm going to point out is just the clue. This is what you're going to look for. This is what you're going to know. But proteinuria, right? So when there is proteins in the urine, we classify them as benign or malignant. Benign, we already talked about, right? Some proteins you can see under normal situations, not a big deal. Malignant means you have more proteins, you have to quantify it. And if it is less than 3.5 grams in 24 hours, proteinuria, we classify it as nephritic. And if it's greater than 3.5 grams in 24 hours, we call it nephrotic. So that's the very first thing to look at to classify nephritic versus nephrotic. Mild proteinuria versus significant proteinuria. So now, nephrotic, right? More proteins are lost, which means what's the first protein that's lost? Albumin. They are going to have low albumin. What are other proteins that can also be lost? Immunoglobulins, right? Which means now what are they at a higher risk for? Infection. What kind of infection? Bacteria, viruses, fungus. Bacterial infections, immunoglobulins, bacterial infections, right? Which also means they're losing protein. We talked about this, oncotic pressure. What happens to that? It decreases. We also talked about this. So do they have edema? They do have edema. But now, if you're losing all this protein, your body is going to try, hey, I don't have protein. I'm going to make some protein. So who makes proteins? The liver. But when it makes proteins, it's not selectively making albumin. It's going to make everything. So that's why you have hyperlipidemia, hypercholesterolemia. And it also makes clotting factors. 2 reasons. One, it puts you at a hypercoagulable state in nephrotic syndrome. 1, because it makes clotting factors. Number 2, when nephrotic syndrome, what's the pathology? What is it due to? You lose charge of the basement membrane, right? When you look at when you look at filtration, when we talk about filtration, there are 3 layers the blood has to go through, okay? Let's say you have your endothelial cells here. These endothelial cells have fenestrations, okay? So first layer is the fenestrations between the endothelial cells. That's 1. So you have to go through the endothelial cells. The second layer it has to go through is the basement membrane, okay? And then in the glomerulus, what are these? Podocytes. Those are also epithelial cells. You have podocytes. And these podocytes also have gaps in between. And that's how you get filtration done. Okay, so let's go to 3 layers: the endothelial cell, base membrane, and podocytes. So what maintains the integrity of the base membrane normally? Base membrane is negatively charged, so it repels protein. What happens in nephrotic syndrome? It loses the negative charge because of damage, and therefore it loses protein. And what are the one of the other proteins it also loses along with it is antithrombin 3. Okay, antithrombin, so it prevents clot, right? So when you lose antithrombin, what are you at a higher risk for now? Clotting. So 2 reasons why you're hypercoagulable: because you lose antithrombin and you also make more clotting factors. And then you see fatty calves. That's a pathology in nephrotic syndrome. It's common to all nephrotic syndromes. Agreed? Now, what are the clues for each of this? Most common in children is minimal change disease. Okay, but it's got a pretty good prognosis. With steroids, more than 90% cure rate. Usually what sets it off? A URI. So if you see proteinuria, small kid, had an upper respiratory tract infection, now presents with edema, significant edema, and a sarca almost, right? You have facial edema as compared to nephrotic syndrome where the edema is not that much. You have minimal change disease. Okay. And what do you see on electron microscopy? Now, the only other clue for minimal change, or very significant clue, is this is the only, whether it's nephritic or nephrotic syndrome, which is normal on light microscopy. So that's a very strong clue, because there is nothing else that is normal. Everything else will have some kind of abnormality. The only nephritic or nephrotic syndrome, which is normal on light microscopy, but what do you see on electron microscopy? Fusion of podocytes. Okay, so they lose that integrity. That's why all these proteins leak. Good. Minimal change disease. What are the clues there? Kid, 2 years after URI, normal light microscopy, fusion of podocytes on electron microscopy. 4 things. Membranous. Membranous means there's something on the membrane, right? And the clue here is these deposits are subepithelial. So that's one clue. Subepithelial deposits on the base membrane. It could be drugs, it could be amyloid, it could be toxin, it doesn't matter. Immune complex is something deposited. And what does that deposit look like? What's the pattern? Spike and dome appearance. Subepithelial deposit, spike and dome pattern, membranous nephropathy. Okay, so those are the clues for membranous, adult. Spike and dome, subepithelial. FSGN, focal segmental glomerulonephritis. So this is a vasculitis. Generally, glomerulonephritis is vasculitis, but this is the only vasculitis which is a nephrotic syndrome. Where do we see this in? HIV patients, IV drug abusers, they have hypertension, correct? And it's vasculitis also. So what you're going to see is focal segmental. So just like the name indicates, some areas or of some segments of the glomerulus are affected, right? Here also, other term usually is hyalinosis. That's the other clue. Because it's a vasculitis, when the vessels get thick and they heal and they get scarred, then there's hyalinization. So hyalinosis, hypertension, HIV or IV drug abusers, adult male vasculitis, that's focal segmental glomerulonephritis. Okay, that's 3. So a mnemonic for nephrotic is M&M, fan. Minimal change disease, membranous, focal segmental, and what are the last 2? Myeloidosis and nodular sclerosis. Okay, so nodular sclerosis is seen in diabetics. So that's a complication in diabetic. Kimmelstein-Wilson nodules or nodular glomerulosclerosis, meaning you will see, within the glomerulus, you have area that's fibrosed or sclerosed, and you see little nodules in different glomeruli. Mohammed, question?
Yes, is this the one with the tram track appearance?
No, that's not this one. That's coming up.
Okay.
Okay. Nodular sclerosis is diabetes. Amyloid, what's a clue for amyloid? Protein deposition, but what's the other one? The dye and the Congo road, apple green birefringent. That's it, right? For amyloid. And then diabetes, nodular sclerosis, FSGN. So these are the nephrotic syndromes and 2 or 3 things. That's all pretty much you have to remember. 2 or 3 things for identifying each of this. Okay, so smaller list. But the nephritic is a larger list. So I've actually put that into like a table. So nephritic is all vasculitis, which means you're going to have hematuria, which also means you're going to have RBC casts. So RBC casts, hematuria, hypertension in the sense of a vasculitis, nephritic syndrome. Okay, so what are the other ones? What else do you see? Because it's vasculitis, as blood cells go through the inflamed vessel, what's going to happen? It's going to break down. So what are you going to see? Schistocytes, and then casts and hematuria along with hypertension with proteinuria that's less than 3.5 grams per 24 hours. So that's the other clue, right? Once you know it's nephritic, then you're going to go to the list and identify the clues for each. So let's look at what the clues are for each quickly. Okay. PSGN, most common. What are the clues? Post-up, yes. No, it's not anywhere. It's just here. It's picture time. All right. So just to make it easier, we can go through the clues here. So post-streptococcal glomerulonephritis. When does it appear? Time frame wise. Almost close to 4 weeks after the infection, because there is one which comes within 2 weeks of an infection. Which one's that? IgA. So that's why the timing is important. Within 2 weeks of an upper respiratory infections or during an upper respiratory infection, it'll be IgA. If it's more than 2 weeks after the infection, strep throat, it's PSGN. Okay. What type of hypersensitivity is PSGN? Because what's deposited? It's type 3 because it's immune complex deposition. It can follow either a skin infection or a throat infection. So that's why impetigo caused by, again, strep or throat. Now, next clue is complement. So there are 3 nephritic syndromes with decreased complement. So anytime you see decreased complement, immediately there's only 3 out of the list. This is the first one, so pay attention to that. Decreased complement. Okay. And this is also the second one with subepithelial deposits. So what was the other one with subepithelial deposits? Membranous, but that's a nephrotic syndrome. So subepithelial deposits in nephrotic is membranous. Subepithelial deposits in nephritic is PSGN. Okay. And how does these deposits appear? Lumpy, bumpy. So kind of like irregular basement membrane. And if the question is, what is deposited? What's the answer? Immune complexes. What is the immune complex made of? What is it made of? C3, IgG, IgM, right? Mainly IgG. So IgG, IgM, C3. That's what you're going to look for. So that's PSGN, post-streptococcal. What's a clue for good pastures? What kind of hypersensitivity would this be? Type 2. Why? It's an antibody. What's the antibody? Anti-glomerular basement membrane antibody against type 4, because what collagen is used for basement membrane? Type 4. So it's an antibody against type 4 collagen. What do they present with? Hemoptysis, hematuria. So when you have lung involvement and kidney involvement, you think about good pastures, right? Hematuria and hemoptysis. On immunofluorescence, how are these deposits seen? The term you're looking for is linear. Okay. Lumpy, bumpy is which one? PSGN. Linear is good pastures. Okay, so the clues for good pastures, type 2 hypersensitivity, anti-globular or type 4 collagen antibody, hemoptysis hematuria, linear deposits. Okay. Third, Wagner's, but no longer called Wagner's. What's it called now? Granulomatosis with polyangiitis. So what do you have? You have polyangiitis, which is vasculitis, and then you also see granulomas. The name says it all. What's the antibody? C-ANCA, right? C-ANCA. So what do you see? Granulomatous vasculitis. These patients also have lung and kidney. However, to differentiate from good pastures, what other system is also involved in Wagner's? Sinuses. Yeah, nose or sinuses. So saddle nose or sinusitis. So lung and kidney, good pastures. Lung, kidney, and sinuses, Wagner's or granulomatosis is polyangiitis. And this is also, you see, crescents, epithelial crescents, crescenteric glomerulonephritis is the other name. Now, both of these, good pastures and Wagner's, is classified under RPGN or rapidly progressive glomerulonephritis. All it means is that if you have good pastures or if you have Wagner's, it can quickly progress towards renal failure. So rapidly progressive. The next one, MPGN, membranoproliferative. What are the clues here? MPGN type 2 has antibodies against C3 nephritic factor. So it's a complement system issue. This is the second one with decreased complement. Remember, decreased complement. The first one was PSGN. Second one with decreased complement. And the other clue is tram track subendothelial deposits. Okay, this is the one with tram track appearance. So the clues here: decreased complement, antibodies against C3 convertase, tram track appearance of these deposits. Yes.
Is there any EM findings?
EM findings, there's deposits. You will see deposits. But the best way to see it is immunofluorescence. Yeah, you will still see deposits. Yeah, for sure. So all of them have light microscopy, EM, and IF findings. But I'm pointing out the one that you have to remember, or what's going to be seen in a question. IgA. Again, vasculitis within 2 weeks, an upper respiratory infection, or even a gastroenteritis. It could be either a GI infection or a respiratory infection. So what do you see? Hematuria. But as the name indicates, what is deposited in IgA nephropathy? IgA deposits. That's it, straightforward. But the main clue for IgA is usually the question is to differentiate between IgA and PSGN. And for that, the main clue there is the time. So within 2 weeks of an upper respiratory infections, IgA. After 2 weeks, think PSGN. Okay, so that's the main difference between the two that appears after an infection. Okay, so those are the two clues for that. After 2 weeks, correct. After 2 weeks of recovery. And then the last three, Alpos. It's against type 4 collagen again, but here, multiple organ system involvement. So these are the people who can't, not climb, they can still climb. They can't hear a bee, correct. Can see, can't pee, can't see, can't hear a bee, but they can climb. So can't pee, can't see, can't climb a tree is what? Writer's arthritis, right. All right, so this is renal issues, hearing issues, vision issues. And as far as electron microscopy goes, it's a splitting. That's it, only thing to remember. But here the main thing is it's also X-linked dominant because you'll have a family history. So think about that too. They talk about someone else in the family having deafness or something like that. So that's a clue there. X-linked dominant and the three systems affected: eyes, ears, and the kidney. Okay. Church-Strauss. Again, no more called Church-Strauss. Eosinophilic granulomatosis with polyangiitis. So it tells you everything you need to know in the name itself. So more than 2 weeks is PSGN. Less than 2 weeks, IgA. Okay. PSGN is decreased C3. IgA's complement is not affected. That'll be normal. So that'll be the other difference. normal. There are only three conditions with decreased complement. One is PSGN, other one is MPGN so far. Yeah, third one is coming up. Okay, so this one is eosinophilic granulomatosis polyangiitis. Everything you need to know is in the name itself. There's eosinophilia, there's granulomas, there's vasculitis. Okay, so eosinophils, increase IgE, associated with an allergy or an asthma. A person who has allergies or person who has asthma, they develop glomerulonephritis. Think this one. And the antibody here is P-ANCA. Okay, and on live microscopy, nothing really significant. It's just what you call necrosis. That's it. So mostly the clue here will be this. And the last one, which could be nephritic or nephrotic, is SLE. This is a third one with decreased complement. Okay. And this is a diffuse proliferative glomerulonephritis, meaning it affects the entire kidney. Microscopy, what's the clue? Two clues: subendothelial deposits and capillary wire looping. So that's how the glomerular capillary looks like. Because of the vasculitis, it looks like electrical wire. So that's called wire looping and subendothelial. There were two subepithelials. What were they? Membranous and PSGN. There were two subendothelials. What were they? SLE and PGN. It's okay. You can go back and review. I'm just yelling it out. And there were three with decreased complement. One was PSGN. Number two, MPGN. Number three, SLE. SLE. There's one with increased eosinophils. Which one? Chuck Straws. There's one with tram tracking. Which one? MPGN.
MMP.
Which one's before 2 weeks? Which one's after 2 weeks? PSGN.
Yes.
Which one has can't see, can't hear, can't hear a bee? Afterwards. There you go. You're good with nephrotic syndrome. Okay. All right. Okay, so that's it. So
Please, can I see the last slide, please? The last slide.
sure. No Chuck Straws, no Wegners. So both those names have been discontinued.
Okay.
So that you can all get your tutoring sessions. We have not gone beyond 10 minutes. So get your sessions and don't say I held you here more than 15 minutes to get it postponed. All right. All right. So that's it for the day. Have a good evening. I think I have somebody here too. Yes.
Just had a quick question.
Yeah.
Pre-renal failure.
Ah.
You said that the RAS gets activated and efferent constriction happens.
Correct.
When the GFR goes up, why does the creatinine go down?
It doesn't go down in pre-renal, right?
Yes.
Creatinine goes down because when the RAS get activated and the efferent is constricted, what happens to GFR?
Increase.
So if GFR increases, can you get rid of creatinine?
Isn't it going? Oh, GFR is increased. Okay.
Right. So creatinine it goes back down to normal.
Okay. Thank you.
Now you can. It's all done.